So good morning and a very warm welcome to one and all present here. We are thrilled to have everyone of you gathered for today's event called Cardiobase 2025. So this is a master class which is covering from the basics of cardiology to the recent advancements that are present till today. So, the opening remarks from the course directors, I welcome Dr. Muruganathan sir, Dr. Sengot Velu to give the opening remarks for today's occasion.
Good morning. Good morning. Yeah, I'm very happy. We are very happy to welcome all of you. This is our third year Cardiobase we are doing. On behalf of the course directors, Dr. Sengot Velu, Dr. Chenniyappan, we are very, very happy and delighted to welcome all of you. You know, the Cardiobase was started with the idea that every physician, every practitioner should learn the basics of cardiology, also updates in cardiology. Because if somebody comes with aortic stenosis, those days we think only aortic stenosis means surgery, and many people, they don't know when they get aortic stenosis and they think only medical treatment is available. We thought, every physician, every practitioner should have basic knowledge about cardiology as a subject, because many times that knowledge can save a patient. Somebody has got a chest pain, you must know what is the chest pain, when to refer to a specialist, when to thrombolize, when to do angio. So these are the small things which will save many lives. That's why we thought we'll have a Cardiobase from basics to updates. So today we are going to have an excellent scientific feast. Before that, we'll have a formal inauguration, and I'll have request my course director, Dr. Sengot Velu, who is one of the internationally known interventional specialists, who is also specializing in latest updates. Recently also he went and had a training in the updates in the valve replacement therapy. So I'll request him to speak, then we'll have a formal inauguration by lighting the lamp.
Good morning all of you. A warm welcome all of you to the Cardiobase 2025. We're extremely happy to announce this edition where we have structured the course to all levels of cardiology, from simple to advanced levels, including interventional cardiology. So please feel free to interact during the session, and I'm sure this will be a great scientific treat today. And I would like to thank my well-wisher and my guru, Dr. Muruganathan, who has been a great support of strength to me, and Dr. Bhanumati and Muruganathan and Dr. Purnima for all their efforts to bringing this to reality. Thank you very much.
Welcome, lighting lamp.
Okay. Now I welcome Dr. Jayashree, Dr. Bhanumati ma'am and Dr. Purnima ma'am for the light lamping.
We are also thankful for the support given by Johnny, IPCA and other team for audio, visual and all other support. So we really thank him and we welcome them also.
Actually, I would mention a special mention to IPCA, because without their support we would definitely not have this meeting, and they've been consistently supporting us, and they're the main sponsors for this meeting today. And thank you the IPCA team for this sponsor. Thank you.
Come. The prayer song இருக்கா, the lighting lamp song. தம்பி உங்களுக்கு song இருக்கா? லைட் பண்ணும்போது இந்த சாங் போடுங்க.
அவங்க ஸ்டெப்ஸ்.
We want 2 more ladies volunteers to come and lighting the lamp, please. I see the sisters. Please. Sachin, can you help 2 more ladies to come?
कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा आकाशस्याधिपो विष्णुः अग्निश्चैव महेश्वरी वायो सूर्यक्षितेशः जीवनस्य गणाधिपः आकाशस्याधिपो विष्णुः अग्निश्चैव महेश्वरी वायो सूर्यक्षितेशः जीवनस्य गणाधिपः
Thank you, sir. So the program coordinators for today will be myself. I am Dr. Dakshin. I am doing MD General Medicine in Mahatma Gandhi.
Please go.
And Dr. Shanmugam, Professor and HOD, Department of Physiology in Sri Venkateshwara Medical College, and Dr. Sharad Babu.
One more good news. The same program is live telecasted in more than 13 places across the country. In Madurai, Erode, Salem, Visakhapatnam, Rajahmundry, Kannur. So those people who are there also, we have great pleasure in welcoming them, welcoming you all for the program. Please send your questions as and when you require any doubt. If you have any doubts, send it by your email. We will answer from here. I request the chairpersons of the respective centers from Coimbatore, Madurai, Salem, etc. to collect the questions and send it to us. So this program is a live program. Not only these 12 and 15 centers, also anybody can watch this program by clicking the link. So we have given the link also. So those who are not there in any center, from other places also, even small village, they can see this live program by clicking the link.
So the first topic for today will be occlusion myocardial infarction, a paradigm shift in acute coronary syndrome. Speaker will be Dr. M. Chenniyappan sir, and the event will be chaired by Dr. Ramesh Lalgudi, who is a CMO in Suham Hospital, Trichy. I welcome you, sir.
Base program. I thank Dr. Muruganathan and Dr. Senguttuvel for this wonderful opportunity. At the same time, I like to apologize for not being there personally due to unavoidable personal commitments. So what we are going to today discuss today is going to be a new concept on the acute coronary syndrome. So what I am going to discuss is called an occlusion myocardial infarction, paradigm shift in the ECG diagnosis and the management of acute coronary syndrome. What do we mean by paradigm? Paradigm means it's a way of looking at something. So we have been looking at acute coronary syndrome in a particular way. and that particular way of looking at acute coronary syndrome is likely to change. So traditionally, we have been classifying the acute coronary syndrome as ST elevation ACS and non-ST elevation ACS. We put them into with those people with the acute coronary syndrome in these two strict compartments. The ST elevation ACS is due to the rupture of the plaque, resulting in the acute total occlusion of a coronary artery with a red thrombus, resulting in a ST elevation. So that's why it's called ST elevation ACS. Here there is an active infarction where the muscle is dying every minute. That's why we immediately rush to open the artery with a primary PCI or a thrombolysis. Whereas the non-ST elevation ACS is because of most often due to erosion of the plaque, which results in a thrombus which is rich in platelets, and it is going to produce a critical occlusion, which means you have viable myocardium supplied by critically narrowed artery. And we think the active infarction is not happening here in such a way like an ST elevation MI, so that we don't thrombolize here, we take things little easy here and giving some heparins, antiplatelet and statins, and depending upon the risk, we send him for a coronary angiogram and intervention. So this is our approach for so many decades. Whether this approach is right or wrong, whether we have to change this approach is the scope of my talk. So how will you diagnose ST elevation ACS in electrocardiogram is by this definition. So except in V2, V3, in all segments it is 1 mm ST elevation from the J point, and in V2, V3 it changes according to the sex and the age of the patient, and the ST elevation should be there in 2 consecutive leads supplied by the same coronary artery, and posterior myocardial infarction can be suspected by reciprocal ST depression from V1 to V4, and of course in the presence of left-bone branch block we have to apply a Cardiobase criteria to know whether there is a ST elevation ACS. In a non-ST elevation ACS, ECG criteria will be ST segment depression can either be upsloping, a slowly upsloping, or downsloping, or horizontal ST segment depression, and the depression should be equal or more than 0.5 mm at J point in 2 contiguous leads. So when you apply 1 mm criteria to diagnose non-ST elevation ACS, it becomes more specific and also conveys a bad prognosis. Whereas the T wave also can constitute non-ST elevation MI. It should be at least 1 mm in deep, so deep T wave inversion. Once again should be present in 2 contiguous leads, and that lead should have a dominant R wave. For example, you have a deep T wave inversion, and that lead should demonstrate a tall R wave, and the RS ratio should be more than 1. Then also it may be with the clinical context. In the clinical context, it may become an acute coronary syndrome of non-ST elevation ACS. But please remember, diseases don't read textbooks. That means ST elevation ACS will not come to my lecture and see my first slide and exactly present as ST elevation for an acute total occlusion or with an active infarction. It has been shown even in the presence of significant persistent occlusion by proven TIMI zero flow, that is no flow, the STEMI ECG criteria often do not develop. Some of the studies go to the extent of 50% of the ECGs with a total occlusion may not show a typical ST elevation described in the definition of ST elevation ACS. So that's why what is needed is a more flexible approach, recognizing the evolving nature of ECG patterns in acute coronary syndrome will improve not only the diagnostic accuracy, but more importantly the timely reperfusion therapy in those people who do not have a ST elevation ECG criteria but have a total occlusion and also an active infarction, and that is called occlusion myocardial infarction. So here we must understand ECG can be a deceiver. So what is occlusion myocardial infarction? The occlusion myocardial infarction is defined as a branch of acute coronary syndrome algorithm representing near or total occlusion. That's what very important, with insufficient collateral circulation, and what is very important is an active infarction. Just like ST elevation ACS, the muscle is dying every minute in occlusion myocardial infarction. Whereas non-occlusion myocardial infarction is maybe due to a critical occlusion or not total occlusion, and some collateral circulation is still present, so that the active infarction may not be happening in although it is ACS, it is non-occlusive myocardial infarction. So the future classification may be in a number of years not as ST elevation ACS or non-ST elevation ACS, it may be an occlusion myocardial infarction versus non-occlusion myocardial infarction. So now what we are going to see is what are the electrocardiographic patterns of acute myocardial infarction patterns. So these are the ECG patterns which is going to be STEMI equivalence. That means In these type of ECG patterns, you have a critical or near total occlusion. What is very important is either the active infarction is already happening or the active infarction is going to come soon and very critical, and the patient is at high risk of having an active infarction soon. So that's called the OMI patterns or ECG patterns. We see one by one. That's why we need a change of approach. So the ECG patterns which are likely to show an acute occlusion myocardial infarction is like STEMI. Either you have an active infarction going on or this patient is at very high risk of developing active infarction very soon. So that changes your approach to these patients. You cannot no longer consider them as non-ST elevation ACS and go easy with heparins and antiplatelets and only going for intervention regarding the risk, according to the risk stratification. The first pattern we are going to see is a Valence syndrome. It is a well-known syndrome where it is likely to be aborted STEMI. So Valence syndrome is characterized by biphasic T wave with a ST elevation, slight ST elevation, which is called pattern A, or symmetrical deep denervation, which is called pattern B. And when the patient comes with this ECG pattern, the patient will not have, or patient may not have chest pain. The patient would have chest pain yesterday, and today he would have come with a normal or some sort of normal pattern or a normal presentation with no chest pain. But the ECG will show these either of these patterns, and it will represent critical proximal stenosis of left descending artery, left antidescending artery. So it is what is happening here in a Valence syndrome is patient had an ST elevation or acute total occlusion 1 or 2 days back, and there was a spontaneous reperfusion. And what pattern you are seeing as a T wave inversion or a coving with a T wave inversion is a reperfusion ECG pattern. So it is a reperfused ECG pattern. So this is what happened. So patient have had chest pain 1 or 2 days back with a ST elevation. So then what happens is the patient usually go for evolution of myocardial infarction in a normal sequence. But if a spontaneous reperfusion happens, what happens is the patient will come next day or 2 days after with a reperfusion pattern like a coving with a T wave inversion or a symmetrical T wave inversion. Pattern A or B as a Valence syndrome. But please remember, although this patient had a spontaneous reperfusion, still the patient may harbor a significant proximal LAD lesion, and that's why this patient is very high risk of having a huge STEMI or an active infarction in the near future. That's why these patients are immediately sent to coronary angiogram and suitable revascularization. So Valence syndrome pattern, any artery which has got a Valence syndrome, and the Valence syndrome is primarily put for proximal LAD, especially in V2, V3, V4. If you have deep T wave inversion, it indicates a critical proximal LAD. This patient should go for a immediate coronary angiogram and probably suitable revascularization. So pattern A is the early pattern where there is a slight coving of the ST segment, the T wave inversion, and pattern B is a later pattern with a symmetrical T wave inversion with a horizontal or a settled ST segment. So second pattern is a hyperacute T waves. So the hyperacute T waves are defined as the T wave which has got increase in width, increase in height, and there is no gentle concavity which actually defines the normal T wave, and there is even the convexity upwards of the T wave upslope and increased QT interval. So these are the definition of the a tall T wave or a T wave which represents an acute occlusion myocardial infarction. And this tall or hyperacute T wave is the earliest ECG feature, earliest, not only earliest, but also specific ECG feature of occlusion, many of the occlusion myocardial infarction, and can be recognized only by trained and qualified ECG readers. So in the absence of specific guidelines of defining hyperacute T waves, there is some formula where the total area under the curve of preceding QRS complex is more relevant than an isolated T wave amplitude. So you can compare with the previous QRS complex. So you can see that here, this normal T wave, you can see that there is a gentle concavity upwards, and T wave is usually asymmetrical. That is, the ascending lobe will be different from the descending lobe. Whereas a hyperacute T wave is a broad and wide T wave, and the T wave is tall, it is broad, and there is absence of this initial concavity. Sometimes even the slope of convexity may be there, and most importantly, it is tall and wide, and the area occupied by the T wave will be much more than the area occupied by the QRS complex. So this is a very important pattern of acute occlusion myocardial infarction. You can see in ECG here, the patient comes with chest pain and there is no significant ST elevation. You tend to think the ECG can be still normal, but you can see a small Q wave and also very broad T wave. And as I told you, you can look at the normal T wave with a gentle concavity there that is absolutely absent here. The tall, broad T wave with a broad base, and it may represent a critical occlusion of, once again, a proximal left-handed descending artery. So then we have a D Winters pattern, which is a well-known pattern, where the patient can have an upsloping ST segment, upward sloping ST segment elevation of 1 to 3 millimeter, and then the patient can have, once again, the T wave I described, tall positive symmetrical T wave. In the previous example, you had only the tall positive symmetrical T wave, but in D Winters, there is association of an upsloping ST segment depression. So there is also some elevation in lead AVR. So D Winter T waves are considered anterior STEMI equivalent, indicative of, once again, proximal LAD descending artery occlusion myocardial infarction and necessitating emergency intervention. So here you can see the pattern here, an upsloping ST segment depression of 1 to 3 millimeter, followed by the T wave I described, a tall T wave, broad T wave with a loss of concavity in the upslope of the T wave. So these are ECG of a patient with a D Winters syndrome. You can see the upsloping ST segment depression, tall and symmetrical T wave. Once again, it is a STEMI equivalent. So you can see that tall T wave with upsloping depression. This patient, once again, is an occlusion myocardial infarction. You must treat these patients as an ST segment elevation MI, and the patient should immediately go for coronary angiogram and suitable revascularization. Then we have pattern called Aslanger pattern. Aslanger pattern is emerged as a distinctive ECG signature. Also with the acute inferior occlusion myocardial infarction, most often it is due to right coronary artery or left circumflex artery. But in addition to that, these patients may have a multivessel disease. In contrast to classical acute inferior myocardial infarction, here the ST elevation is only in lead 3. And there is absence of ST segment elevation in lead 2 and AVF. So in addition to that, the patient may have a ST segment depression in the lateral leads. So this is a ST elevation only in L3, then the ST segment depression in V5 and V6, and ST elevation in V1 will be more than the ST in V2. So these are 3 criteria to diagnose Aslanger pattern. So you can see that here in this ECG patient is coming with chest pain. We have ST elevation only in lead 3, and we have no ST elevation in lead 2 and AVF, but we have ST elevation in V1, and the V1 ST is more than V2, and we have anterolateral ST segment depression. So this combination of ECG findings tells us these patients once again have a critical occlusion or a total occlusion of either LCX or RC occlusion with a multivessel disease, that is Aslanger pattern. D Winter pattern and hyperacute T waves tells us that the D Winter pattern tells us it's a proximal LAD occlusion V1 to V4, whereas hyperacute T waves in any leads will show that particular artery acute or critical or total occlusion with an active myocardial infarction. So all the 3 patterns are maybe indicating to active myocardial infarction and acute occlusion myocardial infarction patterns. Then we come to the South African flag sign. So South Africa is the World Test Championship winners at this time. So it is interesting to talk about South African flag sign. So South African flag sign is a very peculiar ECG sign which will present as acute bilateral myocardial infarction with the ST elevation lead 1 and AVL. And also they will have a ST elevation V2, and there will be reciprocal ST segment depression in L2, L3 AVF, especially in L3. So L1 AVL, although they are not consecutive leads, they may be these are the leads supplied by the same coronary artery, and also V2 is independent of this particular circumflex artery. So V2 also shows ST elevation. So whenever ECG looking like bilateral myocardial infarction with ST elevation in L1 and AVL, you must always look at V2 for the ST segment elevation. When there is ST segment elevation in V2, it indicates a D1, diagonal 1 occlusion. So this is called the South African flag sign because it may indicate a D1 occlusion. The D1 occlusion will produce ST elevation in lead 1, AVL and V2, and you can see that L1, AVL and V2 and ST segment depression in L3, L2 and AVF. So this once again indicates an acute D1 occlusion. So when you think only bilateral myocardial infarction, you may be thinking there's a small area with the bilateral lesion is involved, but when a large D1 occlusion is there, it may involve a huge myocardium at risk. So this patients once again should go for early intervention.
Then we have a new onset of bilateral bundle branch block or bifascicular block. So when you compare the left bundle branch block and right bundle branch block in acute coronary syndrome, the presence of acute right bundle branch block indicate a very proximal left-handed descending artery when compared to left bundle branch block. So both may indicate the proximal left-hand descending artery, but the RDB tells you the occlusion may be before the first septal branch, which supplies the right bundle branch block. So that's why whenever there is a new onset of bifascicular block like right bundle branch block with left-handed vesicular block, because both are supplied by the initial first septal branch. So whenever occlusion of LAD is before first septal branch, the patient may have a new onset of bifascicular block. You can look at here the right bundle branch block and left-handed vesicular block, new onset, and this may indicate a proximal LAD occlusion before the first septal branch. The next pattern is posterior myocardial infarction. So many times we diagnose posterior myocardial infarction by the reciprocal changes which happens between V1 to V4. So whenever the patient comes with acute chest pain and has got ST segment depression, most often it is also with the inferior myocardial infarction, but isolated posterior infarction is not rare. When the patient has got isolated posterior infarction, he may not have the inferior ST elevation, but will have ST segment depression V1 to V4, and it is 97 specific 90 for the occlusion myocardial infarction and 36% for requiring urgent percutaneous coronary intervention. It may tell a large area of your posterior wall is at risk of developing a scar or total depth of the myocardium. So that's why the V1 to V4 ST segment depression, you must always rule out a posterior myocardial infarction, and this is once again a pattern of occlusion myocardial infarction involving either right coronary artery or a left septal artery depending upon the coronary artery dominance. So V1 to V4, this plain ST segment depression may be a reciprocal change of posterior ST segment elevation. So patient is coming to chest pain, you have no ST elevation in inferior leads, but you are classically you have seen that V2, V3 and V4 showing an ST segment depression, indicating to you there is a isolated posterior wall infarction. So although this ECG looks a little bit innocuous, but a huge area of posterior wall is at risk. Subclavicular fact sign is an indicator of D1 occlusion. New onset RB LAB is indicative of proximal LAD occlusion, and posterior occlusion myocardial infarction presented by reciprocal segment depression is indicative of either LCX or RDA or their branches. So all of them need immediate intervention. Then we have a terminal QRS distortion as a pointer of occlusion myocardial infarction. So whenever there is a terminal QRS distortion, that is the ST segment elevation at the J point, the important differential diagnosis is early repolarization syndrome. When the patient comes with the ST segment elevation of the concavity upwards, one of the differential diagnoses between STEMI and also the anterwall myocardial infarction is the early repolarization syndrome. But in early repolarization syndrome, there is a specific point to diagnose an early repolarization syndrome when compared to ST elevation due to LAD occlusion. The proximal LAD occlusion also present with the ST elevation, but you have to differentiate between early repolarization. The two important points are this. When you have the ST elevation, what we mean by terminal QRS distortion is the terminal portion of the QRS is distorted by the ST elevation. The ST is not allowing the QRS to settle down to the baseline. The ST starts before the end of the downslope of the QRS. That's what we mean by terminal QRS distortion. So if it is a myocardial infarction or a STEMI, what you have, you will not have the S wave. S wave is a deep wave after the R wave, and also you may not have the NOS. Whereas in early repolarization syndrome, you will have an S wave, that is the ST will come down, the QRS will come down, and there will be a notch between the ST segment and the QRS, and the prominent J point may tell you it is an early repolarization syndrome. If you look at this particular ECG, patient has got ST elevation, so you can see that here the terminal QRS distortion is happening because the QRS downslope is not allowed to settle down. The ST starts in the downslope itself. You do not have any S wave and you do not have the notch. So that means this is a classical LAD occlusion rather than an early repolarization syndrome. In early repolarization syndrome, what you can have this S wave. You can see that S wave. The QRS comes down and then goes up. Whereas you can see that here, there is no coming down of the QRS. It takes off from the downslope of the QRS. And also you have the notch between the ST segment. So this is an early repolarization syndrome rather than the acute myocardial infarction. So whenever the ST smiles like this, when there is a concavity upwards with a J point and a notch, it is likely to be early referral syndrome. The absence of this ST is taking off from the downslope as a convexity upwards ST. It is likely to be occlusion myocardial infarction. Then we come to the diagnosis of left bundle branch block with acute myocardial infarction. So we know about Cardiobase criteria, which has got a concordant ST segment elevation, concordant ST segment depression, and also excessive discordant ST elevation. So whenever the patient has got the discordant is the rule in a classical left bundle branch block, where the ST segment, the T wave, will be opposite to the QRS. Whereas when the ST goes up with the QRS and the T wave also goes with the QRS in either L1, lead 5, V5 or V6, this is given 5 points. And the second criteria in V1 and V2, normally in uncomplete left bundle branch block, you have ST elevation up to 5 millimeters, whereas here the QRS is down, the ST is also down. So ST segment depression in V2, V3 has got 3 points. This is concordant ST segment depression. This is concordant ST segment elevation and excessive discordance. So here only the Smith modified this criteria as this ST elevation is more than 25% of the S wave. So when the excessive discordance is there, then also it has got 2 points. Whenever you calculate this score and the score of equal or more than 3 may be indicating an associated occlusion myocardial infarction in the presence of left bundle branch block or ventricular pace rhythm. So most often it is difficult to diagnose. When the patient comes with acute chest pain LBB, you do not know whether it is a new onset or a late onset, or when the previous ECG is not available. Applying this criteria will help you to diagnose an acute occlusion myocardial infarction and immediate intervention. So you can see that this is a classical of LBB. LBB, the J point is depressed, ST is down, T wave is inverted, opposite to the QRS. So discordant is a rule in left bundle branch block. Whereas look at V5 and especially V6, you can see the ST is going with the QRS and the T wave is also going with the QRS. So this important point tells you, so you have more courageous enough in this ECG to thrombolize or send him for a PCI rather than isolated left bundle branch block without Cardiobase criteria. And the excessive discordance is here. So excessive discordance is the amount of ST elevation more than 25% of the depth of the S wave. It may have 2 points. Whereas if you have ST segment depression in V2, it may have the another 3 points. So in this way, we can diagnose an acute myocardial infarction, occlusion myocardial infarction in the presence of left bundle branch block. Then we have a condition called precordial swirl. The precordial swirl is a distinctive clockwise vortex appearance of the ST segment. Here there is a marked ST segment elevation in V1 and V2 and there is depression in V5, V6. So this is creating a distinctive clockwise appearance of the ST waves through the precordial lobes. So what this pattern is exhibiting, it tells us that the ST segment is directed rightward. Whenever there is a rightward ST segment elevation in V1 and AVR, it may represent a very proximal left-handed descending artery occlusion, especially before the septal branch and also the diagonal branch. And it is once again a huge myocardial infarction. It may happen and this patient should go for early intervention again. So you can see V1, V2 shows an ST elevation and there is a clockwise ST. From the ST elevation, clockwise it goes to ST segment depression. From the ST segment depression, it comes anti-clockwise to ST segment elevation. So this is called the precordial swirl, and the precordial swirl is beautifully shown here. You can see in V1 and V2 there is an ST segment elevation. So from the ST segment elevation, clockwise it goes to ST segment depression V5, V6. From the ST segment depression V5, V6 it goes to ST segment elevation to anti-clockwise. So what does it mean? It means a very critical proximal LAD. You can look at that some elevation AVR also. So this in this pericardial swirl pattern is indicative of a proximal critical occlusion of LAD. Then we have a northern myocardial infarction. The northern myocardial infarction is a new term to be used for any ST segment elevation in AVR and AVL with a negative T wave in any ST segment depression V5 in inferior leads or lateral leads. So a very peculiar ST elevation in two important leads, that is AVR and AVL. So you have an ST segment elevation in lead AVR and AVL, and you have reciprocal depression in L2, L3 AVF and also V4 and V5, V6. So you can see that northern myocardial infarction is the ST segment elevation in lead AVR, ST segment elevation in AVL, but reciprocal ST segment depression in L2, L3 AVF. So this indicates northern myocardial infarction with ST segment depression also in the lateral leads. So whenever you have a northern occlusion myocardial infarction, it may indicate once again LAD or a first diagonal occlusion, bifurcation disease, LAD or first diagonal bifurcation disease. Precordial swell tells you proximal LAD occlusion. Modified Cardiobase criteria tells you any artery which has got any artery leads which has got this pattern may tell you that artery critical occlusion or total occlusion, and of course terminal QRS distortion tells us there may be LAD occlusion. Then there may be subtle elevation where whenever there is a significant anterior segment depression, you are supposed to look at the inferior leads. A small ST elevation in inferior leads may be missed and you will have only the ST segment depression. So many times the reciprocal depression will be much more than the real culprit of ST segment elevation. Once again, this represents an occlusion myocardial infarction of right coronary artery. Whenever there is anterior segment depression, look for a subtle ST segment elevation in inferior leads. Don't miss the total occlusion of LCX and RCA, and only concentrating on V1 to V2 and telling and diagnosing this as a non-ST elevation ACS. So whenever ST segment criteria are fulfilled, look at all the other causes of ST segment elevation. There are so many causes of secondary ST segment causes like left ventricular hypertrophy, known left ventricular aneurysm, Brugada syndrome, right bundle branch block, Wolff-Parkinson syndrome, then artifacts. Primary cause of ST elevation, we told us, to early repolarization syndrome, pericarditis, myocarditis, Tokuto's cardiomyopathy. So if these causes are there, you have ST segment, ST mimics. When these causes are there, it can be ST elevation myocardial infarction, classical occlusion myocardial infarction. In the absence of classical ST elevation MI, you have to look at these changes we have described. Subtle ST elevation, Valence syndrome, hyperacutive T waves, D-Venter pattern, Aslanger pattern, South African fact sign, nuanced rabbi-vesicular block, post-acute myocardial infarction, and terminal QR distortion, modified Cardiobase, pericardial swell, northern MI. If they are present, you have an occlusion myocardial infarction. Primarily, you will be diagnosing this as a non-ST elevation MI. The important message is when these changes are there, it is a STEMI equivalent. Although you don't have the ECG criteria of STEMI, this should be treated as an acute total occlusion or very critical occlusion with active myocardial infarction at present or in future, and these people will have should go for immediate reperfusion therapy. So that is what the primary aim of this talk is going to give you. The very important ECG changes, we are likely to miss an active infarction. Subsequently, the patient lands with a massive myocardial infarction. After that, we cannot do anything. So this is the change in the attitude. We have in our student days, we allowed the myocardium to die and get stabilized. Then we come to a very active intervention with the ST segment elevation. So we are looking at the ST segment elevation and thrombolizing and doing primary PCI. But the important point to be remembered, in 56% of patients with acutely occluded coronary arteries, they do not exhibit ST segment elevation. 25 to 33% of individuals classified as non-ST elevation MI have acutely occluded artery with a classical active myocardial infarction. They will benefit from immediate intervention. These are the ECGs I have told you and shown you. And of course, 6% of individuals classified as very high non-ST elevation MI only are going to go for acute intervention, not this 25 to 30% of patients. And the future is likely to be application of AA and evidence-based ECG and other investigations, and of course new goal to reperfuse all occlusion myocardial infarction, and the new outcomes is going to be occlusion myocardial infarction versus non-occlusion myocardial infarction, and of course the newer classification and the treatment modalities are going to come. But the million-dollar question is this: whether we can thrombolize occlusion myocardial infarction patterns I have just described. The answer is not yet there. So at this point, we can say occlusion myocardial infarction, the patient should go for immediate coronary angiogram and a suitable revascularization. We have no reason to say that at this point we can thrombolize these patients. Thank you for the patient listening.
That was a masterly lecture by my mentor and my guru, Dr. Chennappan sir. He has given a lot of new insights into the ECG interpretation. Previously, when L3 alone was showing 1 millimeter ST elevation, we used to ignore it, because the standard teaching is the changes should be there in anatomically contiguous leads and we would have missed it easily. Today we know it is Icelandic pattern, and we need to look at the similar some changes elsewhere also. So similarly, the South Africans, and they are all very new informations for us, and I am sure the ECG, we will be saving a lot of more lives by recognizing these things from today. Since the speaker is not physically present here, we can allow some questions. I request our doyens, Dr. Sengotu sir or Dr. Cardiobase sir, to take the questions, if there are any.
Any questions?
Please give him the mic.
It's a great presentation, a real master class, never attended. It's a great learning today. So I'd like to know, sir, the clinical problem is when a patient comes with chest pain, we don't know whether typical, atypical, non-anginal chest pain, anginal chest pain. In those situations, we'll be taking ECG. How early the ECG will pick up once after the onset of the chest pain? So otherwise, how frequently you can take or repeat ECGs?
Even every 5 minutes or 10 minutes you can take depending on the clinical scenario. Nowadays what we do is if you have an atypical chest pain, the question you asked, the newer gold standard is HS troponin I. But the interpretation of HS troponin I is a very tricky question. I don't want to dwell too much into that and take too much of time. But if you have a HS troponin I, even 0 to 1 hour difference makes a negative impression. And if the patient comes less than 3 hours time, 0 to 2 hours. So within 2 hours you can rule out myocardial infarction nowadays. ECG, depending on your clinical acumen, it doesn't really matter.
Sir, one question is that ECG early repolarization changes in diabetic patients, sir. Recently in one conference they were telling that diabetic patients who have early repolarizations, your takes, sir.
Early repolarization is not as benign as it was thought to be, something like white coat hypertension. We always say that white coat hypertension is nothing, don't worry. Early repolarization is nothing, don't know. It's not like that. The prognosis for somebody who's got an early repolarization does change. It's not as normal, but not as bad as a myocardial infarction. I'll put it simple.
Thank you.
How do you manage, sir, when you find early repolarization syndromes? In case we do that, what do we do for the patient?
You don't have to really treat those patients. It's nothing much. Generally, what I will say is risk factor modification. Anybody who's got any ECG change, utilize the opportunity and go for a strict risk factor modification. Primary prevention, primordial prevention takes a very important step. Because you tell them something is there and instill the thought that there is going to be preventive heart disease is there, it will benefit considerably for them.
I think we'll go to the next speaker. Please call the next speaker and next chairperson. So thank you very much, Dr. Prabhakar and Dr. Parandaman.
Thank you so much, sir, for giving me this wonderful.
Thank you for
Thank you so
sharing
much.
the event, sir.
The chairperson and the speakers will be felicitated outside. Please come on. Anush, call the next speaker, next chairperson.
So for the next session, our chairperson is Dr. Prabhakar. He is fellow of ACC and Indian Society of Hypertension and professional member of European Society of Cardiology, and he is a co-author of expert consensus statements on LA dyslipidemia management, part 1, 2 and 3, 4, Indian Society of Hypertension Guidelines 2023. And he has more than 100 publications and presentation in conferences, and he is a primary investigator and lead of the Heart Failure Registry of Tamil Nadu for the ACERT group. And he is the first author of 6 papers presented at 9th World Hypertension Congress 2025. And his current research is ambulatory BP monitoring, ApoB versus LDL cholesterol, resistant hypertension reclassification, neural network to calculate LDL-C.
I also request Professor Alagason to chair the session. You know, Dr. Alagason needs no introduction. He is one of the authorities on echo, and we are also happy to have him to chair this session. And the speaker, of course, Prabhakar and Alagason will introduce the speaker and the topic.
Thank you, sir. First, what I'd like to say is that excellent talk by Dr. Chiniappan, but don't go overboard with ECG changes in ST elevation myocardial infarction. Dr. Chiniappan has also got one talk wherein he talks about all the mimics of ST elevation and gives you about 25 ECGs where there are some abdominal conditions, chest conditions which are not myocardial infarction. So be careful, it's your clinical acumen, ECG changes, everything has to be done. But once you come to the diagnosis of ST elevation myocardial infarction, then the golden hour comes. The price of gold always keeps going up. Similarly, the price of treatment of golden hour also keeps going up. Now today to talk about newer technologies. Now what we have been doing is thrombolizing patients all these years. Now what we are going to do is what can be done in future. What about difficult cases? Not all cases, it's not easy to sit in the cath lab and go ahead and do a primary angioplasty. What is going to be the difficulty, what is going to be there is going to be addressed by our course director. Should I need to introduce Senkutvel in detail? Senkutvel is probably the leader in doing TAVIs and the mitral clefts intervention, structural interventional heart disease. Not only that, in fact, he's been the pioneer in Apollo hospitals trying to do the imaging modalities. He started the imaging very early on, and I still remember Apollo when he joined. That is when we were trying to start radial. He came and did all cases radial. So he's got a lot of firsts to himself, and let's see his experience, what he has done over the years, and what he shall be doing to cases which are difficult to manage, and what is going to be the new path-breaking trends in management. Sir, one second. Dr. Senkutvel, if you're ready, taking time. Yeah.
Just 1 minute they connect.
Yeah. There are a lot of interesting things that have happened in the management of STEMI. Alex.
Actually, when I was in Madras Medical College, we came across a paper where you apply the ST segment elevation criteria and thrombolize the patients. There was a paper in JAC, there was another paper in American Journal of Cardiology. About 10 to 20% of the patients who are thrombolized did not have myocardial infarction. So you have to be a little more careful when you are evaluating, say, patients with ST elevation myocardial infarction. And especially you have to be aware of pulmonary thromboembolism, dissection of aorta, etc., presenting with chest pain, and even dissection can have an acute myocardial infarction also. So it will be a catastrophe if you thrombolize a patient with dissection of the aorta. And another thing is often hypertrophic cardiomyopathy presents with features similar to myocardial infarction or ST elevation. There can be Q waves. So those patients you have to evaluate when they are having chest pain. One of the best one is to have a quick echocardiogram done say as soon as you take the ECG. If you take an echocardiogram, you can more often diagnose especially pericarditis mimicking infarction, the dissection of the aorta mimicking infarction, pulmonary thromboembolism producing RV dilatation. Like that, number of other conditions can be excluded before you thrombolize.
Sengs, are you ready?
Yeah, ready.
Yeah, go ahead, please. Madam, in an acute setting, troponin, HS troponin, highly sensitive troponin, probably we'll ask Murugan sir to have a session on HS troponin evaluation. That's a very interesting topic.
Is the rapid test useful? The NT-pro, have the rapid test. So will it be useful if it is positive? If it is negative, it is not going to be definitively exclude the thing, I think.
So rapid kit is okay for chronic pain, sir, but for an acute setting, you have to go by HS troponin. There are 3-4 values you have to remember. The value less than 5 at any time is negative. If it is less than 13 and if there is no delta change of more than 5 between 0-1 hour, 0-2 hours, then it is still negative. Otherwise, everything else has to be observed. Very few people get out of it. Senkutvel.
Yeah, thank you, Dr. Prabhakar. Thank you, sir. So let us now talk about how we do early intervention and save lives in cath lab with a lot of new availability of new tools and techniques. We are able to give much better results to the patient, transforming to increased longevity. So we know that the STEMI now, primary PCI is the gold standard, and we know that time is muscle, time is myocardium. We have to act in a time-bound manner, and we know that every second we lose myocardium. So we can see that there is evidence that every 30-minute delay in reperfusion results in 7.5 increase in 1-year mortality. So the goal today is to have a door-to-balloon time. That means from the door the patient arrives to the hospital till the time the artery is opened up with a balloon, it should be less than 90 minutes, so that we reduce the time in the emergency, in the diagnosis, and quickly shifting them and getting the cath lab team activated. So that is a standard today, and I just want to show you how we have been generally doing primary PCI quickly, and then I will show you what we are doing currently. This is how generally A primary PCA patient comes, and I can go a little forward. I don't know whether I can do that here. Can you show that? Okay, play that. So, I'm not able to forward it, but I have to play the entire thing, it will be long. Yeah, very good, excellent. Okay, now it's fine. So play it, show it. Volume also you can have. So as soon as he arrives, quickly shift the patient out, quickly take an ECG, diagnosis, quickly shift to the cath lab, get him inside.
Her rate is quite stable. 72-year-old lady, a known diabetic and a known hypertensive. So she has come with chest pain lasting for 3.5 hours, window period 3.5 hours. So we have taken up to the cath lab immediately. So she has also CCG showed ST elevation in 3 AVF and also some ST depression in AVL with ST elevation also in B3, B4. So she was having a winky back phenomenon with a heavy block. So we decided to put a venous line, and now her rate is quite stable. Her rate shows more than 110 heart rate. So we have the venous line. We are just going with the diagnostic catheter quickly and do the right if possible. The vessel infarcted artery would be probably the circumflex. So we will take a quick angio and then take the guiding catheter. Okay. Okay, picture.
So you can see the ECG and the blood pressure.
Is 90 systolic. So let's see whether she needs 80. So let's.
The pressure is only 70.
When we get a pacemaker, we will just start pacing him and then we will go ahead quickly.
So we're putting a pacemaker because she has got some
let's give more
hypotension.
fluids,
So you can see the blood pressure, hypotension, little bit hypotension.
No significant disease in the LAD and SERC. So we will do a quick, we know that the right coronary is totally occluded. So let us open it and then take care of the left. You just look at the left coronary artery. It appears with just one quick check shot, it appears that there is no significant disease there. There is at least symmetry flow in both the LAD and circumflex. So let's now attend to the RCA, which is totally occluded proximally, and then take care of the left injection when we finish the primary PCI. So the pressures are much more stable now. We increase the dopamine. How much dopamine is flowing now? Okay, there is 5 dopamine and some fluids are given. Small test sister. I think there is some amount of damping. So let us open it.
The beginning of the right coronary artery is occluded. I am trying to take a wire inside to open the block. I have to cross the wire.
Okay, so let us take a picture and see where we are, and then take a small picture. Okay, so we have diffuse disease and there is some thrombus down. So it looks like thrombus has migrated down when we started wiring it. So I think we need to consider doing an aspiration in this case because otherwise we'll push a lot of thrombus down to the PDA and PLD. So can you get the aspiration catheter? And there is some significant distal embolization. So getting the catheter in. As we are entering, I would like to. Oh no. Okay, we don't have much flow. Is there flow? No. No.
So we are trying to aspirate.
So no major contraindication for thrombolysis. So we decided to give intracoronary thrombolysis here because of the burden of thrombus and distal.
Because of huge thrombus burden,
giving 2 inhibitors in this situation might help. But looking at the burden of thrombus, I would prefer to give thrombolysis. So it looks like there's a lot of distal embolization here.
Now you have ventricular bigeminy there, the ECG.
Before you put 3A, inflate and put 3A, so that we don't have any air inside. Okay.
We are trying to get the flow back in the artery.
Keep going, keep going. Give another push. Another push. Not much difference. Back. See, no, the better movement of the balloon also is better. You see? So ready for picture. Pressure is okay. Okay, picture. I'm expecting good flow, but
See, there is almost no flow distally. Blood is not flowing, full of clot inside, despite the
okay,
thrombolysis.
let's do one thing. We are getting, but give me one more. We will stent it and then we will.
So we are putting a stent in the proximal region.
Give the SNP, some more SNP.
We are giving some medicines to get the flow back.
But the problem is, I think there is a lesion there or thrombus only. It looks to me, I think there is thrombus. But it looks like there is a lesion in the thrombus, so we decided to stent that part. 1 minute 23 should be fine, I think. 15 plus 8, yeah. Okay. Give. Okay, keep injecting. Nine. So you want to put one more stent there? I think we have to. 23 may fall short. Now we can take the stent inside. Now the deep.
They put multiple stents.
In this case, I don't want to use complex. Okay, still we don't have a TIMI free flow. The TIMI grade is less, but hopefully it will improve probably from this level. Okay, now good picture, yeah, good picture.
Finally, we get the flow back.
And the patient is stable. We will complete. We just take a quick shot of the left colon, left injection.
So patient had a intermittent, in the middle had a VT, which I tried to show it to you. I couldn't get that exact frame, but we had to shock the patient and then revert and finally got the flow back. So this is a usual challenge we face in the primary PCI. Huge amount of thrombus, getting the clot out, getting the flow back is always challenge. We use a lot of aspiration and sometimes use intracorneal thrombolysis rarely, but nowadays there are several other methods to. So thrombus is the biggest enemy, and thrombus is always a challenge. So now we have several other therapies to. Can I have the slides, please? Now it's over. Huh? It's not coming there. Okay, so the new cutting-edge therapies are now developed to act on the thrombus. One is we have mechanical thrombectomy, where the thrombus burden is huge. Now we earlier used to use aspiration catheters and aspirate. Now we have a powerful system where you can have mechanically, it can suck the thrombus and you can remove the thrombus, particularly when there is a huge thrombus burden, so that we can restore the blood flow early, reduce the infarct size, and then have a good clinical outcome. So I will show you one case where this is a new technology where there is a powerful mechanical aspiration. There is a engine which has a power, and it just has a very large lumen, and this catheter can be used in using this in challenging patients. This is one of the patients where we have a total occlusion of the right coronary artery, huge thrombus from the beginning till the end, and it was so much amount of thrombus, so the aspiration catheter wouldn't work, and we had to use a special the CAT catheter, which is the mechanical thrombectomy, and we had to use a lot of power and engine, and so we were able to take out the thrombus. The amount of thrombus burden was huge. You can see the thrombus we aspirated. I can show you. This was the amount of thrombus we removed from the artery. These are all bits, and you can see a large clot. In fact, it was like a shape of the artery which we were able to remove from the right coronary artery on the left side. So once we got it, we could see that now the flow is back. The artery is a lot of ectasia, and you can see the flow back, and we were able to revascularize this patient. So the next, another new technology is laser. I use a lot of laser now to vaporize the clot. So vapor is again a new technology which is a which is actually photocoagulates and completely removes the clot. I'll show you a video.
So this is the laser console for intracoronary laser, eczema laser, which is very useful in certain situations where the block is sometimes very hard and difficult to cross with the conventional balloon. It's extremely useful in difficult situations, in complex cases, and sometimes where all other materials fail. An animation where you can see laser catheter moving forward, it ablates the tissue, it emits ultraviolet rays, laser which causes sonic waves, and that creates a bubble, and bubble helps to expand and debulk the lesion. So thereby a big lumen, the artery blocks are cleared. As you could see in the saline, there is no cavitation energy. Where you can see cavitation bubbles, you can see in this contrast now see this very powerful.
Very powerful.
See the difference.
And we use this energy to, now you can see this is again a young male. He is actually one of the very important person in one political party. So we had seen he'd come young person who came with almost total occlusion of the right coronary artery. It was actually failed angioplasty in another hospital, and you see there's a huge amount of thrombus fully inside. So how do we do it? Then we used laser. And see, we passed multiple times we passed the laser, and then we were able to get a flow. You can see that we got a flow a little bit, and then we were not able, because of huge ectasia, we were not able to size it. Then we did an intravascular ultrasound. We saw there was a huge ectasia. We were able to again use the appropriate size stent, and we got the flow back. This is the final angiographically. You can see that artery is fully open. It's a big vessel. So we were able to achieve this because of using this laser and intravascular imaging, which we are able to get. So another area is we are having now patients coming with cardiogenic shock, which is again one of the categories where the mortality is extremely high, and the survival is almost about 10 to 20%, almost nil if they're not treated. So I think these patients with acute MI, again a challenge. Now we have a lot of support devices. So it is not, once the circulatory system fails, it translates to reduced tissue perfusion, and so it's very important to identify early and act upon these patients when they come to emergency. So these patients, now we have several options. Intra-aortic balloon pump was originally available. ECMO was available for the past more than 30 years now, 40 years, but now we have the Impella, which is again a small miniaturized pump which can, the pump is placed inside the left ventricle, so it sucks blood from the left ventricle, and it outflow, you can see the outflow in the aorta. So basically this is it's like a submersible motor pump where it sucks blood from the left ventricle, puts it into the aorta. So it is it takes over the function of the heart, and therefore unloads. So the heart is now has a reduced afterload, almost zero afterload. So it unloads the ventricle, so allows time to heart to recover, and then you can revascularize. You have time, so the demand and the unloading helps heart muscle to recover. I'll show you some cases. This is one of the patients who had a left main occlusion, and he came with a cardiogenic shock. And the right coronary artery is filling, came with cardiogenic shock. You see the mortality is very high if you don't do anything. We had quickly put in a ECMO, VA ECMO, and also put in a intra-aortic balloon pump. Then you could see that we have stented the left main with the bifurcation stenting. And this is the flow we got finally after about 2 hours struggle. I'm just showing you briefly. So this man actually walked home and doing well, but this is one of the situations where this patient was able to reach the hospital. Sometimes left main occlusions don't even reach the hospital. They often die at home or outside the hospital. The Impella is the device, as I told you, it pumps, it takes the blood from inside and brings it out. So in this situation, anterior MI with the left main, we put in an Impella and then did a complex plasty. So these technologies are now helping to really, in sick patients, cardiogenic shock patients, we are able to bring them back. So in these patients, it's very important to understand the time is again very important. So now we talk about a new time called door to unload time. And in these cardiogenic patients, cardiogenic shock patients, we identify early, and we are able to identify the systolic blood pressure is becoming very low, and with a lot of inotrophs. And there is tissue hypoperfusion, very, very important. The lactates are going down, or if the mixed venous oxygen saturation is going down, then it is very important that they should be immediately placed on the support devices and primarily safe one. So it's very important now to use all these innovative technologies, not just about technology, it's about transforming the entire pathway right from the patient arrives in the hospital till we do a complete reperfusion. So we have to treat it not only faster but more also smarter. Thank you.
Thanks, Dr. Sengupere. I think that is very interesting to see a case and then proceed with cases and give a more practical approach to the physicians. I think that makes them see, you feel, and you can understand much better. I think interesting technologies have come up in several aspects of myocardial infarction. I think the most important rule, the golden rule, still stays good. The golden hour, don't waste time, diagnose early, open up the vessel. Opening the vessel is more important. And today we also come to a point of saying that we'll have what to say about thrombus aspiration as well.
Mechanical thrombus aspiration is all depends on the thrombus load. If you use a thrombus load, then we use all this mechanical thrombus aspiration or laser. I think as Dr. Prabhakar was mentioning, a lot of changes in antiplatelet therapy. But I think one tip about therapy, I think all these patients should receive aspirin and ticagrelor or prasugrel, not clopidogrel in acute coronary situation. So it is very important. The guidelines strongly recommend to give either ticagrelor or prasugrel. So you have to load with 180 milligram of ticagrelor along with aspirin or 60 milligrams of prasugrel, the aspirin, and statin, of course. So clopidogrel is completely out in acute coronary syndrome. So that's very, very clear. So that is one thing which you should all remember before we load and shift the patient to any other higher center.
Any questions from the audience? Yeah, Dr. Parandaman always.
So wonderful presentation, very innovative technology and very skillful, very amazing to see the procedures. So when you pass a laser wave to extract the occlusion or clear the occlusion.
Actually it doesn't extract, it just vaporizes, it just goes away.
Oh, okay. Is there any chances of injuring the normal endotheliums?
No. See, that's why the catheter is just, it hits exactly in the lumen and we have to size the catheter properly. So it is actually sized 0.5 ratio. With the artery is 3 millimeter, we use a 1.4 or even 0.9 laser catheter. So the risk is very low unless you use a contrast laser. Then the power is several fold higher. So if you use a saline laser, it's very safe. But again, situations demand we sometimes use a saline laser. If the saline laser doesn't work, we use contrast laser. Which means during laser we give contrast injection and that increases the power of laser. So we can control, and energy is also controlled. We have the console, we can control the energy, both the laser energy depending on how much we need.
Great.
Dr. Ravi Edwin has asked a question particularly to you. Experience of laser on huge thrombus burden.
See, one area where laser is extremely useful is huge thrombus load. There is no doubt. So the indication for laser are multifold. One, where you can't cross the lesion, uncrossable lesions. When there is heavy calcium, and calcium also it can help to allow other devices to track. Instant restenosis, where the failed stent, then the riser can help. But in this context, what I was discussing, for a thrombus, particularly when there is a huge thrombus burden, laser is a wonderful tool, particularly because it doesn't cause thrombus to embolize, because it vaporizes thrombus. So it is quite safe, so that there is no embolization, unlike the other devices where there can small bits of thrombus can go down. So extremely useful to have laser in high thrombus load. In fact, I have also used in a failed SVG grafts, which is very, very challenging to open, failed bypass surgery grafts, where it is fully laden with thrombus. We have experience in using laser and opening up those grafts. Thank you. CTO, the laser, see, you have to get a wire and a balloon and once you cross with the wire, then further devices cannot be advanced. Sometimes whatever device you can't be advanced. So laser will help to create a passage, and then you can use other devices to treat the CTO. So for CTO, where none of the devices are able to cross, laser is extremely useful to create a pass and then cross it.
Thank you, Dr. Sengupere. That was an excellent session. Let's give him a big hand and say thank you for exposing us to new things in life. This is probably artificial intelligence from Sengupere. Thank you so much. Go for the next session.
You are continuing?
It depends on you, sir. When Shanmugam sir orders, I have to obey. God says, I will say.
I think he said, no, you can continue. Who? Vinayak. No, wait. No, I will request Dr. K. Vinayak Sendil. He is the general surgery and also cardiovascular surgeon. There are so many MRCP, UK, FRCA, so many things are there. He is the consultant cardiothoracic surgeon, founder and managing director and faculty, Speed Medical Institute, Chennai, chairman, Speed Medical Center Hospitals and Speed Medical Village, Chennai. The next speaker will be yes, you had. Dr. C.K. Pandey, we welcome you, sir. He is also a MD, DM cardiology, independent cardiology, consulting cardiologist at Bombay renowned PD Hinduja Hospital and Medical Research Center. He completed his post-graduation in medicine from Shivaji University, Solapur with top honors. He has delivered lectures on various topics in cardiology and several national and overseas conferences. Had the privileges to be selected as the referee for articles in cardiology for the Journal of Association of Physicians of India, JAPI. Fellow in Interventional Cardiology, Rotary International Ambassadorial Scholar, Fellow in Electrophysiology, April 1996 to 1997, Brisbane, Australia. Welcome you, sir. He is online. Yeah. He will be talking on the congruous promise of ARNI and SGLT2.
He's online, you can project him. You can project him.
Yes. Over to Dr. Pandey, sir.
The topic is interesting. The speaker is one of the very renowned speakers from all over India. Very respected gentleman in cardiology circles. Dr. Pandey is one of the very good speakers. He links so many things and talks coherently about the whole topic. I've heard him several times. Pandey sir, are you there? We can't hear you. Hello?
Hello, can you hear me?
Sir, Dr. Pandey sir, good morning. This is Dr. Prabhakar from Chennai. How are you, sir?
Can you hear me?
Yeah, we can hear you well, sir. Can you hear us?
Yes, we can.
Great, sir. This is Dr. Prabhakar from Chennai. We are from Cardiobase. We extend a very, very warm welcome to you, sir. We have had your introduction. I think without wasting much time, you can go ahead with your congruous promise of RD and SGLT2 inhibitors in heart failure management. The screen is all yours, sir. Thank you.
Thank you. So my topic today is the congruous promise of ARNI and SGLT2 inhibitors in heart failure management. When we say congruous, it is complementary, supplementary, and added promise when they work together. So what are the sad truths about heart failure in general? The sad truths are heart failure is deadlier than many cancers. If you look at the 5-year mortality of heart failure, it is higher than leukemia, colonic cancer, and even non-Hodgkin lymphoma. Heart failure is a progressive condition.
Pandey sir, one second.
High mortality.
Yeah.
High mortality, and with every hospitalization, there is a decline in quality of life and increase in mortality. Mortality remains quite high and urgent for patients with heart failure. In hospital mortality is around 4 to 6% in the best of the centers. 30-day mortality approaches 10%, and 5-year mortality, despite all that we do, approaches 50%. Is prognosis of heart failure different in Indian patients? Well, if you look at this data from Seth et al. Way back in 2015, Indian heart failure patients are approximately 2 decades younger than their Western counterpart. Our in-hospital mortality is almost 10 times higher, and the post-discharge 6-month mortality is 3 times higher. the inter-CHF registry, of which we were proudly the part of this registry, 23% of Indian heart failure patients die within an year of diagnosis. To add to that, if you look at this bar, the Indian heart failure patients predominantly have cardiovascular mortality as compared to Africa, where the predominant mortality is non-cardiovascular. If you look at the trajectory of the trials of drugs and devices in heart failure, after a long hiatus of 10 years, we had the Paradigm Heart Failure trial. This trial was done in patients with heart failure with reduced ejection fraction and who were stable with at least 4 weeks of treatment with ACE inhibitors or ARB, were then randomized to enalapril versus sacubitril valsartan. This was the largest mortality and morbidity trial in patients with HFrEF, most geographically diverse and most racially diverse heart failure trial. This trial ushered in a completely new era. It caused a paradigm shift from Paradigm Heart Failure trial. Sacubitril, by inhibiting neprilysin, reduces the degradation and increases the availability of natriuretic peptides. And thus, ARNI improves the good neuroendocrine axis instead of blocking it. So for years together, we are talking about RAS inhibition, sympathetic nervous system inhibition, and mineralocorticoid receptor antagonism. Here, for the first time, we talked about agonism or neuroendocrine boosting instead of antagonism. And this was the major difference. So if you look at the mechanism, we know that the sacubitril inhibits the neprilysin, and that enhances the natriuretic peptide axis, causing decrease in blood pressure, sympathetic tone, aldosterone levels, and fibrosis and hypertrophy, ultimately benefiting patients with heart failure. This trial showed 20% reduction in cardiovascular death and heart failure hospitalization, and 16% reduction in all-cause mortality in patients with HFrEF compared to enalapril. So over and above enalapril, it caused additional 16% reduction in cardiovascular death and primary composite endpoint of CV death, heart failure hospitalizations, and even all-cause mortality. What was more important in this trial was participants taking lower than target dosages of sacubitril valsartan also benefited quite well compared to equally reduced doses of enalapril in the comparator arm. So if you look at the clinical evidences of ARNI, and then of course many trials took place including Pioneer HF, Transition HF, and Paragon. As we all know, Pioneer was the trial using ARNI for hospitalized patients with heart failure, and there it showed a 24% reduction in 30-day mortality when sacubitril valsartan was started in hospital before discharge in patients with acute decompensated heart failure. Paragon Heart Failure randomized patients with preserved EF, that is more than 40%, to sacubitril valsartan versus valsartan alone, and this showed significant reduction in heart failure hospitalization in patients with preserved ejection fraction. However, there was no benefit in mortality. And if you look at the ejection fraction quartiles, the cutoff of benefit of ejection fraction was 57%. So anybody and everybody with heart failure with ejection fraction less than 57% benefited. Women benefited more than men in terms of reduction in heart failure hospitalization in patients with HFpEF. What about reverse remodeling? Through heart failure trial in approximately 800 patients with reduced ejection fraction, when sacubitril valsartan was used and a baseline echo was compared with 12 months echo in a core lab, it showed approximately 9% mean increase in ejection fraction 12 to 15% decrease in left ventricular end diastolic and end systolic volumes respectively. LA volume index reduced by around 8% and E by E prime by around 6. Even the global longitudinal strain improved by 42% with sacubitril valsartan, confirming the power of this molecule in reverse remodeling. Evaluate heart failure was another trial which tested the same hypothesis of reverse remodeling and showed significant per arm or upper edge of this molecule compared to enalapril in reduction of ventricular volumes and LA volume index. And then we formed this consensus, and Dr. Prabhakar was the part of this consensus, as I am aware, that sacubitril valsartan should be used in each and every patient with HEPREP, and even those patients who are relatively into inverted commas stable with ACE inhibitor should be shifted to sacubitril valsartan because of added benefits in sudden cardiac death and cardiovascular death with this molecule. ARNI is also efficacious in patients with relatively low blood pressures and irrespective of glycemic status. Then we come to the SGLT2 inhibitors. What did the pivotal 3 CVOT trials tell us? The CVOT trials of SGLT2 inhibitors, EMPEREC, CANVAS program and DECLARE TIMI58 showed one truth, and that truth is on the right hand side here: reduction in heart failure hospitalizations across the board, equally significant with empagliflozin, canagliflozin, dapagliflozin and vertigliflozin. So all gliflozins do provide significant benefits in heart failure hospitalizations. However, empagliflozin was the only SGLT2 inhibitor which showed reduction in cardiovascular death, and EMPA and CANA showed reduction in MACE. Then we realize myriads of multitude magnanimous benefits with SGLT2 inhibitors in improving mortality and morbidity in patients with heart failure. And I will not go into details of this for the paucity of time, but the 6 most important mechanisms are reduction in preload because of diuresis, reduction in afterload because of improvement in vasodilatation and reduction in aortic stiffness, reduction in body weight, persistent ketonemia making an alternative fuel available to the myocardium, reduction in interstitial edema and reduction in inflammation, producing significant benefits in heart failure. When these trials unleash another era of SGLT2 inhibitors in patients with heart failure, and these were DAPA-HF in patients with reduced ejection fraction, dapagliflozin, EMPEROR reduced with empagliflozin, and DELIVER in EMPEROR with DAPA and EMPA respectively in patients with heart failure with preserved ejection fraction. These trials consistently have shown benefits. And if you look at this single slide, 26% reduction in heart failure hospitalization in DAPA-HF and EMPEROR reduced. In DAPA-HF, in addition, there was 18% reduction in cardiovascular death and 17% reduction in all-cause mortality. In DELIVER and EMPEROR preserved, which were conducted with heart failure with preserved ejection fraction, there was no significant benefit in cardiovascular death. However, there was 20% approximately reduction in heart failure hospitalization with dapagliflozin and empagliflozin in patients with preserved ejection fraction as well. So if we compare DAPA-HF versus EMPEROR reduced, you can see that both molecules behaved almost the same, except the fact that cardiovascular death was significantly reduced with DAPA alone in DAPA-HF, but EMPEROR reduced, I think, was terminated little prematurely. Had it been conducted another 1 and 1.5 years farther, we would have seen primary benefits in cardiovascular death as well. DELIVER trial, however, showed a trend towards reduction in hospitalizations because of worsening heart failure, and even some trend to show reduction in cardiovascular death. The benefits were far much more in those patients who were more symptomatically impaired at the baseline. So more the symptoms, more the benefit. More recent the hospitalization with heart failure, more the benefit with these molecules. To add to the magic of these molecules, SGLT2 inhibitors, we know that 3/4 of patients with heart failure in India have iron deficiency anemia. And empagliflozin in patients with emperor-reduced showed reduction in new onset of anemia with empagliflozin close to 51%, and the similar results were seen in DAPA-HF trial with dapagliflozin. So what do SGLT2 inhibitors do really? They increase the secretion of erythropoietin by the proximal convoluted tubule in the kidney. They increase iron bioavailability in tissues, and they reduce ferroptosis, which is the iron-induced tissue injury that is caused in the myocardium. With the virtue of this, they improve the hemoglobin in patients with heart failure and reduce myocardial toxicity with iron, which is so common with heart failure. Effectiveness of dapagliflozin was also seen in DELIVER trial in the incident atrial fibrillation and flutter in patients with HFpEF. What about reverse remodeling? Several studies, including the recently released DAPA-MODA study, have clearly shown us that SGLT2 inhibitors do cause reverse remodeling by reduction of left ventricular end diastolic volume, left ventricular end systolic volume, improvement in global longitudinal strain, and reduction in left ventricular mass index. And then we had another consensus on SGLT2 inhibitors in management of heart failure. And in this consensus, we have clearly said about uniqueness of SGLT2 inhibitors: once a daily dose, no dose titration, no hypotension, no electrolyte imbalances, and in addition, glucose control in patients with diabetes. To add to the magic of these molecules, they improve iron bioavailability, and they are useful across all the ranges of ejection fraction. Whether you are low range ejection fraction, mid range, or preserved, SGLT2 inhibitors do improve or do reduce heart failure hospitalizations. They have also concordant benefits in renal outcomes by declining the progressive decline in eGFR in heart failure patients. So now if you look at the guidelines, SGLT2 inhibitors are RNA have class 1 recommendation in HFrEF. SGLT2 inhibitors have class 1 recommendation in mid-range and class 2A recommendation in even preserved ejection fraction. What about combining these molecules? These two big studies, one by Hasiao and second by DiMarzo, one in 2,300 patients between 2016 and 18, clearly showed that treatment with combination of SGLT2 inhibitors and ARNI was well tolerated, safe, and excellently effective in improvement of cardiovascular death and reduction of mortality and reduction in heart failure hospitalizations in patients with HFrEF. DiMarzo study in 91,000 patients showed clearly the stepwise introduction of ARNI SGLT2 inhibitors and the mineralocorticoid receptor antagonists showed the maximum benefits in heart failure patients. So if you look at all these combinations, multiple and myriads of combinations, the top combination, ARNI, beta blocker, MRA, and SGLT2 showed maximum reduction in mortality, close to 67%. Whenever SGLT2 inhibitor has been taken away from ARNI, the mortality reduction has declined. You can clearly see here, whether you add vericiguat, omnicative mecarbil, or whatever, the best combination is ARNI, beta blocker, MRA, and SGLT2 inhibitors, and therefore, by Dr. Salim Yusuf and Dr. John McMurray, they have been called as the Fantastic Four in patients with heart failure. So, to summarize, ARNI is an iconic molecule of the century and is indispensable and superior to ACE inhibitor in reduction of cardiovascular death, heart failure hospitalization, and even sudden cardiac death. It also improves ejection fraction and reverses adverse LV remodeling at all dosages in patients with HFrEF. On the other hand, SGLT2 inhibitors reduce CV death and heart failure hospitalizations in HEPREF and heart failure hospitalizations alone in HEPPEF. They also offer concordant benefits in renal outcomes in patients with HEPREF. They are easy to use, have no hemodynamic side effects, and have no electrolyte disturbances. Both drugs lead to significant reverse remodeling. Current guidelines have provided class 1 recommendation to both ARNI and SGLT2 inhibitors in HEPREF. On the other hand, SGLT2 inhibitors have strongly gained their position in treating HEPPEF as well. They have clearly different mechanisms of action which are not overlapping. In fact, they are complementary to each other. They are safe to be used together and extremely effective in reduction of cardiovascular mortality and heart failure hospitalizations in patients with HEPREF. In patients with HEPF as well, particularly in women, all the way up to the ejection fraction of to almost 57%, the combination of these molecules works well in the reduction of heart failure hospitalizations. When you combine all the fantastic four, you see a 67% phenomenal reduction in cardiovascular mortality in patients with HEPF. Thank you very much indeed, and that tells you about the congruous promise of these drugs in HEPF. Thank you.
It was indeed a very good and excellent presentation by Dr. C.K. Pandey. The congruous promise of ARNRA and SGLT2 in heart failure management, and we could learn a lot from you today's presentation. And any questions from the audience? Go ahead.
This is Dr. Aditya. Go ahead. Before Dr. Aditya asks, Dr. Pandey, I have a question for you. I was listening to Michael Baum, is he still there? You can project him if he's online. You can project him online. So Dr. Baum says that hematocrit increases when you give SGLT2, but actually the iron levels come down. You have to look at iron and probably supplement iron. Your comment on, I know it is contradictory to what you said, but this is what he said, and I had a little bit of doubt. Found a couple of references to that effect. What are your thoughts on that?
Yes, I think iron level 2 comes down by around 6 to 12% with SGLT2 inhibitors, but the bioavailability of the overall iron improves, and therefore the hemoglobin tends to improve around 0.6 to 0.8 grams over 6 months. But it is important to diagnose iron deficiency not by hemoglobin, but by transferrin saturation and ferritin levels in these patients, and supplement them simultaneously despite you using the SGLT2 inhibitors. You are absolutely correct, sir. Yes, sir.
Thank you, sir. Dr. Aditya is a physician from Chennai. Go ahead with your question.
Sir, good morning, sir. In case of Indian patients with heart failure with reduced ejection fraction, when the patient is maintained with the ARNI at the 50 mg dose itself, when they come for follow-up, what target dose I should be my target in case of elderly, and in case of 50 years old, and in case of less than 40? What target dose should I?
The younger the patient, higher the target dose should be achieved. Usually they tolerate very high dosages. So, but in my clinical practice, only 20% of the time I have reached the dose of 200 milligram twice a day. There is usually some degree of hypotension, symptomatic. If the hypotension is symptomatic, then you stop up titrating ARNI. Second problem with ARNI up titration is the potassium levels. So in fact, in our institute, the moment the patient goes on ARNI and MRA, the first consultation that occurs with a dietitian for a potassium restricted diet. So the patient starts following a low salt, low potassium diet right from the beginning. You will be able to up titrate ARNI very easily, up to 100 milligram twice a day in majority of your patients. In frail elderly patients, I would be hesitant to cross.
Cardiac asthenia, how to differentiate the side effects, sir, if it occurs? Patient complaints of inability to stand, not after starting.
No, most probably fatigue syndrome and also the sarcopenia.
After starting this, yes. Seems to be more.
That's really a concern with SGLT2 inhibitors, but the data clearly shows that in frail elderlies also the benefits are far outweighing the harms. But at the same time, I must say that when you put an elderly patient, frail patient on SGLT2, please see to it that number one, you stop loop diuretics altogether. Number two, check their volemic status by just keeping a probe in the inferior vena cava and check that they are euvolemic. Don't ever start a SGLT2 inhibitor in a hypovolemic patient because that will lead to problems, hypotension, falls, and even euglycemic ketosis. The third most important thing while starting a SGLT2 inhibitor in a frail elderly is to ensure their oral intake. An elderly patient who is eating poorly and who is getting SGLT2 inhibitors is not a good news. So those are the three things which I would like to emphasize.
Last question from Dr. Paramdaman.
Yes, sir. It's a wonderful presentation about this RNA and SGLT inhibitor. When you give SGLT inhibitor, there is an increased glucagon level. Well, this glucagon, increased glucagon has an direct effect on the myocardium in terms of hypertonicity or the increased performance of the contraction.
Yes.
Glucagon by per se, does it work like that, or other actions what you said was applicable?
See, glucagon action is one of the hypotheses of SGLT2 inhibitors, but I think more important than that is the other actions which I've said about reduction of preload and afterload, small persistent ketonemia which is making the alternative fuel available to the myocardium, reduction in aortic stiffness, and vasodilatation that is produced by the anti-inflammatory activity of SGLT2 inhibitors. There are myriads of mechanisms. Nobody knows which mechanisms are working in which group of patients. Myriads of mechanisms. But the drugs work, and they work how? They work beautifully in patients with HEP-REP as well as HEP-PEP.
Why I asked this question was, when you use for toxicity of the beta blocker and the calcium blocker hypotension, the refractory hypertension will be managed by injection glucagon. So when we use glucagon for that, whether the same works here like in heart failure, that's what my concern or work.
Oh, you meant that.
Yes.
I'm sorry, I won't be able to really comment. That
Dr.
was
Bonde, sir, you don't have to worry. Dr. Parandaman always bowls Google is worse than Shane Warne, so you don't have to worry about the question. We are all used to it in Chennai. Dr. Lakshmanan, I think you must be aware.
Panda, excellent lecture. I just wanted to know whether we used RNA as an antihypertensive drug.
Yes, sir. There are trials in place right now. Two big randomized trials. One is a multinational trial, and one is in Japan, going on right now. And I think the results will be available, one by the end of this year and one by the early part of the next year, of sacubitril valsartan in patients with resistant hypertension.
Yeah, well,
resistant hypertension.
I've been
Yes.
using it for people with CKD with hypertension. Really
Yes.
brings down the nocturnal blood pressure. And my
Wow.
observation, it really dips the blood pressure in the night. Normally, CKD patients are very resistant non-dippers. I think Prabhakar should be
correct.
knowing. He also is doing ABPM. Thank you, sir.
Yep.
Thank you, Dr.
Thank
Bonde.
you.
I think that
Thank
was
you very
an
much.
excellent discussion on SGLT2 inhibitors and RNA and your depth of knowledge and the way you answered our questions patiently. Thank you very much on behalf of the organizers.
Thank you,
sir.
Dr. Murgunathan.
Have a nice
Thank
day,
you,
sir.
Dr. Prabhakar.
Thank you, sir. Have a nice day,
IPCA,
sir.
for inviting me. Thank you very much indeed.
Thank you, Speaker and the Chairperson. I think we will move on to the next sessions. You can collect your memento outside the hall.
Thank you.
Yes.
Thank you,
The
sir.
next-
Thank you for the opportunity
Yes.
to be here, part of it.
The next talk will be on unveiling the power of inclisiran. I think the new drug has come. I think I don't know how many people have experienced this in India. For that, other than our dynamic speaker, Dr. Prabhakar, you know that now he is the most wanted person now in throughout India. Every state wants his speech. For that is Dr. Prabhakar. To chair this session, I request Dr. Balachandar. I think he is from Kollam, and he is a physician cardiologist from Kollam, and he has got so many degrees, MD, MNAs, then FRC, PFC. Over to the chairpersons. I think
Thank you,
one
Dr.
more. I request Dr. Lakshmanan, who is the dynamic clinician in city of Chennai, and also one of the most powerful speaker, especially in the case discussion, to chair along with the other chairperson. Please. Yes. Stage is yours.
Mic
Yes.
is not okay. Rathala. Dr. Lakshmanan is physically, mentally very, very strong. And Dr. Shanmugam made me most wanted, I don't know for what reason.
Good morning, gentlemen, please. So at the outset, let me thank Dr. Muruganathan as well as Dr. Senguttuvel for organizing a very nice meeting. So today's topic is going to be on a new molecule, that is inclisiran. We all heard about PCSK9 inhibitor, PCSK9, which is a protein secreted by the liver. This protein, along with LDL, it reduces the LDL receptor population, so that LDL disposal becomes a problem. So that's why we got a molecule called PCSK9 inhibitor. We all heard about alirocumab and evolocumab, which has revolutionized the treatment of LDL reduction. So now we have another molecule called inclisiran. This inclisiran is a small interference RNA which reduces the production of PCSK9 so that the LDL receptor can stay in the system for a longer time. So over to you, this is available as LivCube. And over to Dr. Prabhakaran.
Thank you, sir. Thank you for the kind words.
Inclisiran.
Sir, thank you so much, sir. I think you've given a lot of talk. A lot of my talk is already over in about 3 sentences by what you said. Thank you so much. Thanks to Dr. Muruganathan and the organizers for giving me an opportunity to talk about the power of inclisiran. I'm sure all of you have been hearing about inclisiran. At least I have spoken to a lot of people on this topic. Now, this is a beautiful village called the Framingham village. And Framingham village is the village that first came up with the concept that LDL is the risk factor for atherosclerosis. It also said that low HDL is another risk factor, saying that there is an inverse relationship. From there, we have been very, very clear that atherosclerosis is a lipid-centric disease. That's been very, very clear. And over the years, the guideline that has been spoken of most often is the European Society of Cardiology guidelines, which says that a target of 55 milligram per deciliter is the target for atherosclerotic cardiovascular disease. Look at the lowest level. Nobody can have an LDL that is more than 115, even for the lowest risk. So if you're having an LDL more than 115, for anybody who doesn't have any other disease, again, you're going to be at risk, remember that. But in what way are Indians different? India is always different. We have Operation Sindoor, Sindhu, everything. But Indians are very different. You will understand that the good news is that the UK Biobank showed that the LDL cholesterol is 10 milligrams lower in Indians. But unfortunately, our atherosclerotic coronary artery disease starts 10 years earlier. 10 milligram lower cholesterol, but 10 years earlier you have a disease, which is always bad. So Indians are very prone for atherosclerosis. So the Western standards may not apply. So the Lipidization of India came up with these guidelines. More or less similar, but only thing is that keep the LDL cholesterol lower than 50. All diabetics, LDL less than 70, remember, don't go by the lab value reference, which is ultimately wrong. They say 70 optimal. This is the biggest problem in the management with physicians. Don't look at lab references. Please tell each patient his disease is different. So 50 milligram LDL for atherosclerotic cardiovascular disease. Now when you look at serum cholesterol, all the patients come and tell you, doctor, I don't eat cholesterol, I don't eat diet, I don't eat butter, ghee, nothing. But my cholesterol doesn't come down. Why is it so high? The reason is, it's only 20% of your cholesterol that is based on your dietary factors. 80% your body synthesizes. So unless you cut the synthesis, you are not going to bring down your LDL cholesterol. So how do you cut the synthesis? I think the Honorable Chairperson clearly mentioned that the LDL receptors on the hepatocytes are important. More the LDL receptors, more LDL cholesterol is going to be drawn from the blood. So what happens inside the cell? You look at the cholesterol inside the hepatocyte. There is synthesis of cholesterol, which is blocked at two sites. The HMG-CoA reductase, if you block that, that is the statins. If you have the ATP citrate layers above that, that is the bempedoic acid. So these two drugs reduce intracellular cholesterol. When the intracellular cholesterol levels are low, more LDL receptors are manifested outside to pull in more cholesterol, and that is the mechanism of action of all these cholesterol lowering drugs. PCSK9 is something I will come to next. So when you look at low LDL cholesterols, it's very, very important to know how your LDL cholesterol is estimated. Because your LDL cholesterol estimation, most of the labs do a calculated LDL. Now this is a paper I published with about 30,000 patients data showing that if your LDL is less than 70, and if you do a calculated LDL,
nearly 40% your LDL is underestimated. So you must remember, go for a direct LDL estimation in patients with coronary artery disease, otherwise you'll have a false sense of security. All this said is well and done. Well said. So, but the point is, how many of our patients get controlled and reach these targets? All values are good. It's very nice to talk theory. The Lipid Association of India conducted a survey of about 10,000 patients all over India. 100 cardiologists were involved, and we found out that the target of 50 milligram was achieved in only 23% post PCI. This is very poor target achieved. Now mind you, these are all cardiologists with proven atherosclerotic cardiovascular disease. This is the status of affairs. So how do you overcome this problem? So first you have to identify what the problem is. So if you don't achieve the target, the first important thing is the inter-individual variability of LDL cholesterol. Now what is it? If you look at this, not all persons respond similarly. When you give 40 milligrams of rosuvastatin, nearly 26% do not achieve 50% reduction. Similarly, when you give 80 milligram of atorvastatin, 42% don't achieve this target of 50% reduction. So this inter-individual variability is very huge with statins, which we must remember. Second, patient-related factors. 60% of the patients go through Google and the internet and WhatsApp messages and say statins are harmful and they don't take statins. The truth is that the harmful effects of statins are much, much less. The true statin intolerance is only 7%, but 60% perceive it as side effects, and so the compliance is going to be poor. More the number of tablets, less the compliance, and ultimately physician's inertia, which is what I showed you in the LICARE study. Physicians don't treat the patients adequately. Second time he comes, first time you start him on 40 rosuvastatin, next time he comes, put him on a rosuvastatin with atorvastatin, with the aspirin clopidogrel, some gold combination, and don't reduce the cholesterol. This is what happens most of the time. So this we must understand is a problem. So you keep taking the cholesterol up and down. This LDL variability is a big problem, because LDL variability is associated with 42% higher all-cause mortality, 33% non-fatal stroke, 41% non-fatal myocardial infarction. It's very, very important. Variability of LDL is very bad. If the LDL comes down, how low do I have? I have patients in 10 to 20 milligrams comfortably walking around, no problem. I've left them on that. Please don't worry, it is very, very safe. And mechanism of this is very, very clear. As the LDL levels are higher, it accumulates in the cell, and depending on the kind of LDL, whether it is oxidized, non-oxidized LDL, this produces plaque rupture and subsequent events can happen. Sustained reduction has clearly been proven. Sustained reduction means you have a consistently low value of LDL cholesterol, reduces major coronary events, cardiac revascularizations and stroke, and that is also there. So both the cause is there, effect is there, proven. This is the important thing. If you start giving a patient 365 tablets a day, he's not going to take 365 days. Definitely he's going to miss 5 to 10%. And cardiac patients are on multiple drugs. More the drugs, less the compliance. That has been proven time and again. That is the concept of the single pill theory. But the monoclonal antibodies, which the honorable chairperson had said, they are given twice a month. So the number of doses are less, 26 injections. But what if you can give 1 injection, 2 injections a year? That is going to be much better. So to overcome all these problems, we go beyond the LDL receptor. What you do is the LDL receptor combines with the molecule called the PCSK9. Once it combines with the PCSK9, goes inside the cell, the LDL receptor is destroyed. So what do? You remove the PCSK9. How do you remove the PCSK9? You use monoclonal antibodies that bind with the PCSK9, that is evolocumab and alirocumab, which is what we have said, talking about. So what happens if you stop the production of inclisiran, stop the production of PCSK9? That comes inclisiran. So instead of having a molecule that is going to block the PCSK9, stop the production of PCSK9, that is how the inclisiran acts. It is a small interfering RNA. What it goes is, it goes through a specific mechanism where it has to act only in the liver. There is a ship called the GalNAc which takes it to the liver, gets inside the system, stops the RNA from being produced, and there is no production of inclisiran. That's how no production of PCSK9, and that is how the inclisiran starts working. How does it impact clinically? 50% consistent reduction in the LDL cholesterol, 50%, which is as good as a high intensity statin. So whatever level you start, it is going to bring down the LDL cholesterol by 50%, and that is going to be there. Time and again, several studies have shown even up to 57% reduction, and look at the person achieving target. Nearly 70% of patients once started on inclisiran achieve target or goal LDL cholesterol. This is something fantastic, which you have not seen, we are not seeing with the consistent use of statins also. Sustained reduction, we have already seen, has a reduction of MACE of 24%, 15% all-cause mortality, and risk reduction for myocardial infarction by 31%. So the evidence is there, the molecule is there, so it is important to make sure that it is there. Whenever there is an upward trend of variability, suppose your LDL keeps going up because of your reduction in statin doses, that is harmful. So the event rates are higher. But if your trend comes down, it's like over a period of time the LDL starts going down, that is going to be more beneficial and it is going to be very, very useful. Now more recently the Sweetheart study looked at just a combination of only statins or early introduction of ezetimibe with statins. Now what they found out in this Sweetheart registry was that if you start introducing the statins and the ezetimibe very early, sustained benefit and long-term clinical benefits and risk was much, much less. So what nature tells you is, it doesn't matter whether you give statins or not. How you bring down the LDL cholesterol doesn't matter. Bringing down the LDL cholesterol to lower levels is very, very important. And this is what the Orion trial did. Consistently, there are two arms. They did not give for 3 months, they did not give inclisiran. Then inclisiran was started. Look at the values. Once inclisiran started in both these groups, consistently steady, slow levels of LDL cholesterol are found. And how often do you give? The standard dosing regimen for inclisiran is day 1 you give the dose, which is about 300 milligrams, and second dose is given after 3 months, and after that once in 6 months you give these doses. Once you give this effect is going to be lasting and it is going to be consistently there. But mind you, even if you give a single dose, this brings down the LDL cholesterol. Even at the end of 1 year, there's a nearly 30% reduction of LDL cholesterol, which has also been documented before. So this offers a very high adherence and very, very safe. The safety is that the only side effect noted is the local side effect where it is given subcutaneously, otherwise nothing else happened. I keep putting this slide very often, the good, bad and the ugly slide. I'm sure all of you heard about the good cholesterol, which is HDL, the bad LDL and triglycerides, which is the ugly cholesterol. But what is more important is the noose and the gun here, which is the deadly cholesterol. What is the deadly cholesterol? Is the LP little a. LP little a is 6 times more dangerous than LDL cholesterol. Currently, there is no specific treatment for LP little a. In fact, a lot of new therapies, including the pelacarsen, is coming in, and once pelacarsen comes in, you'll have nearly 80% reduction of LDL cholesterol, but it has not come into the market as yet. This is going to come into the future. What about conventional therapies? Statins can actually slightly increase the LP little a. You have to be a little careful. But if you give inclisiran, 20 to 25% reduction can be achieved. Indians are more prone for LP little a elevation. So in all your patients with ASCVD, look at LP little a, and if required, probably that's an additional indication for using inclisiran. In the Asian subpopulation, the Orion 18, there was Asians responded by reducing the inclisiran by nearly 41%. So this is a remarkable reduction that can be achieved. Now this is the latest trial published called the Victorian Initiative, which is published in JACC in May 2024. So they said don't wait for too long, start inclisiran early. So when you start inclisiran early, there is a nearly 57% reduction in the LDL cholesterol. Look at this, clearly comes down. Next, if you start looking at goal achievement, less than 55% was achieved by nearly 72% of patients. So your goal is achieved very well, 57% reduction in LDL cholesterol. What about safety? What about statin? All the patients are already on statin. 90% of the patients were on statin. Only 6% actually withdrew statins. They called it statin intolerance. But in the conventional usual arm therapy, 16% had a reduction in LDL cholesterol and had a statin stoppage. So I think finally, ladies and gentlemen, we must all understand, you have a wonderful molecule which has 50% reduction, administered in your clinic, no compliance issues, consistent, safe benefits, no side effects. What are you waiting for? I think you have the power. You have the power of inclisiran with you, which shows sustained LDL-C reduction, excellent compliance, no variability, better tolerance, and I think with great power comes great responsibility. From Spider-Man, I will take it, that was He-Man. So I think you have to understand and follow this. Thank you very much for the patient listening.
Hello. Yeah. Thank you, Prabhakar. I think excellent exposition of the molecule. Now I think the Victorian has shown that how post-ACS patients also being helped. I think the rapidity of the LDL reduction with this molecule is quite excellent, unlike the conventional molecules. I think over and above the statin dose, when you start using this molecule, we get a good benefit. Are there any questions from the floor?
Madam, right now, evolocumab is available in India. Evolocumab Ripata is available twice a month. Every 15 days you have to give an injection. That is available in India. And oral PCSK9 is coming. Advanced trials have come in. It's probably going to take another 2 to 3 years to come into the market. Oral PCSK9 is also coming up.
I am asking, sir, what are the other physiological action PCSK has got and that is blocked by this inclisiran, whether that has any side effects?
No, that is the beauty of inclisiran. Inclisiran goes specifically to the liver. The GalNAc takes it only to the liver, it acts only in the liver. So if there is any other PCSK9 anywhere else, it doesn't touch because this acts in the liver. And in fact, if you give an inclisiran injection, 48 hours later you check the blood, there is no inclisiran in the body.
Inclisiran prevents the production of PCSK9.
Only in the liver.
That's the answer.
Prabhakar, what is the cost of the drug?
Sir, currently cost has come down. Actually, it was 1.2 lakhs when it was launched per dose. Now it is available direct purchase at about 90,000 rupees. And the companies have, all of them together, they found out after the first 1,500 patients, 50% of the patients were not taking the second dose. So now what they have done is, they are giving the second dose free. So effective cost is 45,000 rupees per injection.
If the patient is on high dose statin and HTMB, can we skip the 3 months dose and go to the 6 months? 0, 6, 12, like that.
Sir, this is, it can be done. I wouldn't say no to it because even at the end of one injection, at the end of 1 year, there are nearly 30% reduction of LDL cholesterol. So there will be some effect. But the studies have used this particular schedule and I don't think we can create. Maybe you can sponsor a study for this. We can say that it will work. It might work, sir.
And one of the pharma representative asked what price you should keep for the inclisiran. So one of the doctors responded, LDL you are saying lower the better. So the inclisiran price also should be lower the better. Then
nowadays we say lowest is best. That is also the best. Sir, mic kudunga sir, enakku kekla.
Can we stop statin or other?
No, sir. Everything is on top of standard therapy. Over and above the standard therapy, it produces 50% reduction. So if you stop the statin, that effect is gone.
Sir.
All you continue everything and give the inclisiran, sir. There is one company which actually gives you the statin for free if you buy inclisiran from them.
Sir, great presentation, very clear presentation, very easy to understand your lecture, sir. So one thing is I like to know, patients with the hypercholesterolemia of hereditary, how frequently you give, how long to give, how to maintain? Because these people will be continually having lifelong hypercholesterolemia. So those individuals, how start you early, how early you start, how frequently you give for those who are having hypercholesterolemia congenitally?
So today the concept is slightly changed, sir. It's a wonderful question. It's not as complicated as you normally ask, but thank you very much for that. And so nowadays what we say is start a triple combination therapy from day 0. Start every patient who comes to an emergency with ACS with 40 mg rosuvastatin, estimate and bempedoic acid. If you start all three, nearly 70% of the patients achieve target. So you're left with only 30% who don't achieve target. And within 1 month, you know that they're not responding. You can start inclisiran. And once you start inclisiran, the sensible thing is to go by the book and give it 0, 3 months and every 6 months thereafter. The second important thing is what Dr. Alagasan says, go by individual patient's response. Keep monitoring. If it goes up, start it. That's another intelligent way of doing it if cost is a factor. But I think science has got no answers for that.
Yeah, but I think what Prabhakar said was very important. First, most of us don't start statin, bempedoic acid and ezetimibe. I think you get good reduction in majority of the patients with these three. And now the current guidelines insisting on very, very low LDL, particularly in patients who have coronary disease. Most of the time I start all three in high risk patients. All three, 40 mg rosuvastatin or all three. And then the rest of the patients, I think, again, the cost is a big concern. So we have to, that is the only major concern. And people who don't tolerate statin is another area.
That's more of a myth.
Yeah, I use personally, it's very less. I see in hardly 1 to 2%, not many patients, as you said, but they are not able, they say I can't take statin at all because of severe fatigue or body ache, but it's not very common. But such patients, they prefer, people who can afford prefer, they specifically want either the evolocumab or the inclisiran. I think now inclisiran is more favoring than the evolocumab because of its ease of administration of once in 6 months.
I think normally we don't have the combination in US, but the first time they have the combination of statin, pemidinic acid, histamine in a single pill. Such is not available in India.
It's coming, sir. It's probably going to get launched in about 3 to 4 months.
Then the compliance will be much better.
It's going to be much better. My only request to all the physicians here is if a patient with coronary artery disease, post-PCA, like what Sangatwel says, comes to you, please don't tell them that you are on a high dose of statin or a combination therapy. You don't have to bring down LDL. Sir, in the Fourier trial, single-digit LDL cholesterol was seen in 500 patients. Nothing happened. They are all safe. So there is nothing like low LDL cholesterol. You don't have to worry about brain synthesizing because all the areas, there is a local synthesis of LDL cholesterol. So it's very, very safe to have low levels. Please continue high intensity statins, combination therapy, whatever they are on. I think we should close. Thank you, sir.
Thank you, Prabhakar,
Thank you
for
so
an
much,
excellent
sir.
lecture. Thank you.
Thank you, both the chairpersons and the speaker. I will move on to the next session. I think already you have heard of the lecture by the Dr. G. Sengutuvelu. He will be doing 10 years of our TAVI program from mission to milestone, a legacy of structural heart leadership. For that to chair, I called Dr. Parandaman, who is the retired professor of medicine from Rayapeta, and also Dr. Bhanumati is an obstetrician and gynecologist from Tirupur, and she is none other than the Mrs. of our beloved friend Dr. Muruganathan. Madam, I think we have seen Dr. Sengutuvelu coming up even from the first year, then second year, third year, every time there was an improvement in the technology and also the skill of the doing this TAVI. I think now he will project his 10 years experience. Over to the chairperson, I think you can introduce.
Yes. So great presentation. Sir, this lot of major surgeries now become many minor surgeries by innovative technologies. So the aortic valve replacement is a major surgery previously, nowadays become minor surgery, it was a minimally invasive surgery. To talk on 10 years of TAVI program from mission to milestone and legacy of structural heart disease leadership by none other than very able, eminent, skilled personality, Dr. S. Sengutuvelu is here to enlighten us about the milestones in this career of TAVI. Go to Sengutuvelu.
He is the pioneer in India also.
Yes.
Good morning. Thank you very much. And the TAVI program was starting the TAVI program was it was not a very, very difficult journey, I would say. But now I'm enjoying the fruits of that seeds what I placed 10 years ago. It was a very, very challenging time when I started the procedure, and we went through a lot of challenges, sleepless nights, sleeping with the patient, so many challenges we had. But I think TAVI has now become a very, very, very happy to say that today TAVI is a very well established procedure. We do TAVI almost every day. Yesterday morning we did, just procedure took half an hour and the patient is going home today, and tomorrow morning we have a TAVI. So it's become a routine procedure, and it's become very much less complicated, and it's easy for the patient and for the doctors. So having said that, we know aortic stenosis is really a significant clinical problem. I know we all know untreated aortic stenosis is one of the major causes of sudden cardiac death. And the mortality is very high in patients who don't get treated aortic stenosis. So almost if a patient untreated aortic stenosis, 75% of them die in 2 years and 50% of them die in 1 year. So the mortality is very high, and once they develop symptoms, it's very important to immediately refer them to a higher center for valve replacement. So the prevalence is quite common. Aortic stenosis is not, we are seeing now very common in the sense that as the population ages, the incidence also increases, particularly in those of 70s and 80s, and patients who have congenital bicuspid stenosis, which is 1% of the population, very common. Those patients develop aortic stenosis yearly, even in their 40s or 50s. Sometimes they develop severe aortic stenosis. So it is almost more than 14.5 lakhs suffer with severe AS, and they classically have symptoms of angina, syncope, and heart failure. And so the prevalence, as I told, increases with age, and over the age of 75, 3% of the population have severe aortic stenosis. So the aortic stenosis, we know that when I was a medical student, I never ever thought a valve can never be taken through a small catheter and replaced in a valve. Such a big valve, how can it be replaced? But thanks to Professor Alain Cribier, who did the first TAVI in the world in 2002 in France. Actually, he was a great pioneer. He worked a lot of animal studies, and unfortunately, we lost him in 2024 last year. So we celebrated the time of TAVI, almost 20 years of TAVI when he did. And I was very fortunate to be with Alain Cribier, in Professor Alain Cribier in Rouen, France. And those was many years ago. In 2021, we were there for some time in the University of Rouen in France. And subsequently, I had many occasions I was able to again see him later on in many other places. So the guideline, now fast forward, the TAVI has now become a very standard procedure, and now it's become class 1 recommendation for severe symptomatic aortic stenosis. And if they have a severe aortic stenosis, particularly in the age of above 65, we should consider TAVI as an option. And currently there is a new article which is now published, and now the guidelines are going to probably change. Even in asymptomatic aortic stenosis, if you do TAVI yearly, these patients can be superior to clinical surveillance in reducing the incidence of death or stroke or hospitalization. So this is a very important new publication from New England Journal of Medicine. So again, we need to identify patients who have severe aortic stenosis, and those patients will benefit even if we treat them yearly. So this is fast forward to today, 2022. I met him again, Professor Alain Cribier, before his passing away. So our program started, I started looking at TAVI very early, but unfortunately we didn't have access in India. 2013 I went to Switzerland, and 2014 I went to France again. 2015 we were getting trained in TAVI a little bit abroad, but we didn't have anything in India. So how we started, our first case we did in 2015, 10 years ago. And that time, though no valves were available in India, we had to find a suitable patient who was needed of, because surgery was almost impossible for him. Patient had critical aortic stenosis in the ICU bed. Surgeons were not willing to operate, multiple comorbidities. We had to get a special permission, write to DCGI and the Drug Control General of India, saying that this patient has no option, he's left, he will die. And they gave a special permission to import the valve. And we took a license, we got a customs license and got the valve imported. And that is how we started the first TAVI, when the TAVI was then there was, then first 5-10 cases were very challenging because we were just learning, and we had to get some proctors who were abroad. They came and taught us, and slowly we started learning. 2016, several new valves were approved, and 2016 we got the US FDA valves came to India, and 2017 was again a landmark, I would say, because the first Indian valve, the first in-man study was started. We were part of the study. We initiated the first in-man study, and then the valve got Indian approval, European approval, and commercially available. And today I am proud to tell you that again this valve is now being used all over the majority of the countries in Europe, in South America, except the US. In most of the countries around the world, it is now Indian valve is available. In fact, I was also quite fortunate to go and proctor some of the cases in Spain, showing the valve to them. So subsequently, subsequently we went to the US in 2016, got our training in Cedars-Sinai Hospital, Los Angeles, and then we created our own heart team in India. Creating a heart team was our own members, the surgeon, the interventional cardiologist, the imaging specialist, all together form the team, because it's important to discuss a particular patient's history, anatomy, and find out which is the best suited replacement, whether surgical or transcatheter options. we have to decide that we have taken, based on that we take a decision. In fact, I got best practices around the world. Whenever I travel, I used to, for example, in Japan, when I went to Japan, I found that the patients were discharged the next day. And I took a video of the anesthetists and everything and brought to our anesthetists in Apollo and tell them to incorporate the same thing in our hospital. So basically the best practices around the world were incorporated into our system, and then we decided to do TAVI. So the TAVI basically earlier we were only concerned of the big 5 complications. When we started in the first 5 years, our strategy was to reduce the risk of bleeding, reduce the risk of stroke, reduce the risk of paravalvular leak, that means aortic leak in the side, and heart block and the renal failure. But today we are more focusing on, because complications have significantly come down with our expertise as well as our new valves available. Today we are more focusing on TAVI durability. We want the TAVI durability, which means when we are implanting for young patients, we were initially doing for old patients, now we are focusing more on young patients also, like above 65 years, but less than 65 we still send them for surgery. And we focus on long-term valve durability, like using the best type of valve, no pacemaker, etc. So we refined our techniques to implant the valve in position where you have the less risk of pacemaker, so landing appropriately. The stroke risk is about 3 to 4% and TAVI, but though in our practice we were seeing very much less amount of stroke. But this again, now we have filters to protect the brain during stroke, and it comes with an additional cost, so we don't recommend for every patient. But I have seen that in one of our patients, I can remember, I can show this picture where we removed a chunk of calcium. This is probably a calcium which was embolized from the aortic valve and went to the brain. I was extremely happy when I saw. Fortunately, we were able to use a protection device. Otherwise, this person would have developed a major stroke. And I took this one and from the filter, from the carotid filter, and felt it in my hand. It was like a stone. So clearly, it was a calcium which was dislodged from the aortic valve during TAVI and caught in the filter in the brain. So, but this is only out of many patients we got this in such a big chunk in only one patient. So it's not common, but it can happen. So using a filter can save such patient from major stroke. So again, there is no big evidence because they are mounting now they are routinely using the filter doesn't really help. To high risk patients, maybe we use selectively because there is no big evidence on routinely using filter will reduce the risk of enabling stroke. And also now we are preparing. See, the natural anatomy, if you look at the aortic valve, you have coronary arteries arising from between the commissures. There are 3 commissures. There is where the valve originates. So this is the left coronary artery, the right coronary artery. It arises between the commissures. So when we put a valve, the valve commissures also will be placed exactly that commissure. So creating a natural anatomy like how a native anatomy looks like will give a long-term better result. So we are looking at all that, and for reaccessing the coronary arteries after TAVI, if required to do second TAVI later on. So we always think now when we plan the first valve, which is the best type of the valve, and how can we look at the patient's lifetime management. We call it lifetime management because first time what do we plan, second time what do we plan, in case they develop later on what do we plan. So this is what we think and decide which type of valve. And for failed surgical valves today, TAVI is the first option because second surgery is completely ruled out. So we routinely do that. And we also nowadays started doing without contrast, particularly because many patients with severe aortic stenosis and comorbidities have chronic kidney disease or acute renal failure, and remitting contrast is very useful. So we use both MRI and sometimes we use ultrasound, and we do it without giving contrast. The other area where TAVI is expanded is severe aortic regurgitation. The major challenge with severe aortic regurgitation is because there is no calcium. We know calcium actually helps to anchor the valve in place, and when we don't have calcium, we tend to use oversized valve, and different types of valves are now available where we can use it for aortic regurgitation. And this is one of the cases I did in Kolkata, where we did simultaneously mitral and TAVI. So where we did an aortic valve and a mitral valve. Mitral valve interventions are now also becoming very popular. I'll later talk about it this evening about the mitral therapy, which is one of the rapidly expanding after the aortic valve. So this is again, now we have the intravascular lithotripsy. Through the femoral leg approach, if the arteries are diseased like this with heavy calcium, we can still go through the leg and perform the TAVI and send the patient home. So different types of valve are available. This is called valvolute valve, called self-expanding valve. Then we have the Indian My valve. Now today, if we fast forward now, the Sapien valve, the challenging Navitao valve, and then we have the Hydra valve, then we have the Accurate Neo valve. So now today we have about 7 or 8 valves which are approved and available in shelves. So we can use any valves. We have two Indian valves, namely the My valve and the Hydra valve. Then we have the valves from the other countries. And also we sometimes have to treat the associated coronary disease. So we have to do stenting, complex PCI and TAVI together. So we have a plan and strategy on how to implement both. And we have now several imaging advances, we have the new cath lab systems are now adapted to TAVI planning, and we can have these kind of images. This is aorta, this is the left ventricle, and it can help us to identify where the valve we position. And these are the we can superimpose the CT scan on the cath lab images. So the CT scan with the cath lab can be superimposed. And then you can see the valve, I am superimposed, I am taking the valve inside through the aorta, which is superimposed, and you can see through the aorta, and then placing it in the aortic valve, this is the old aortic valve, and see the left ventricle is blue color, the orange color is the aorta, and you can see the coronary arteries here, and we place the valve and implant the valve using these imaging softwares. These are all color coding, gives much more, exactly you can see the aortic valve, the left ventricle, and this is a CT scan which is color coded. In difficult anatomies like bicuspid valve, we also sometimes use a 3D printing model where we print, 3D printing is done to know whether we can use a specific type of valve, because every anatomy is different, we know, and now we are trying to do a tailor-made solution for each individualized patient. So every patient we know is different, so we need to, because we can also predict the complications and then plan appropriately. So post deployment, we can outside with the 3D model, we can check whether it is available. And we can also do a computer simulation where we can use different sizes of valve, different types of valve, and see which is the best valve suited for that particular patient. So the vascular space also is improved where we have new devices to make them mobile the next day. And again, the discharge is now the next day. Most of the time it is next day, and 80% of the patients are local anesthesia. So several advances, even our training has gone very high. We have now simulation labs, we train people on TAVI, we have animal models as well as training systems where we can train, we routinely train people on TAVI. So to conclude, aortic stenosis treatment has come a long way, and the last 10 years have been very rewarding for us, where we have a huge number of patients have been benefited with our program. We look at now treating more younger patients like age 65 years with excellent outcomes and planning for their lifetime management. And the new generation TAVI devices with additional tools and imaging modalities have really helped us to achieve the best hemodynamic result with good long-term results. Thank you very much.
Great presentation, sir. Real wonderful learning. It's amazing to learn that Indian valves are being used by the other countries as well. And I'd like to know whether when you're doing the TAR, replacing the aortic valve, what about the native valve? You remove the native valve or incise it, or whatever repair you do on that? Okay.
The native valve actually is the sides, when we put a valve in, the native valve is plastered to the sides. There is a huge sinus of Valsalva. If you see the aortic valve, there is a huge sinus of Valsalva. So the native valve goes in the sinus of Valsalva. So the risk of coronary occlusion is high if you have a large native leaflet. So we always look at the CT scan and see what is the length of the leaflet, what is the height of the coronary artery, what is the width of the sinuses. The sinuses are wide, generally the native aortic valve goes into the sinuses.
Chances of infected endocarditis or thrombus formation is there, sir, in that cases?
Yeah, exactly. Like any other valve, with like a post-prosthetic valve, the risk of infected endocarditis exists, and we have to look at the risk, and particularly when they go for any procedures, we need to look at and ask them to have prophylaxis for infected endocarditis. In my practice so far, I have seen one patient after TAVI developing infected endocarditis, and that patient had actually had probably, he had a severe multiple dental treatments, and he didn't take care of his valve properly. And he came, and finally we have to remove the valve. It's fully, he had root abscess, and there's only one patient I saw. But it is possible, it can happen.
I think probably we get the future, the drug-eluted,
Hello?
the drug-eluted valves may come?
No. See, future we have polymeric valves.
Okay.
The polymeric valves are valves which, the problem of valve is only durability. See, when you take animal tissue, the valve tissue is still from porcine and bovine tissue. So what we do is, there is a frame, metal frame, where we take pericardial tissue from the bovine heart, and they stitch the valve. That is how stitch valves are made. All these valves are bioprosthetic valves. I'm not talking about mechanical valves in young patients. Bioprosthetic valves eventually start degenerating. How like a normal valve degenerates, the same tissue valves, all the tissue valves start degeneration over time. So they are doing a lot of calcium treatment so that there is no calcium adhesion to improve the leaflet longevity. Durability is a major concern. That's why these tissue valves fail over 10 to 15 years. So the long term, the goal is to have a polymeric valve. You have polymer leaflets which will last a lifetime. So that is what people are working in. There are already studies which are going on with polymeric valves.
When you select a candidate for TAVR, do you go by pressure gradient measurement or by symptoms?
Very, very important. So many patients, they can't go by symptoms. Severe aortic stenosis starts from mild, moderate, becomes severe. Very often they don't have symptoms. Only patients who develop symptoms develop at late stages when they have severe aortic stenosis or develop LV dysfunction, and they develop symptoms. And very often they deny symptoms also. Because they restricted the activity once they go with the risk. But we have to identify now with the available evidence. We have to offer treatment to patients even if they are asymptomatic. So if they have severe aortic stenosis, which means the mean gradient is more than 40 millimeters.
40 itself.
40 millimeters, more than 40 millimeters mercury. Or by echo, if you have the aortic velocity more than 4 meters per second, these are the patients we have to send them for. Or if the aortic stenosis is rapidly progressing, for example, the velocity increases, aortic velocity increases more than 0.25 centimeters.
We told to all the practitioners that some people think that they can wait up to 70-80% pressure gradient difference, or till the patient develops effort syncope, effort angina, effort chest pain.
You're right. If they have symptoms, they must undergo. But very often when we see patients, they have a higher gradients. By then, when they can make a diagnosis.
To do it when the gradient
when the aortic stenosis is severe, they should go. If they have severe symptoms, it's strongly recommended. The earlier the better, because the risk is higher.
Thank you. Thank you.
Because I have one patient who, like Sir was telling, 50. How frequently?
So as I was mentioning earlier, the data still, guidelines still recommend only when this aortic stenosis develops symptoms, you have to intervene. That was previously where you have to wait, you have to screen every 6 months to look for symptoms. But today, as I showed you an article in New England Journal of Medicine, even early TAVI, before they develop symptoms, if they have severe aortic stenosis, which means a severe aortic gradient by echo, these patients benefit from early aortic valve replacement.
Thank you so much.
I think in our country it's very difficult to see that when you are going to screen, when you are going to subject the patient for echo or other things. Unless the patient is well educated, it's very difficult.
Sir, whether a patient had previous endocarditis is a contraindicated, sir? Or
Very nice question. Generally, infective endocarditis is a relative contraindication to TAVI, because infective endocarditis might have abscess, vegetation, or underlying infection. So surgeon has to manually remove it, debride abscess, remove the agitation, and then place a valve, which offers a better hope in terms of recurrence of infection. So generally, infective endocarditis is a contraindication for transcatheter procedure, but there are situations where there is a healed endocarditis, or we treated them adequately, and where the patients cannot undergo surgery at all, then we do take it. But generally it is only surgery. It's not transcatheter if you have infective endocarditis.
Assessment of aortic stenosis is not so easy.
Yes.
As he said, the above 4 meters velocity, peak gradient, peak velocity, and mean gradient of about 40. Only 60% of the patients come with that findings.
Correct.
If they come with findings which are typically severe aortic stenosis, then the decision is easy. Even in these patients, if they are asymptomatic, we should not leave them alone. One thing is to be sure you can do a treadmill test to find out whether they become symptomatic after exertion. The other thing is there are certain echocardiographic criteria like global longitudinal strain. If it reduces below -15, then the mortality is going to be higher. So they can be submitted for surgery even or TAVR even before they develop the symptoms. The other thing is you can do an MRI, which will show the subclinical fibrosis. If they have fibrosis, they are going to develop, say, left ventricular dysfunction, cardiac failure earlier. So these are the cases where it is directly severe aortic stenosis. 40% of the patients have what is called low flow, low gradient, severe aortic stenosis. In that itself, there are three types. One is the one with reduced ejection fraction, one with normal ejection fraction. There is another group also they have described. So all those confounding factors are there. So if you are sure that the aortic stenosis is significant, we should go ahead.
Thank you, sir.
I think it's very important to diagnose early, and as Professor Alagasan said, I think echo also is advanced, and you have to properly look at an echo because gradients may only show in severe elevated dysfunction. You may not miss the gradient and may require a dobutamine echo or other echoes to confirm the diagnosis. So I think very important to echo is critically important for diagnosing and deciding the need for early intervention. Thank you.
Thank you.
Thank you very much, sir, for your elaborate discussion on TAVI and wonderful presentations.
I think we will move on to the next session. This again, I think let him come. Well-known endocrinologist and diabetologist, and her talk is mainly on hypertension and women. I think both of you can stay there. We are scarcity of chairpersons. Yes, I think you can give it to Madam. She can, because she being an obstetrician and she would have seen all. And the only thing is, they blame the man that you are not looking after the woman, therefore they get lot of problems. And another thing, vice versa, அது உங்க வீட்டிலே இருக்கும் இல்ல. Therefore, there are so many differences between men and women in hypertension that one should remember, and the complications are more with the women. I think with this, over to the chairperson.
Hello, good morning. Dr. Jayashree Gopal, Director, Diabetic Endoc India, Chennai, Institute for Diabetes, Endocrine, Metabolic and Lifestyle Health. And she is a founder, trustee of Diabetes India Foundation, Preserving Health Across Generations, Senior Consultant Endocrinologist and Diabetologist, Apollo Hospital, Chennai, Vice President, Endocrine Society of Tamil Nadu and Puducherry, EC member of API Chennai, EC member of Chennai Menopause Society, recipient of the Vocational Excellence Award from Rotary Club, awarded Dr. Sam G.P. Moses Oration at the API Chennai Chapter Annual Conference. Welcome you, Madam, for the conference.
Thank you. Thank you. Good morning, everyone. Thank you, first of all, to the organizers, Dr. Muruganathan, for this very kind invitation. So I'll be talking about some very basic facts regarding hypertension in women. Like Dr. Shanmugam said, there are some nuances about managing and understanding hypertension in women that we all need to be aware of. These are some of the facts that have been published over the years in various journals. One is that postmenopausal women constitute the highest population burden of sudden cardiac death. So 13% of all deaths and 50% of all coronary deaths occur in postmenopausal women, sudden cardiac death. An average life expectancy of a woman with hypertension is about 5 years shorter than a woman with normal blood pressure at the age of 50 years. The WHO has noted that the highest prevalence of hypertension occurs in low and lower middle income countries in Africa and Asia, and according to this, of course, you will all be familiar with this, it is the most important cause of death and disability in India. So these are some facts about basic hypertension. This is data from the National Family Health Survey, most recent one, the NFHS 5, which was done in 2021. Overall, the national prevalence of hypertension was about 18%, 21% men, 14% women. So the overall prevalence is lower in women, and it appears that women as compared to men are more likely to be screened, so 80% versus 64%, more likely to be aware, 46% versus 26%, more likely to be on treatment, 16 versus 12, and more likely to be under control, 11 versus 6. Now, of course, there are many other cultural factors, social factors in our country, but this is the data from the NFHS survey. There is a baseline difference in the BP distribution. In general, women tend to have a slightly lower BP. So you can see this brown bar for the systolic on both, and the blue is for the men, the systolic and diastolic. And you can see that in general, women tend to have a lower blood pressure, particularly at a younger age. And obviously, one thing is in general, women with hypertension are more likely to have central obesity and CKD. Men are more likely to be smokers and have dyslipidemia. A 10 millimeter rise in systolic blood pressure increases the risk of CVD in women by 25% and increases the risk of CVD in men by about 15%. Also, studies have shown that women are more likely to have a nocturnal non-dipping of blood pressure, which we know is an independent risk factor for CVD, and a more variable 24-hour BP control. So there are some differences in the way blood pressure exists in women. I spoke a little bit about the CVD complications being higher in women. It has also been noted that women with hypertension tend to have higher chances of developing LVH. Of course, in the brain, white matter hyperintensities, which means they are more prone to develop CVA. Though the data or the information regarding CKD is a bit, CKD may be more, but the progression to end-stage kidney disease is actually more in men as compared to women. It looks like the threshold at which people develop complications with blood pressure tends to be lower in women as compared to men. So this, what we call the complication threshold, is a linear line. For men, it starts, the systolic blood pressure being above 130 is when the risk of incident cardiovascular disease seems to increase, whereas for women, it starts increasing at a lower range, maybe around 120 it starts to go up. So again, this is something we need to keep in mind when we are considering how well we are going to manage the blood pressure. Of course, women in general are exposed to certain physiological changes and certain other pathophysiological changes across their lifespan, which increases the risk of developing blood pressure, and I'll talk about some of these factors. In a very young woman, someone below the age of 25 who is presenting with high blood pressure, we need to consider secondary causes. In reproductive years, obviously things like becoming pregnant itself is a risk factor for developing hypertension and getting onto the contraceptive pills, assisted reproductive technologies, in the menopause, going on to the hormone replacement therapy, presence of vasomotor symptoms itself is a risk factor for developing hypertension in women. We'll start with PCOS. Now, PCOS increases the risk of hypertension. These are sort of, it's a meta-analysis, various other meta-analyses have been done, but overall there seems to be at least a 1.5 to 1.7 fold increase in the prevalence of hypertension, even in young women with PCOS. And obviously this is related to the insulin resistance, inflammation, and the metabolic syndrome and the increase in the visceral adiposity. However, in young women, we do need to rule out these rarer causes. We need to have a high clinical index of suspicion, fibromuscular dysplasia, Turner syndrome, and coarctation of the aorta, and keep these sort of physical exam findings in mind. Look out for an epigastric bruit, look out for a brachiofemoral delay in a short person with webbed neck. You need to have, remember, Turner syndrome need not always present with amenorrhea. A Turner syndrome may develop, a lady with Turner syndrome may develop amenorrhea only after the age of 30 or 35. They may present at a young age with just cardiovascular disease or hypertension. So we need to have a high index of suspicion for these rare causes. Any person with hypertension at a young age, at least once, I think it's useful to do a potassium level to rule out the possibility of primary hyperaldo. Younger people respond much better to treatment for primary hyperaldo. The longer that they have high blood pressure, the more difficult it is to reverse it, even if we treat the primary hyperaldosteronism. When we move on to pregnancy, again, there are some changes which increase the risk of hypertension. One is that there is an increased sympathetic tone, which causes renal vasoconstriction, water retention, increasing the volume, and that increases blood pressure. The increased estrogen production from the placenta also causes RAS activation leading to vasoconstriction, and in some women who develop placental dysfunction, there is a pro-inflammatory sort of milieu that is set up which further increases the risk of blood pressure. We know that pregnancy is a state of sort of a stress on the vasculature, and some women it develops to a greater degree. Preeclampsia is defined as a pregnancy complication in which women develop hypertension and proteinuria after 20 weeks of gestation. It is believed to impact anywhere from 5 to 8% of all pregnancy. A woman who has had a history of preeclampsia has a 3 to 4-fold higher risk of chronic hypertension, 2 times higher risk of cardiovascular disease and stroke. And in fact, an earlier onset of preeclampsia before 32 weeks is more detrimental. This woman is 5 times higher risk of CVD in the future. And half of all women who have preeclampsia develop hypertension by 10 years after the delivery. Why this is important? Again, when we are looking after women, they may be coming to us for some other reason. If they tell us that they have preeclampsia, it is important that we monitor their blood pressure at least 2 times a year or 3 times a year and explain about the risk of hypertension in the long term. Getting onto the contraceptive pill increases the risk of hypertension. So you can see that compared to a woman who's never used OCPs or a woman who's just used OCPs for a year, a person who's been on even 1 to 2 years of OCP or more than 2 years of OCP is more likely to develop hypertension and prehypertension. BP is well controlled. Think about using only progesterone only pills for contraceptive or other purposes. And if they don't have well controlled hypertension, definitely it is a grade 4, which is absolutely not useful. Even if they give a history of high blood pressure during pregnancy and the current blood pressure is measurable and normal, even then a progesterone-only pill is considered more beneficial as compared to the combined OCP, particularly if they have other risk factors for atherosclerotic cardiovascular disease. And we are seeing this so often even in women in their 30s and 40s, an older lady, smoking, diabetes, hypertension, dyslipidemia, consider using a progesterone-only pill as compared to a combined OCP. And any person who is on an OCP needs to have blood pressure monitored at least 2 times a year. Various societies have recommended various types of guidelines, but keep it in mind, particularly in people who are on OCP long term, monitor their blood pressure. So this lady who's been through, say, PCOS and pregnancy and possible use of OCP now enters menopause, and she is definitely at higher risk of hypertension. So you can see here nicely that up to the age of about 55, women, which is this black bar, have a lower prevalence of hypertension. After the age of 55, the prevalence of hypertension increases in women compared to men. So you see the sharp cutoff, which is similar to the slide that I showed earlier. The falling estrogen levels activates the RAS and the sympathetic nervous system. Remember, I told you that estrogen actually activates the RAS, which is the synthetic estrogen. So the synthetic estrogen in OCPs activates the RAS and in the SNS. Drop in the natural estrogen level does the same thing. It activates the RAS and the SNS. So estrogen, we have not yet found an estrogen which exactly mimics. There are various types. Now there is one called estradiol, which is being used, which is considered to be the most similar to our body's natural estrogen, but we are not there yet. We don't yet have an estrogen which very, very closely mimics our own estrogen. The other thing that happens in the menopause is endothelin, which is a vasoconstrictor, increases, further increasing the risk of hypertension. Contrary to belief earlier, HRT does not protect against hypertension. And because again with HRT we are going to use synthetic estrogens, you further increase the endothelin levels, you further increase the risk of hypertension in the menopause. What about management issues? Are the targets different? Are the outcomes different? What about medication? Is there any sex difference? Do the targets need to be different? Currently the guidelines are not recommending it. Maybe they will in the future. There are some studies which suggest that you have better cardiovascular protection with a lower daytime blood pressure in women, less than 125/80 as compared to 135/85 for men, and a lower nighttime blood pressure, less than 110/65 in women compared to 120/70 in men. But this has not been proven in long-term studies. Maybe we will get this in the future as more and more women are developing hypertension. What about the large antihypertensive trials? Have they shown any sex differences? Overall, no major sort of big difference in the way So the same antihypertensive medications have a benefit both in men and women. However, some little things which came out. So for example, in the LIFE trial with losartan, men and women responded equally well, showing that losartan is superior to atenolol for CV and stroke outcome. But overall in the trial, it looked like more women required hospitalization for angina. In the ALL-HAT trial, it looked like there was more CVA with ACE inhibitors compared to amlodipine. So amlodipine seems to be more protective for CVA in women. And similarly, in the VALUE trial, valsartan with amlodipine, CV outcome was also more superior with women. Other big studies, including the SPRINT trial, all of them did not show any big difference in terms of outcome. So currently, we don't have any strong data to say that hypertension in women has to be managed differently, very differently from men. What about antihypertensive medications and sex differences? There are some pharmacokinetic, pharmacodynamic differences. For example, ACE inhibitors. In women, the non-classical RAS pathway is activated more as compared to men. Men, the classical RAS works more. In women, this gets activated more. They tend to have a lower level of the classical ACE activity in women, but clinically it doesn't seem to have an effect, apart from the fact that women have 3 times more likely to develop a cough with ACE inhibitors compared to men. ARBs, maybe the telmisartan concentrations are noted to be higher in women compared to men. CCBs, I did mention earlier that women respond better to amlodipine in terms of BP reduction and protection against CVD and CVA, but they do develop more edema. Beta blockers, again, no big differences in pharmacokinetic, pharmacodynamics. Some beta blockers may work better for women because of some more drug-drug interactions, but all of these are very, very small studies and more postulations. I don't think we have enough data to say you have to do this and you don't have to do it. Diuretics, important to keep it in mind because women more frequently develop hypokalemia and hyponatremia. This is important, particularly when we are using a diuretic in elderly women, frail women who are also going to be on SGLT2 inhibitors. So to summarize, hypertension in women, I spoke about how in general the mean BP is lower in women than men. Estrogen, natural inherent estrogen has a beneficial effect on vasculature and the RAS pathways, whereas synthetic estrogen has the opposite effect. The prevalence of hypertension tends to be remaining higher in men till menopause, after which there is a steep rise among women. More variability in the daytime and non-dipping at night is seen in women, and they are more likely to develop LVH, arterial stiffness, and more likely to develop a stroke compared to men. Adverse effects may be more in women with the same level of blood pressure, but currently guidelines do not focus on differential BP targets, and some gender differences do exist in the effect of antihypertensive medications, but not enough to say that you have to do this or do that. So that is my final slide. I shall stop here and happy to answer any questions.
Thank you very much. Thank you very much, madam, for a brilliant presentations, a lot of informations.
Thank you.
From the learned points are excellent. And we know that you already mentioned that natural estrogen has got a protective effect on the vasculature, both progesterone and estrogen. But artificial progesterone estrogens are not that good and increase the blood pressure, increase the activation of RAS. Is there any specific reason for that, madam?
The structure is very different. Even though we think they are binding to the estrogen receptor, the way they will modify the estrogen receptor and the downstream pathways that are going to be affected because of that, that's what I'm saying. We don't yet have something that exactly closely mimics. At the end of the day, it is a different chemical.
Different chemical, yeah. And regarding the telmisartan, in reproductive age group, usually you should suppose not to use because at any time they become pregnant and it may lead to complications of the fetus. So generally you don't use, but your study shows that telmisartan is safer. So
this is across all age groups. I'm not saying it's safe. This is across all age groups.
Okay. So preferred drug is only amlodipine and CCBs, other CCBs.
Yeah. Particularly in a woman planning pregnancy, yes. I would say amlodipine is the safest.
Thank you very much, madam.
Ma'am, in elderly women, what should be the target systolic BP? And what is the commonest side effect you come across?
So the blood pressure target remains the same, 130/80, in any same as men and women. There is no difference in targets as yet. But what we are beginning to understand is a 130/80 target for a woman may not be enough because women develop complications even at lower BP levels. So a woman who's got, say, multiple complications, if she's able to tolerate, try to target a BP of 110/70, because studies have shown that lower BP in women seems to have lesser chance of developing complications.
What are the side effects you come across in elderly women, ma'am?
Elderly
with the
women.
hypertensive drugs.
I was just talking about the thiazide diuretics. I mean, apart from that, I can't really.
Alpha blocker.
Alpha blockers, definite drop in the postural drop in the blood pressure.
Any drug interaction?
That is completely outside. Major, I can't
in
think
elders,
of anything.
elders, ma'am. In elders, they are taking lot of drug for cardiac, for lipid. With that, whether the hypertension drug has any side effect, any interaction, ma'am?
The only thing I would caution, I think, was also mentioned by the cardiologist who spoke from Bombay. With SGLT2 inhibitors, stop the diuretic because they're going to drop. And I don't know how many of you noticed that in the summer, a lot of the elderly people came in with weakness and they all had a low sodium. And so that required a stopping of the SGLT2 inhibitors for some time. Dehydration, low sodium is much more common with diuretics and SGLT2s.
Then what is the best drug for them for their sugar control, ma'am?
SGLT2s need to be there for cardiac protection, but temporarily withholding it at certain times is prudent. The safest and best tolerated is probably going to be DPP-4 and metformin, but you do not get the cardiac benefit that you get with the SGLT2.
Thank you.
I think if there are no questions,
Thank you, madam.
we can.
Thank you.
Yes.
Thank you.
Thank you. And for want of time, we'll go fast and try to be short and one. We got an important one, the cardiorenal syndrome. We got two chairpersons, one Dr. Naveen, is the consultant diabetologist from Kolattur, Chennai, and the other person is none other than everybody would have known, Dr. Namita. He is one of the professor of medicine in MMC and also taking part lot of in teaching sessions also throughout APA and also in various organizations. Over to the chairperson and the speaker, Dr. Vijaya. She is an American board certified internist and nephrologist, chief nephrologist at VHS Multi-Speciality Hospital, VMS, and 20 years of clinical nephrology experience. Over to the chairpersons.
Thank you, sir. Thank you for the wonderful opportunity. At the outset, let me thank Dr. Muruganathan, sir, for the opportunity to be here today. And over to you, ma'am, for the cardiorenal syndrome, as we are running short of time. We are not taking much of your time.
At the outset, I'd like to thank the organizers for giving me the opportunity to speak here. It's quite a complex topic, and I'd see whether I can rush through it in the interest of time. So what do we mean by cardiorenal syndrome? It's a condition that describes the interaction between the heart and the kidney. Can you come up here? It's going to somebody else. But how do I move it here? इसी पे करते हैं? Cardiorenal syndrome is a condition that describes the interaction between the heart and the kidney, where the acute or the chronic dysfunction in one organ can lead to an acute or chronic dysfunction in the other. It's a complex bidirectional hemodynamic crosstalk between the kidney and the heart with changes in both neurohormonal and inflammatory markers. I can't see anything. Yeah, okay. Yeah, this one. So what do we know about the interaction between kidney and heart failure? Upward of 60% of the patients admitted for acute decompensated heart failure have CKD as defined by an eGFR of less than 60. CKD is one of the strongest risk factors for mortality and cardiovascular events in decompensated heart failure. Acute declines in eGFR, which is defined by increases in creatinine of more than 0.3, or an eGFR decline more than 25% are observed in approximately 20 to 30% of patients admitted for decompensated acute heart failure. There is significant maladaptive activation of the sodium retention pathways, which is present despite the presence of hypovolemia. Many of our patients are discharged with residual volume and therefore lead to poor prognosis. The finding that there are unmeasured uremic toxins in many of these 6 patients and ongoing neurohormonal activations which cannot be controlled continue to be a challenge. So based on the classification, we have 5 types. Type 1, acute CRS, where there is an acute decompensation of the heart leading to an acute kidney injury. Type 2, where there is a chronic decompensation of the heart, chronic heart failure resulting in chronic kidney disease. Type 3 is an acute renocardiac syndrome, where an acute kidney injury results in acute heart failure. Type 4 is a chronic renocardiac syndrome, where the chronic renal disease results in chronic heart failure. Type 5, usually there is a systemic process involved, which may involve both the heart and the kidney, like in amyloidosis, sepsis or cirrhosis. The interest of time will be probably focusing more on type 1. So in this slide, you see a very simplistic diagram of an acute decompensated heart failure, where the mechanism is initiated at this stage with ischemic heart disease, valvular heart disease or ventricular interdependence, leading to arterial underfilling and problems in the kidney with acute reduction in GFR. This acute reduction in GFR sets into motion sodium retention and fluid retention, compromises the endocrine function and decreases kidney clearance. This is a bidirectional flow where there is venous congestion which affects both the cardiac and the renal function, and as they deteriorate, it increases venous congestion. So this CRS cascade, initially said to start with arterial underfilling, it causes more decompensation, but there have been no clear direct association in studies found between cardiac output and either baseline eGFR or acute eGFR decline. Initially, it was thought that the cardiac output was the main player in initiating the CRS cascade, but over time the thought that venous congestion is the main player except in significantly decompensated cardiac disease where the cardiac output is really low. In that situation, the forward underfilling plays a bigger role, but otherwise the venous congestion leading to upregulation of fibrotic pathways in the kidney and inflammatory pathways leading to increased venous congestion under the capsule and a condition called kidney tamponade is also called into play. When you have venous congestion, they can manifest ascites. What is different from the regular definition of increased abdominal hypertension is that even at a lower intra-abdominal pressure of about 8 millimeter Hg, you can have pressure on the kidney and increase in serum creatinine. In this cascade, as shown earlier, we go down the neurohormonal pathway activation, the RAS activation, the sympathetic nervous system activation and the natriuretic peptide pathway, all increasing sodium retention and water resorption. Background cytokine and inflammatory biomarkers lead to endothelial dysfunction and fibrosis. The initial picture was quite simplistic, but if you look up close, there are so many simultaneous pathways which are going on. When heart failure is initiated, the renin-angiotensin system leads to vasoconstriction, endothelial dysfunction, inflammation, and cyclically again causes venous congestion and congestion in the kidney. There is ongoing lymphatic congestion, interstitial congestion in the kidney, which all increases the intratubular pressure. When the intratubular pressure increases, the single nephron GFR also starts to drop. One of the key armaments that we have is the usage of diuretics to address the congestion factor in CRS. So little about that. The DOSE trial, it showed no difference between the continuous IV loop diuretic agent infusion or the bolus intermittent dosing? These are practical questions that come to us on day-to-day practice. It's good to know that the loop diuretic agents have a steep dose response curves. When they have reached a level threshold of maximal activity of their diuretic effect, further increase in dose would not necessarily increase the natriuretic effect. However, if you keep the drug levels higher than the ceiling threshold, it allows for more time for the diuretic agents to exert their effect. The Transform Heart Failure trial failed to demonstrate a significant difference in all-cause mortality between torsemide and furosemide in individuals discharged after an acute heart failure hospitalization. And just to deal with the practicalities, a dose of 40 mg of IV furosemide is equivalent to 1 mg of bumetanide or 20 mg of torsemide. The concept of diuretic resistance is something we face in critically ill patients. So what do we mean by diuretic resistance? It's the persistence of signs and symptoms of congestion despite optimal use of IV diuretics, which is defined as following. The optimum is a furosemide equivalent dose of 160 to 240 milligrams daily in a continuous loop diuretic infusion or in combination therapy with an optimal dose of loop and a distal diuretic like a metallazone. That is the sequential blockade theory. So how do we get diuretic resistance? There are multiple factors which are contributing in addition to the low flow, low perfusion state of the underlying medical problem. Due to diminished oral bioavailability, impaired apical drug delivery, impaired sodium delivery. There's a concept called braking phenomenon, that is, as we continue to increase the dose of the diuretic, initially there is significant amount of sodium and water loss, but after some time there is diminishing return even at that high dose. Sometimes when we give high doses of loop diuretics for a long period of time, the tubular cells which get remodeled and the effect to that particular dose starts diminishing. So what's the best way to accurately assess diuretic response? Initially it used to be weight and urine output, but we know that reliability on that is not always consistent. A spot urine sodium concentration of 50 to 70 milliequivalent per liter at 2 hours after loop diuretic agent administration, or assessing urine output, which has to be at least 100 to 150 ml per hour in the first 6 hours after the diuretic dose. In some centers, it's possible to get a spot urine sodium result maybe in about an hour, and in that case, it helps to direct your care. So, couple of studies have shown that the natriuresis guided protocol was associated with greater salt loss and diuresis and a shorter length of stay without an increase in safety events. What data do we have regarding the usage of sequential nephron blockade? Acetazolamide by the ADVOR trial, SGLT2 inhibitor in the MPulse trial with loss of salt and water, thiazides in the chlorotic trial, the use of MRA in Athena, and tolvaptan for aquaresis in the Everest trial. We know that the 4 pillars that we use both for cardiac and CKD management are useful for us clinically. But with regard to the all-cause mortality and the CV cardiovascular death and heart failure, you can see that as the renal status worsens, the data is not really strong across all the pillars. So it seems to be more consistent in the early stages, at least till stage 3, where we are able to see a strong benefit in terms of ACE, ARNI, SGLT2, MRA, and beta blockers. The focus of dealing with CRS is a goal-directed medical treatment, both in heart failure and CKD. It is the same 4 pillars which are acting and beneficial to protect both the organs. The beta blockers for the sympathetic nervous system, the angiotensin block receptor, and ACE inhibitors, ARB and ARNI for the angiotensin system, the aldosterone blockade, and the SGLT2 for reducing the sodium avidity and water resorption. This is in a simplified form to say that there is, in terms of the therapies, as the CKD stage goes, you can see that in the advanced stages of CKD4 and CKD5, the data is limited. The non-steroidal MRA is strong up to an eGFR up to about 25, SGLT2 inhibitors up to a GFR of about 20. In CKD stage 5, as you see, the data is absent. So how do we go about using a diuretic? Initial IV loop diuretic dose, you will have a home oral dose. At least 2 times of that oral dose should be given as an equivalent as an IV. That is approximately 40 to 80 milligrams of IV furosemide. You assess the adequacy of the diuresis by checking the urine sodium. If urine sodium is greater than 50 or the urine output greater than 100, there is a response. If there is a response, you can up the dose or repeat the dose and follow up with sequential urine output and urine sodium measurements. Once decongestion is obtained, you need to switch to oral diuretic regimen. If there is no response, that's when you escalate and add agents. You can double the loop of the diuretic dose, or you can do a combination therapy. You can add acetazolamide or thiazide. You could consider adding an MRA at a higher dose. If there is inadequate diuresis, despite that, you need to explore possible causes of poor diuretic response, that is a low cardiac output state, and may need to consider further workup like a right heart catheterization. If none of it is working and you still have to get decongestion, you would have to consider ultrafiltration. So the approach to a cardiorenal syndrome is multi-pronged. First limb is the strategies for decongestion as it has been already mentioned. Now once we have gone through the steps and the patient is not responding, then you need to go to ultrafiltration. You work on strategies to improve your cardiac output, treat the underlying ischemia, arrest arrhythmias, valvular disease, any other pulmonary hypertension, RV or LV failure, medical management maximization. You also have to screen for other conditions which may contribute to the worsening of both heart and the kidney. Use of imaging modalities, point of care ultrasounds nowadays are coming into play, so that the volume status is initially delineated, because almost always before the patient presents with volume overload, they are already having a lot of fluid accumulated, and clinical examination for volume is usually suboptimal. You also have to check with the echo and check for congestion in the hepatic and the portal and the intrarenal vessels. So one of the challenges towards managing and diuresing patients who need higher doses is the concern that we are, the thought process, we should do no harm, because as we diurese the patient, very often the creatinine starts to go up. But that is part and parcel of the therapy. So we have to first have a baseline renal assessment so that you know the serum creatinine and the eGFR. Check the urine to see whether there is a truly underlying native kidney disease by checking for proteinuria and hematuria. You could consider using cystatin C, which is really not used as much in an ICU setup. Renal Doppler if is indicated. Classify if it's acute or chronic. Both these classifications are available online, and you can classify where we are starting from. The common risk factors like hypertension, diabetes, obesity, dyslipidemia, all those need to be addressed as this crosstalk continues. Cardiac assessment in biomarkers like NT-proBNP in addition with the echo need to be done at baseline. It is only by combining both the cardiac and the renal assessments that we are going to be able to be effective in clinical care. So what is our takeaway? Main thing being, do not under-diurese. If the creatinine goes up, it does not automatically mean that there has been significant renal impairment. One way of assessing that is looking at urine protein. But when you assess the urine protein to creatinine ratio, there may be a problem where it is overestimated due to the concentration and the fact that less of creatinine is being excreted. In some cases, the fact that the creatinine is going up is actually pointing you to the direction that your treatment was very efficacious and it is in the right direction. So not be very overly concerned about a change in creatinine. Talk to your nephrology colleagues. Differentiate true AKI from functional AKI as mentioned. All rise in creatinine is not bad. Look for contributors of diuretic resistance. In this subset of patients where they have an unacceptably high percentage of mortality and morbidity, and it is important that a teamwork with cardio and nephrology multidisciplinary approach maximize cardiac and renal outcomes. Thank you.
Thank you.
Thank you, ma'am, for that wonderful lecture. And
I will request only the chairperson to comment. In view of the time, the next speaker has to catch the flight also. Therefore, no audience question. You can interact after the lunch session or during the lunch.
Okay,
yes,
sir.
ma'am.
Thank you, ma'am, for the wonderful lecture and a great insight on diuretics and diuretic resistance. Madam, I just have one question. Any novel biomarkers for cardiorenal syndrome?
No, the biomarkers which are available are segmental in terms of cardiac and renal. So the biomarkers are many in the lab, but you have the KIM, NGAL and all those, but they are not available at bedside. So whatever we have to do, we have an urgency of time when patients present in decompensated heart. So the only one which is clinically available to us is creatinine, and in some places probably cystatin. And for the cardiac, we tend to use the NT-proBNP. So what we have, the financial and the availability determine what we use.
Basically, they say social determinant of the health. No? SDOH.
Talking about the SGLT2, ma'am. Ma'am?
Talking
about the SGLT2, where you just showed it has got strong evidence in first stage 4 till stage 4 and has even got limited evidence in stage 5. So whether it's EMPA or DAPA from your preference?
Okay, I think there has been first mover advantage because DAPA got cleared out. And in terms, there is data for DAPA and there's data for EMPA also. And the CRS has the EMPA data with the Fidelity and the Figaro. So I think based on the price points, now I think I'm open to the EMPA also, but I have used DAPA significantly also.
Thank you. Thank you.
Yeah.
Thank you both the chairpersons and the speaker. We will move on to the next session. The topic will be on salt sensitivity in modern hypertension, therapeutics. I think the speaker is none other than Dr. N.S. Prasad. For that, I request Dr. Balakrishnan, who is a physician cardiologist from Kollam, Kerala, to chair the session.
Good afternoon, friends. So the topic is going to be on salt sensitive hypertension. I know the salt sensitivity, it is about 50% of the individual, they suffer from salt sensitivity. And the main problem of salt sensitivity is the pressure-induced natriuresis, which is not there. When the BP goes up, automatically sodium should get excreted. But when there is an impairment of the pressure natriuresis, the salt-sensitive patients will be having more hypertension. But other factors also contribute like renin, angiotensin, aldosterone system, sympathetic nervous system activity, and kidney function. There are a lot of inflammatory mediators. There are so many things are coming in the people with salt-sensitive hypertension. Over to you, Dr. Prasad. I am very honored to chair this session of Prasad because I have been knowing him for the last 40 years. Over to you, sir.
Good afternoon, everybody. I first of all thank the organizers and Dr. Muruganathan in particular for having given me an opportunity to be amongst you. So, as our chairman has already in brief, given the gist of the salt sensitivity in modern hypertension, I think my job will be very much easy. So as you are all aware, hypertension is an important risk factor for death and disability. So one of the important contributory factors for, especially the lifestyle factors for hypertension, is the high dietary salt intake. Apart from, of course, the usual factors like obesity, alcohol intake, physical inactivity, smoking, unhealthy diet, stress, sleeplessness and things and so on and so forth. So by definition wise, salt sensitivity is defined as a acute blood pressure change in mean blood pressure corresponding to a decrease or increase in sodium intake. And usually salt sensitivity is arbitrarily defined as an increase of blood pressure of 10% or greater during a high salt diet than during a low salt diet. This is as per the definition. One thing is, prevalence is about nearly 1/3 of the healthy individuals seem to be having salt sensitive, being salt sensitive, and over 50% of the hypertensives are salt sensitive. However, we really do not know what is the Indian prevalence. It is more common in older adults, African Americans, patients with chronic kidney disease, metabolic syndrome, diabetes, etc. So, one thing is the high intake of salt elevates blood pressure and this increases the cardiovascular. Why we should be bothered? Because we all know that the cardiovascular risk is going to get increased because especially in patients with salt sensitive patients. So this exaggerated effect is seen in salt sensitive individuals. That is the reason we need to give more importance to these individuals. And this is an independent risk factor for cardiovascular disease and mortality. So that is the reason we are going more, even though hypertension itself is a risk factor, salt sensitive individuals are at exaggerated risk. Here it's a complex mechanisms is involving the renal, vascular function, immune system and gut microbiota. So the result is elevated blood pressure in response to high salt intake. This is the cardiovascular mortality attributed to sodium consumption. Depending upon the sodium consumption, the number of deaths of cardiovascular death is estimated. Here sodium consumption of more than 2 grams per day. Coming to the salt intake in the South Asian scenario, there is excess salt intake. This is the 7th leading cause of mortality in Southeast Asian region, which is higher than the rest of the world. So 11th globally, 7th in Southeast Asia, highlighting the adverse impact of high intake in countries like India. Recently, 1.65 million deaths from cardiovascular causes that occurred in 2010 were attributed to sodium consumption above the reference value of 2 grams per day. So this is the average consumption in the Indian population. It somewhere varies between 10 grams to 14 grams region wise. So if you just see this is approximately 5 to 6 fold higher than the levels provided with the natural diet and the same food items without added salt. Even though some of the Western literature recommend 2 grams, on an average in the Indian population, we are recommending around 4 to 5 grams per day of salt that is the permissible level. But on average, if you see, most of us are consuming between 10 to 14 grams of salt per day. So this, from the source by which we derive is mainly 71% is derived from the processed or pre-prepared food, especially what we get from the restaurants. Of course, the other contributory factors being natural occurring, what we add to the table, home cooking preparations and so on and so forth. So this is a very, very important study, the InterSalt study. This shows that an increase in the blood pressure with age associated with the higher salt intake. This was done in 52 communities worldwide and the population was quite significant, around 10,000 and odd population. This shows that more than 6 grams per day over 30 years of age increases the systolic blood pressure by 9 millimeters of mercury. So one interesting factor is the variability in BP response to salt. So again, if you take the salt resistant category, the increase in BP is not significant when compared to the category A and B category, wherein the salt sensitive individuals, the BP response is more when compared to the salt resistant individuals. Salt sensitivity in hypertension, there are multiple theories causing salt sensitivity. Some of those include the TGF, nitric oxide endothelial dysfunction theory, vascular angiotensin dysregulation theory, theories involving neurogenic dysfunction, oxidative stress related theories. Then again the nitric oxide mediated vasodysfunction theory, endothelial glycocalyx. So previously our pathogenesis was mainly kidney centric. Now we know that the vascular endothelium is also at fault. So the lot of changes occurring in the glycocalyx and the endothelial layer, NAC mediated vascular dysfunction is also a very, very important cause for the salt sensitive individual. So not only it's a renal, it's also a endothelial dysfunction prospects apart from the other immunological, the gut mediated and so other sympathetic nervous system and so many factors contributing to the increase in the salt sensitivity. Finally, the end result is contributing to the increase in the blood pressure. The novel mechanisms of salt sensitive hypertension is the high sodium consumption level is considered as one of the modifiable risk factor. And the various mechanisms are again kidney centered mechanism, vasoconstrictor mechanisms. So this is the diagrammatic. So previously we were high BP allows pressure natriuresis to match sodium excretion with intake. Now the vasoconstrictor theory shows that high BP is a consequence of incapacity to vasodilate after sodium load. So this is again being contributed by gut microbiome, the endothelial changes, the changes in the skin, sodium and the immunological factors. So one important factor seen in the salt sensitivity is here in salt sensitive patients the slope of the pressure natriuretic relationship, this is less steep. If you see the red curve, it is less steep and shifts to the right. As a result, the response of blood pressure to changes in the sodium intake is greater, that is the salt sensitivity increases. So the significance is that in salt sensitive patients, the pressure natriuretic relationship is altered and higher BP levels are required to achieve increased sodium excretion. So this is again the volume loading and vasodysfunction theory. CKD and sodium intake affects the increased sympathetic nervous system, decrease in the nitric oxide, increase in the RAS and so on and so forth. Ultimately by various mechanisms there is an increase in the systemic vascular resistance and then there is an increase in the blood pressure. Here again the impaired ion transport. The thick ascending limb of Henle's loop reabsorbs sodium but not water via the sodium potassium chloride co-transporter. So enhanced activity of this co-transporter in the thick ascending loop of Henle is a major cause of salt sensitivity. Again the renal adrenal glands are involved. This is the very interesting slide because sodium has got effect on the gut microbiota. So the lactobacillus and the shift in the microbiota occurs. As a result, it brings about the release of various factors for immunological factors, increases the inflammation and blood pressure. Whereas if we take a high fiber diet which is rich in vegetables and fruits, that decreases the inflammatory pathways and then brings about decreased inflammation and blood pressure. So lifestyle modification, dietary sodium intake, eating healthy foods rich in fiber goes a long way, in tackling this problem. Apart from that, genes are also involved in salt-sensitive hypertension pathophysiology. Genes involving so that there is an altered renal sodium transport and an altered vascular reactivity. Both predisposes to salt-sensitive hypertension. Then role of anti-natriuretic peptide also seems to be there. It decreases the natriuretic effect, decreases the diuretic effect, as well as increases the hypertensive activity. Then sympathetic nervous system overactivity, already we have seen. Enhanced sympathetic nervous system activity causes salt sensitivity. So finally what we have to do? Salt reduction lowers blood pressure, we know that. So we need to do a smart swap to lower the salt. So whichever dietary food contains more salt, we have to swap to dietary intake which contains less salt. So therapeutic, coming to the therapeutic perspective, treatment of salt-sensitive hypertension. At present, no standardized therapeutic guidelines to treat salt-sensitive hypertension. The consensus is reduction in the salt intake at a population level combined with conventional antihypertensive therapy. So, which is the most effective option for hypertension management in this subgroup. The WHO has classified sodium restriction as one of the most cost-effective methods to lower the burden of hypertension and CVD. In this regard, evidence has strongly suggested that the benefit of lowering sodium intake in both hypertensive as well as the normotensive population also. Here, patients with salt-sensitive hypertension or low renin hypertension have characteristics that lend themselves well to treatment with a diuretic. So, in clinical trials, we have looked upon patients with low plasma renin activity and our salt sensitivity. Effective BP lowering strategies include chlorthalidone, hydrochlorothiazide, indapamide or spironolactone. So, these type of diuretics seem to be having a role. Of course, apart from this, we have to use standard treatment, whichever antihypertensive which we are going to use. So, in salt-sensitive hypertension, especially in black patients, older adults, in patients with severe blood pressure and comorbidities such as metabolic syndrome, diabetes, CKD, low renin hypertension, particularly African Americans, the elderly, it is not surprising that diuretics have been shown to be particularly effective in these patient populations. So diuretic is one thing which definitely we need to use along with the standard care. And it has been found that thiazide like diuretics, especially the chlorthalidone and indapamide, score over rather than just thiazide diuretic alone, because apart from their proven effect, it has got CV event reduction benefits also. So, to conclude, management and clinical consideration. The AHA and ACC views salt sensitivity as a marker for increased cardiovascular risk. So, patients with salt sensitivity are at increased cardiovascular risk. So, this is additional cardiovascular risk apart from the people having traditional hypertension. Second thing is, the main drawback or the real challenge is current recognition techniques are impracticable for routine practice. So, we can easily, detection of salt sensitive individuals, we can do it only empirically in our day-to-day practice. Of course, in the lab setup it is totally different, or for a research purpose it is totally different, but in our day-to-day setup it is very impracticable or very, very difficult. So, the management or the key strategy is dietary sodium restriction, varied individual response. Additional interventions may be needed for hypertension management as on a case-to-case basis, and a network meta-analysis suggests that CCB combined with diuresis, especially chlorthalidone, are more effective drugs in reducing blood pressure for adult salt-sensitive hypertensive patients. Thank you for your patient hearing.
Thank you, Dr. Prasad. See, I have two questions to ask. One is, you said the diuretics is good for salt sensitivity, but the diuretic at the same time can increase the renin angiotensin aldosterone system. So, do you comment about it?
So it is, see, this is one as a, see, basically, I would like to say that this is a drug which is going to be useful in natriuresis. Additionally, we have to use the standard care. See, we all know that blood pressure control is not possible with a single agent. So whatever be the other agents, ARBs or AC inhibitors or CCBs, we have to use concomitantly.
See, whenever the sodium enters into the proximal convoluted tubule, so not naturally the system is stimulated. So that is the reason why the diuretics can, over a period of time, will increase the hypertension, though it may reduce the salt sensitivity. There may be a lot of question about salt insensitivity. In those people with salt insensitive hypertension, can we take more salt?
No, doesn't mean, they see, even for a normal individual, we want people to reduce their salt intake, because basically for our Indians, our salt intake is very much above the recommended dosing. So even among the normal individuals, there are salt sensitive individuals are also there.
Dr.
So it is not recommended to take more salt for salt sensitive. Only thing is the effect will be more on salt sensitive individuals. The CV risk, the CV problems will be more in the salt sensitive individuals compared to the regular insensitive individuals. That's all.
Dr. Lakshmanan, as an hypertensive man, will you be able to comment?
No, the salt handling by the kidneys now depends on the amount of sodium transporters strength in your kidney. Almost 30% are salt resistant. They take any amount of salt, they don't develop hypertension. Whatever the salt take, the kidney eliminates. The unlucky people is 70%. So we can do a small test in patients who are salt sensitive or salt resistant. Increase the salt, and after 5 days you can see the blood pressure systolic goes up by 5 millimeters, then we know they are salt sensitive. So not necessarily that all people, I still remember so many people enjoy pickles, puppets, despite all our advices, but they don't go for complications. But most of them are salt sensitive. We are Indians. And one more thing is we are living in a hot place, so by salt restriction we go for complications. It's not true. It holds good for everyone that in a blood pressure patient. That's why I rightly said, Prasad said, we give always combinations. We give a CTD-T, and you give a chlorothalidone small dose. You also add telmisartan. 6.25, nothing happens. It's a very, very safe drug and effectively brings down, especially blood pressure in the elderly people.
Thank you, Dr. Lakshmanan.
Any comments or any questions?
I think for final. Yes.
So this is a point to add. A normal healthy kidney excretes 1.5 kilogram of salt per day. That comes around 25,200 millimoles of sodium is excreted by the kidney per day in a normal healthy individual. If that is the case, if you add salt, give a burden to the kidney.
Yes.
So you have to reduce this thing. Well, one question is that if you give ACE inhibitors or ARBs, that itself excretes the salt, sodium. So thereby combination drug like chlorothalidone with the ACE inhibitors may be more appropriate rather than the calcium channel blocker, which only dilates the blood vessel. So probably in this situation where salt sensitivity is there, either ACA, ARB or aldosterone, probably along with the diuretic probably helps in those hypersensitivity.
I think we should bring our children from childhood without salt or minimize salt. Therefore, they will not feel the taste.
No salt till the age of 5.
Yeah.
No sugar till the age of 2. We make the people perceive these sort of foods with the high sugar, high salt. The food habits changes. So after 5 years, they don't accept your own the diet. So it should be from the school.
Yes.
No salt till 5 years. No sugar till 2 years. That should be the message to the public.
I think
Thank you, Prasad, for
can
the
we
good
close
lecture.
down the...
Thank you very much, sir. Thank you for the opportunities.
Thank you, Chairperson and
you have any comments?
No comments. And
So
the
if there are no
Chairperson and
comments, I
the
think
Speaker.
We'll close down this topic. Once again, thanks Dr. Prasad for your excellent talk on salt sensitivity. I think we'll dismiss.
No, we will adjourn for lunch for 30 minutes for want of time. Please finish up your lunch very fast and assemble here. Thank you.
to particularly use for calcified lesions. Calcium is very hard blocks. It's not like regular balloon angioplasty. So seeing is believing. When we sometimes when you do angiogram, we will not be able to see it. Depends on the angle which we see. We might think it is mild, we might be severe, so we will miss it. So when we go inside and look into the artery, we can get a much better, clearer picture. And with that we have ultrasound, which is sound-based evaluation, which we can assess the type of plaque, like how we can see the fibrous plaque or what the type of plaque we can identify, and then accordingly we treat. Similarly, optical coherence tomography is another mode where we can identify the type plaque, particularly in acute situations like acute coronary syndrome, a thrombus, and we can size it properly and use the appropriate devices. So this is one of my areas of great interest, which is intracoronary physiology. We do a lot of work. I do a lot of work on physiological measurements, and I use a lot of physiology measurements to guide procedures. So we check the intracoronary pressures. For example, if you see this angiogram, sometimes we don't know where the block is. So we check the pressure and then we do pullback. So we know where the pressure drop occurs. When there is a block, then we have pressure drop, and we use this frequently I use it very often to guide procedures, whether it's required or not, even if it is required, how many stents to place and all that. So calcified lesion is one of the challenging subsets which are very difficult to treat. We have now several options to treat calcified lesions. Sometimes when you use balloon, it doesn't open very well, and the calcium is like a stone. When you normally walk on a beach sand, it gets compressed, whereas on a rock, if you walk on a rock, it doesn't move. Similarly, the calcified lesions is like a rock, and it does not yield to balloon angioplasty. So we use several modes, and I can show you. This is called using a scoring or a cutting balloon, which has got blade in the sides. So it uses blade to cut it, and then we are able to get a better lumen in hard lesions. And we have some cases where we have done this kind of cutting in some cases, and followed by intravascular ultrasound imaging. There's other interesting new mode is to use intravascular lithotripsy, which is similar to lithotripsy in the renal system, which is usually hard on the calcium but soft on the tissue. That is a big advantage because it doesn't hurt the soft tissue, but it will be very hard on the hard tissue. So it doesn't cause a damage. It is similar to if you hit a stone or a hammer on the glass will not break, but the pressure gets transmitted. Similarly, this is going to have less effect on the soft tissue. So this is how a shockwave lithotripsy works. So if you see this, it's connected to a console through which high pressure through the ultrasound. It's actually a sound waves, ultrasound waves, which are pulsatile and are delivered in the balloon, through the balloon. And that pulsatility and the pressure exerts huge amount of pressure in the calcium. So this is a balloon through which these electrodes or the emitters are present, and these are inserted into the blood vessel, and then the shocks, or what we call as ultrasound bursts, are delivered, and it causes fracture of the vessel. So this is passed into the blood vessel like that.
Is advanced and placed at the lesion using marker bands under angiography, with the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution. The fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. With emitters along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmospheres, they create a series of microfractures. After the calcium has been fractured and trauma to the surrounding soft tissue has been minimized, the vessel becomes more compliant.
So this is now available with us and we've been using. We started the first in about four years ago. So you can see some of the cracks caused by the shockwave balloon. These are heavy calcium, these are fractures caused by the shockwave balloon. And this is extremely useful in difficult, hard situations. So rotational atherectomy we've been doing. In fact, day before yesterday, I conducted a workshop with we conducted many cases of rotational atherectomy for some of the cardiologists who came from other parts of the country. Here you see the calcium is it's drilled with the burr rotates at 1,90,000 to 1,80,000 revolutions per minute, and it helps to drill the calcium. This has been available for many years. And this is now, even today it's useful and it really helped in clearing the calcium and opening the vessel. This is one of our cases where we have done a rotational atherectomy and put a long stent and then evaluated with the OCT. So other new recently introduced technologies, orbital atherectomy, which is again, there is a burr which orbits around the vessel. Both it rotates itself as well as circumferentially. And it's a single burr with different speeds so that it can drill the calcium. Again, it causes sanding. You get minute particles of this, the calcium gets washed away in the blood. So this is also, we use it I use it routinely for calcified lesions and we are able to open in difficult situations. So this is one of the patients who actually had he crashed during procedure. So he was very critically ill. So we had to just do the orbital atherectomy and with an ECMO and bail him out. So this is one of the cases with orbital atherectomy. So there are different types of treatment available: cutting balloon, orbital, rotational atherectomy, intravascular lithotripsy. So many options are available, and imaging with intravascular ultrasound and optical coherence tomography. One is a sound-based, one is a light-based imaging modality. We can look at it and give a good results. So the message is very extremely useful, and in these kind of difficult situations, hard blocks, the only option is to use these kind of devices to bail out and get a good result. Thank you. No, let Dr. Elidan.
I think he want to have some question. Lakshmanan. Yes.
I remember a long time back, the very famous writer Sujata, he underwent coronary intervention. He landed with acute kidney injury.
Acute?
Kidney injury.
Kidney injury.
The calcium you liberate, isn't it? Even a small amount of calcium causes the renal shutdown. You using now distal protective devices or you don't use it?
No, we don't use it. Basically, multiple reasons for renal failure during angioplasty. It could be contrast-induced nephropathy, it could be cholesterol embolism, multiple things. But we don't use filter. Nowadays, we protect the kidneys. One thing is we use very low contrast, zero contrast angioplasty, where we minimize the dye. We only look at the images, use wires as markers, and we do one. Second, even when we limit, we also hydrate the patient very well. There are other drugs sometimes useful like N-acetylcysteine and other drugs. So these are the ways to minimize contrast and to prepare them well to reduce.
What's the creatinine level you look into before you do this?
It is not that level because it's all the risk and the benefit ratio. Generally, if the GFR is less than 50, sometimes what happens is we have to weigh the pros and cons. And if angioplasty is required, then we have to minimize the contrast and do it. But if the patient is already in dialysis, for example, then it is not a problem because anyway, when we give contrast, it can be dialyzed and removed. Patients with, recently I had a doctor who had multiple disease, LV dysfunction, no role for surgery, creatinine was 3. But this is a problem because 3 can sometimes go on for dialysis suddenly. If they leave it like that, they can progress, CKD will progress slowly. So that situation, we had to use very low contrast. We almost did without contrast, very negligible zero dye. So that contrast is the one which causes most of the time renal damage.
Now what's the incidence now? Is it coming down, the acute injury following? What is the...
No, it all depends upon the pre-existing renal function.
Okay.
So elderly male patients who have pre-existing renal function, dysfunction, diabetes, diabetic nephropathy, they still have higher incidence of contrast-induced nephropathy. So this is a major topic. We always protect them. We hydrate them well. Hydration is the key. Then stop all the nephrotoxic drugs, particularly patients we on some metformin and those drugs. We stop all that. We hydrate prepare properly. And most critical thing is using the contrast. Normally, if the GFR, we also have 1 ml contrast. Suppose GFR is 20, use only 20 ml contrast. So we try to minimize the contrast. That is how we do it now.
Thank you, Changatwel. Thank you. Very clarity.
Yeah, see, calcium is one challenge. Like when Dr. Lakshman asked me the same question, CKD patients also have calcium. Diabetic patients, old patient, all of them develop calcium. So calcium can reaccumulate. See, the problem with calcium is any calcium other than deposition in any visceral organ increases mortality. There is an article that says coronary calcium is a risk for all-cause mortality, not just coronary mortality. So visceral calcium deposition is a big challenge, and we don't have any drugs or anything to prevent calcium deposition. Though there are some not much of evidence-based, but they say vitamin K2 and other things remove the calcium from the bone, sends it back to the bone. But there is no evidence-based method to do calcium. So we have to, whenever calcium deposition works, we have to remove it. The only thing is to control risk factors like control diabetes, kidney disease, all that are potential risk factors for increased calcium deposition. So that is the only way to solve. As age increases, particularly we have high amount of calcium deposition in the viscera, particularly in the coronary arteries. Can you give a mic to her, please? I am not able to clearly
Any
understand.
cases, whether you have to redo this, sir?
Please repeat.
After removing the calcium, after some time, whether you...
So, let me tell you, the process of atherosclerosis is a slowly progressing disease process which keeps on increasing over time. So, atherosclerosis, as you know, it is a combination of multiple processes where you have intimal growth, fibrous tissue, calcium, cholesterol, lipid, everything. So naturally, when the atherosclerosis progresses, the new calcium deposition can occur. But we cannot, by certain drugs, we are able to retard the progression of atherosclerosis. Like we are discussing about statins and other drugs. But there is nothing specific, it can recur. We have seen several patients who recur, particularly young patients when we do. Naturally, when they live long time, then 20 years, 30 years later, calcium can come. But fortunately, it's a very slow deposition. It doesn't come in short time. Calcium progression happens over time. And we also look at calcium scoring by CT. There's again an indicator, a marker for atherosclerosis. We know the calcium score, if it is more than 100, definitely significant atherosclerosis. More than 400 is highly significant. So it is useful to identify calcium, but calcium is a big, one of the difficult things to handle as an interventional cardiologist when the amount of calcium is very high.
Thank you, Dr. Singh. We will proceed to the next case. I think we have got our own cardiologist from Madras Medical Mission, Dr. Yadilan. He will be talking on the spotlight on beta blockers. So spotlight means, suddenly it comes, everyone talks about that. For that, I request Dr. Parandaman, retired professor of medicine, Rayapeta Hospital and KMC, to chair. I will co-chair with him for some time.
This topic is spotlight on beta blocker, and to talk on that we have eminent cardiologist in the country and is a renowned professor of cardiology. He is a director of peripheral vascular intervention at Madras Medical Mission. He has got a rich experience in the interventional peripheral disease and a very popular speaker about this, the beta blocker. Now over to the speaker to deliver lecture on spotlight on beta blocker.
Thank you, respected chairpersons. And Dr. Pandaman happens to be my junior at Kilpauk Medical College. Very glad that you are introducing me. So, my topic for today will be spotlight on beta blockers. Before starting this, how many in this hall have normal BP? Okay. From 2024, no one will have normal BP. The ESC 2024 hypertension guideline says that even if your BP is less than 120/70, you should call it non-elevated BP, not normotension or normal BP. If you have more than 120/80, it is elevated blood pressure, more than 140/90, hypertension. So now there is no terminology called normal BP. Everyone has non-elevated BP, that's all. Now coming to beta blockers. Beta blockers block the beta receptors. There are three types of beta receptors: beta 1, beta 2, beta 3. The adrenaline and noradrenaline secreted by the sympathetic nervous system sit on these receptors and stimulate them. So if the beta 1 is stimulated, you have increased rate of contraction, increased peak force of contraction, increased rate of relaxation. Beta 2 has positive inotropic response, vasodilation, decreased central aortic pressure, bronchodilation. And beta 3 causes lipolysis, fat oxidation, energy expenditure, insulin sensitivity. Now ideally, if you have a good beta blocker, it should block only the beta 1 receptors. It should not block the beta 2. Then it is cardioselective. But there is no 100% cardioselective beta blocker. Most of them block both beta 1 and beta 2, do nothing for beta 3. Only one molecule, nebivolol, stimulates beta 3 and blocks beta 1 predominantly. Previously, when we were doing DM, you had so many beta blockers. You had to classify whether it is cardioselective, non-cardioselective, whether it is with ISA, without ISA, with membrane stabilizing activity, without. It was difficult to remember all this. Then in addition with alpha blocking effects. But now it has become simple. We have only 4 beta blockers in use: metoprolol, bisoprolol, carvedilol, nebivolol. We call it as cardioselective if majority it blocks only the beta 1. Metoprolol 70% will block beta 1, but 30% will block beta 2 also. Bisoprolol, nebivolol have higher beta 1 selectivity. 95% will block only beta 1, 5% beta 2. And then nebivolol has ISI on beta 3. That is how it is a little different beta blocker. Now beta blockers we have been using for as an anti-ischemic drug for 50 years. As an anti-failure drug for 35 years. Initially it was absolute contraindication to give beta blocker in heart failure. Now it has become a class 1 indication. As anti-hypertensive also we have been using for 45 years. The anti-ischemic effect of beta blockers remains unchallenged. The anti-failure is growing from strength to strength, but it is only the anti-hypertensive effect which is being questioned. I would say injustice has been done to beta blockers as an antihypertensive. It is not that the molecule is bad. We are looking at it in a bad way. Previously, there used to be JNC guidelines from USA coming out once in 4 years saying which drug is first line drug, which is second line, which is third, fourth. They used to classify hypertension also, initially stage 4, then became stage 3, then stage 2 hypertension and all. So we are following these JNC guidelines. And if you look from JNC 3 to JNC 7, that is from 1963 to 2005, diuretics and beta blockers remained as the front runners. They were the number 1 drugs in the management of hypertension. But then suddenly what happened to beta blocker? 2 trials killed beta blockers. One is the LIFE trial in 2002. It compared atenolol versus losartan in diabetic hypertensives, and you could see clearly that losartan did better and had lesser primary composite endpoints of CV, death, MI and stroke. So beta blocker atenolol was pushed to the back seat. Then came this Ascot-Cafe trial. This trial was a very good trial at that time in 2005. It divided 2,000 patients into 2 arms. One arm received amlodipine plus perindropil, ACI plus CCB, and the other received atenolol plus bendrofluothiazide. And if you look at the results, for the first time this trial showed there is something called central aortic pressure. If you look on the left hand upper column, the brachial pressures was reduced equally by both the arms. But whereas if you look at the aortic pressure, central aortic pressure, only the amlodipine perindoperable arm was able to reduce the central aortic pressure. Atenolol and diuretic did not reduce it. Then if you look at reduction in stroke, it was 23% more. Reduction in CAD was 24% more. And new onset diabetes was 30% less in the amlodipine perindoperable arm. So clearly, beta blocker and diuretics were inferior. But there was problem with this trial. It was not that atenolol was bad. See, amlodipine has a half-life of 30 hours, perindoperable has a half-life of 30 hours, atenolol has only 6 to 7 hours, and it was combined with bendrofluoromethacide, which is a diuretic not used at all, diuretic which is least potent diuretic and very short half-life, and the dose given was 1.25 to 2.5. And if you see in the trial, the BP reduction in the amlodipine perindoperable arm was 2.4 more than the atenolol and diuretic arm. When you have a trial, the end result should be equal, only then you can compare the drug. We know by decreasing 2 millimeter of mercury, you can reduce 7% CAD and 10% stroke. So how can you compare these two results? So this Ascot-CAF was an unfair trial where amlodipine and perindoperable giants were made to fight with atenolol and bendrofluorothiazide, which are not that giant molecules. So the fault was not with the drug, but in the trial. So then in 2005, the Lancet, should beta blockers remain first choice in the treatment of primary hypertension? A meta-analysis was done, and they said that beta blockers are less effective than other antihypertensives and should not be used as a first-line drug. And then the UK NICE guidelines said that beta blockers should not be recommended for hypertension. So if you look at the BHS NICE guidelines, step 1 beta blocker was cut off, step 2 beta blocker was cut off, step 3 it was not to be used, only in step 4 you can use beta blockers. So it was degraded from step 1 to a step 4 drug from 2002 to 2005 after these two trials. So beta blockers was pushed to the graveyard, people started using less beta blockers. Why atenolol, which had done so well in the past? Even now, if you take the maximum sold beta blocker, it is atenolol, not even the newer molecules which we are using. Why 4 trials made it fare badly? Why 2 trials influenced UK guidelines to degrade beta blockers? And in spite of beta blocker and diuretic both being used, diuretic was not blamed, only beta blocker atenolol was blamed. So now let us look at the trials. If you look at the trials positive for beta blocker, that is atenolol, IPPP, SH, MRC, mild hypertension, MAFI and UKPDS. If you look at the mean age, all were less than 60. If you look at the pulse pressure, it was narrow pulse pressure. So if you are young age, less than 60, if your pulse pressure is less, then beta blocker works for you. Now if you look at the negative trials of beta blocker, MRC, elderly, HEP, life and Ascot, the age was more than 65, and if you look at the pulse pressure, it was wide. So if you are elderly hypertensive and your pulse pressure is wide, beta blocker doesn't work. Now if you look at patients who took beta blocker first and then diuretic was added, or people whom diuretic was given first and then beta blocker added, in the MRC elderly, when beta blocker was given first, reduction in coronary event was 0%, stroke event was 17%. The same MRC elderly, if diuretic was given first and then beta blocker was given, you could see 44% reduction in coronary and 31% reduction in stroke. Similarly, SHEP also showed good reduction in coronary and stroke events. So giving diuretic first then beta blocker helps. Why? If you give first line diuretic, it increases the sympathetic nervous activity, increases renin, decreases pulse pressure, improves vascular compliance. All of the above makes the hemodynamic scenario similar to a young hypertensive and conducive to beta blockers. So we should know how to use beta blocker. You should not give it in the wrong place. So the reasons for poor performance atenolol was dosed once daily with a plasma half-life of 7 hours. So they should have given it twice, or they should have made it into a sustained release preparation, then atenolol would have done much better. It had a peak trough ratio of 30%. It partially blocks beta 2 receptors and does not improve vascular compliance. Atenolol does not decrease central aortic pressure and hence left ventricular hypertrophy. It is not the drug of choice for elderly hypertensives with decreased receptor. sensitivity, decreased plasma renin, and wide pulse pressure, as was the case in all the 4 trials. So then after seeing all this evidence, the Canadian leading medical journal was the first to come out again in support of beta blockers, re-examining the efficacy of beta blockers for the treatment of hypertension and meta-analysis. And then it concluded that for patients with a mean age under 60, beta blocker were no different from other drugs in reducing the composite outcome of death, stroke or MI. And in those with a mean age over 60 years, beta blockers were associated with a higher incidence of stroke. Then the Canadian Hypertension in their guidelines told that you can use beta blockers as a first line drug. Then the European Society of Hypertension in 2000 also said that beta blockers can be used as a first line drug in the management of hypertension. And now the ESC 2024 hypertension guidelines again has said, if you look at the right column, beta blockers can be used as monotherapy or at any step in the combination therapy of hypertension management. Another thing is you have a high sympathetic activity in Indians. If you see 6 out of 10 Indians are hypertensive. So when you are having a hypersympathetic activity, beta blockers should be the first choice in the management of hypertension. So at least in India, even in younger age group, first line drug can be a beta blocker. Though guidelines gave it only a third line recommendation, beta blockers is one of the most preferred drugs in Indians, and next to CCB, maybe because of the cost, you see beta blocker is the maximally prescribed drug. If you look at this article by Bangalore and JICC, in the lifespan of an individual, maybe in the early uncomplicated stage or uncontrolled stage, you need not give beta blocker. But in the 4th, 5th and 6th decades, when you develop complications of hypertension like heart failure, angina, arrhythmia or post-MI, beta blocker will be a compelling indication. And in India, even in the early phases, beta blocker will be the drug of choice. Thank you.
So great presentation, sir. It's like a professorial presentation. How started with beta blockers pushed back by 2 studies, and subsequently how it was completely analyzed and made it to a first line drug or maybe subsequently used as a second line drug. So great presentation, sir. It's a wonderful message. There are so many years I was having this doubt why the beta blockers not being used, why is pushed back, because of this half-life of 6 to 7 hours compared with the half-life of 30 hours. That is injustifiable. That's the reason it got pushed back. And anyways, a wonderful, clear presentation. We have learned a lot from this study and your lecture. And thank you very much, sir, for the presentation.
Thank you.
Now, floor is open for discussion. Sir, my question from side.
Sure.
The 2 main hormones responsible for hypertension, 1 sympathetic system, 2 RAS system. If at all we have, all this produce sodium water retention, both hormones by action. So you start straight away with the beta blocker, because sympathetic activity is the 1 and the RAS is the 2. The 2 hormones are there in hypertension, along with the other minor like aldosterone, other things. So can we use straight away beta blocker those who are having hypertension, especially more than 40 years of age?
I mean, in hypertension, there could be basically 3 reasons. One is increased volume. Second is increased sympathetic activity system, and third is increased activation of the renin-angiotensin system. But clinically, it is very difficult to find out which one of the 3 is responsible for hypertension in that individual. If it is volume, then definitely diuretics will be the first choice of drug for him. If he has increased sympathetic activity, that to a certain amount you can identify. If the patient's resting heart rate is high, if he is tense, if he has tremors, if he is talking fast, all that are signs of increased sympathetic activity. If that is there, then for that individual, beta blocker should be the first drug of choice. If he has increased renin activation, then RAS inhibitor, ACI, ARB will be the choice. But it is very difficult to identify which one of these 3 is responsible. That is why now even ESC guideline says straight away give 2 drugs as a first line, so that you are acting on 2 mechanisms. And the next, if it doesn't act, then give all 3 drugs. So combination therapy, 2 drug pill first, and then if not 3 drug is being given, because you are simultaneously having an attack on all the 3 systems responsible for hypertension.
Excellent.
I think excellent exposition, Ilan. I enjoyed it. I think the life trial is the one which spoiled the image of beta blockers, as you rightly said. I think it was all tried 70 plus people comparing the beta blocker versus the losartan sodium. And comparing the young hypertensives in India, the resting tachycardia is very high. If you check the pulse rate, that's why we clinically know that they have increased sympathetic activity. Would you prefer what beta blocker, nebivolol or bisoprolol or carvedilol?
Yeah, I would prefer bisoprolol or nebivolol.
Yeah, don't prescribe carvedilol to young hypertensives. Cause impotence. I think safer will be nebivolol because it also donates the nitric oxide.
Yeah, new onset diabetes also will be more with the non-selective beta blockers.
Thank you, sir. Thank you.
Thank you.
Which is the ideal drug you combine with the beta blocker? Either ACE-ARB or diuretic or alpha blocker?
I mean, if I am giving beta blocker as a first line drug, I would combine it with an ACI or ARB. And if third drug is needed, only then I would go for diuretics.
We also know that when you combine a beta blocker with a ARBS, the reduction of blood pressure is manifold. Double digit reduction is there.
Yeah, in dialysis patients, bisoprolol would be preferred because it is least dialysable. It does not go out during dialysis. And fluctuations in blood pressure also will be better if the patient is on bisoprolol. If you give some other drug which is dialysable like atenolol or metoprolol, then the hypotension during dialysis will be more. But whereas if the patient is on bisoprolol, the dose reduction will be less.
If there are no questions, once again I thank you for your wonderful discussion also. Clear the doubts on beta blockers. Thank you, sir.
Thank you. Dr. Velilan and Parandaman. Now I will hand over the mic to Dr. Muruganathan. He has got some special announcement and he will proceed.
Since we started Cardiobase, the third year, first year we gave Lifetime Achievement Award to Professor Tanigachalam. And this time, we have chosen an excellent person who is known internationally. We have chosen Dr. Mohammad Raleigh to receive the Lifetime Achievement Award. So, we'll have a short awards function. And Mohammad Raleigh is a versatile genius. He not only talks about liver, he can talk about Kambaramayana also. He can sing a song also. Such a jovial, nice person. So, we'll have the award ceremony. I requested Professor Santaram, the former Vice Chancellor, to take the stage, Dr. Sengotuvel, and of course myself. So we'll have a... You can see, I asked him just now, Mohammad Raleigh, what do you like to talk about the liver? He said, you people, what do I talk about liver? I'll talk about the world, current scenario in world. So, such a versatile genius, he can talk about anything. So, I think give a round of applause to welcome our Mohammad Raleigh, and it'll be our pleasure to introduce him and give a citation, give an award, and then we'll listen to him. I thank Justin Paul. Of course, he was supposed to talk and he said he can wait and see. And Alagasan is there, Dr. Lakshmanan is there. Lot of charming ladies are there, they are waiting to listen to him. I think now, Sengotuvel, yeah, come. We'll go to the stage and we'll read first introduce him and then talk about it. Sir, please come to the center stage. Of course, to chair this session, we have a wonderful person, Dr. Santaram. He's a former Vice Chancellor and he's a well-known diabetologist. Now I request our course director and the director of the whole medical academy. So he'll read the citation and then he'll present the award, and then after that we will listen to Dr. Mohammad Raleigh. Of course, we'll have the felicitation from Dr. Santaram also. Over to you, sir.
Good afternoon, all of you. The directors of whole medical academy and the whole medical academy is proud and privileged to honor Professor Dr. Mohammed Rela. You know, Dr. Mohammed Rela is a very world-renowned Indian liver transplant surgeon and hepatobiliary specialist, based over 3 decades of international experience, and is trained at the prestigious King's College Hospital in London. And Dr. Rela established a formidable reputation very early in his career for clinical excellence and surgical innovation. Currently, he is a founder, chairman, and managing director of the Rela Institute of Medical Science and Center, established in 2018 in Krompet, Chennai. Under his visionary leadership, the institute has become a premier destination for liver transplant, and people around the world, South Asia, do come here, transforming this center in one of the most active Indian liver center with over 300 transplants conducted annually. In a landmark medical achievement, Dr. Rela performed the world's first successful liver transplant on a 5-day-old infant in December 1997, a feat recognized as the Guinness World Records in 2000. He has since pioneered and popularized several advanced surgical procedures, including split liver transplantation, auxiliary liver transplantation, living donor, and pediatric liver transplantation, and the Whipple procedure. A prolific academician, Dr. Rela has authored more than 800 articles, scientific publications in many reputed journals, and also contributed to several leading iconic textbooks like Gray's Anatomy and numerous high-impact journal and surgical textbooks. He has served as the past president of the International Liver Transplantation Society, the ILTS, president of the Liver Transplant Society of India, and many other esteemed organizations. Dr. Mohammed Rela's career reflects a remarkable blend of surgical brilliance, compassionate leadership, and a deep commitment to advancing healthcare globally. His legacy continues to inspire generations in the field of liver transplantation and beyond, and brings him the Lifetime Achievement Award from the whole medical academy. The directors are really honored and thank you for accepting the award. On the behalf of the directors, now we request him to present the award.
In fact, that was the shortest citation we could make out of his biodata. You know, biodata runs in pages and pages, and we had a very difficult time to concise and make it a shortest biodata. Now, I request the senior professors are there, Alagasan, Dr. Lakshmanan, Dr. Justin Paul, all of us, please, we'll have great pleasure jointly. So many professors are there. He is a proud person of our country. So we are really honored to give the Lifetime Achievement Award. Now, please join us. Dr. Parandaman also, please join. Whoever senior persons, because, yes. Come. We have given a solid, we are really happy to give him a silver liver, but he deserves more than that diamond liver or, you know.
I would have preferred a heart, your heart.
And you know, this liver also has all the portal vein and hepatic artery also in the figure, and we really, you know, made it only for him. And it will be our honor and pleasure to have this award bestowed on him in front of all of you. And I think, come. Yeah, please come, please come. just now I told Sivakadacham, the senior people to come to the stage, but you are only junior to me, so it's okay. Yes, so we'll all have it. And I wanted the two professors, ladies, Vijaya and Namita, please come to the stage. Vijaya, nephrologist, yes. Because the photo will be colorful if you two are there. She is Professor of Medicine, Namita. She is Vijaya, nephrologist. Yes. Thank you. Now, before I ask him to give the acceptance speech, we will also ask him to cut the cake. Be there, allegation, please.
Shall I announce now?
Yeah. Now, after that, Santaram will offer felicitation. Then acceptance speech finally by.
Yes. Yeah. I think this celebration also include our beloved Dr. Muruganathan's birthday in June, and also it is the 50th wedding anniversary of the couple. No? Therefore, no, this also included, I told, not, no, exclusively. Yes. Yes.
Dr. Bhanumati?
Bhanu? No, sorry.
Yes, after this acceptance. I think I never expected to have a wedding anniversary celebration, because to mark this award function, we thought we'll also cut the cake and share our joy. Now we'll ask Dr. Santaram to offer his felicitation, then acceptance speech, then we'll have the final. Now, yeah. Yeah, please. Yeah. Come, all of you please join. Please. Santaram. Yeah. So, no. Thank you. Thank you. Now, thank you, gentlemen. Now I'll request Professor Santaram to offer felicitation. Then finally, Mohammad Rela will give his acceptance speech. Oh, yeah, I'll give the program. Ask him to call my wife.
Respected Professor Dr. Rela, Chairman and Managing Director, Rela Institute and Medicare Center, Cardiobase Directors Dr. Muruganathan and Dr. Sengetuvel, Senior Professors, Consultants, Budding Specialists and students. A very pleasant evening to all of you. Thanks to the Cardiobase organizers, especially the course directors Dr. Muruganathan and Dr. Sengetuvel, for the opportunity, and the Cardiobase provides the platform to discuss the basic or to revisit the basics and update with the latest in the cardiac science to empower the practicing physician to treat patients with a cardiac illness. It is very heartening to note that they not only disseminate the knowledge but also taken the responsibility of honoring and recognizing people whose contributions had changed the landscape of management of diseases and has benefited the patients. Though it is customary to celebrate and recognize people who have achievements, who have made contributions, by conferring honor to a person like Rela, the honor itself is honored. So I congratulate the Cardiobase 25 for the appropriate choice for the Lifetime Achievement Award. And to take about Dr. Rela, to talk about, we can go on and on, but with the constraint of the time, I will limit myself to highlight certain aspects of his achievements. Graduated from Stanley Medical College with MS in General Surgery in Stanley, he moved to UK in around 1986 and had his FRCP in 1988. After working in various hospitals, he joined the Langdon's King's Hospital, where he serves till today as the Professor of Liver Surgery and Transplantation. An innovative surgeon, he had many innovations while in King's Hospital, like Dr. Singhatwal has enumerated, the split liver transplantation, the auxiliary transplantation, live liver transplantation, and one more is the segmental transplantation for the neonates. Having known Rela, it is not surprising that he has come back to India to serve the society which has made him what he is today. And we have all give standing applause to Rela for what he has done. He came back in 2009 and started the Indian largest liver transplantation unit and the Dr. Rela's Hospital in 2018, doing over 300 liver transplants annually with a 99.2% success rate, apart from the complex hepatobiliary surgeries. Having seen his achievement, we should not think that he is only a skilled, innovative surgeon and an astute clinician, but is also an academician, as he has authored over 800 publications, peer-reviewed journals, and 35 chapters in textbook, including the latest edition of the Gray's Anatomy and the Bailey and Lau Short Practice of Surgery. And being a visionary, he wanted to disseminate the knowledge, what he has acquired. So he started a postdoctoral fellowship in transplantation in the Rela Institute in affiliation with the Dr. Tamil Nadu MGR Medical University to train students to carry his legacy in future. Knowing his heart, we know that he has a heart for the poorer section of society. He has offered himself to do liver transplants free of cost at Stanley Medical College, where the outcomes were same as in his institute. That shows his commitment. Also to enable people from far places to have access to the facilities what is given in Chennai and abroad, he has started the program in tier 2 cities also. This shows his humane nature. Apart from this thing, he had served in the editorial boards of various prestigious journals like the American Journal of Transplantation and Transplantation Journal of International Transplantation Unit. And he was also the editor between 2000 and 2015 in the Journal of Clinical and Experimental Hepatology. And he's been a reviewer in over a dozen journals. With all his accomplishments, still humble, down to earth. And he had so many recognitions both nationally and internationally, over 20. But I was fortunate to confirm with the DSA Honoris Causa in 2013 when I was the Vice Chancellor. And once again, I had the opportunity and the privilege to be in this award ceremony thanks to Dr. Muruganathan and Singatuvel. Today, as you are conferring Lifetime Achievement Award to Dr. Rela, we should vote to imbibe some of his qualities, both professionally and as a human, and carry his legacy. Thank you.
Now, I request Professor Rela to give the acceptance speech. Good, sir.
Can I close this? Good afternoon. First of all, I want to thank whole Medical Academy of India and Dr. Muruganathan for approaching me. I'm really humbled by this award, really, where so many of the senior professors are there. But I'm actually as old as most of you. And I also want to thank a close friend who I got to know recently, Dr. Sengatuvel, and the course directors, all three of them, Dr. Sengatuvel, Dr. Muruganathan, and Dr. Chennappan. I didn't realize, I thought I would speak for 5 minutes, accepting and thanking people, but I'll probably take 10 minutes to talk about the world happening, what's maybe something about cardiology, my understanding, and then the liver. But I think I'm even, when I heard, I'm really even more honored that Dr. Shantaram is here. He mentioned this. It's almost 13, 14 years ago. I was offered the DSc honoris causa by MGR University when Dr. Shantaram was the Vice Chancellor there. And that award function, we had the late Chief Minister, Madam Jayalalitha there. I think that was one of a very rare occasion where she came to the Tamil Nadu MGR University's convocation. I was really honored, and actually for you to be here, I remember the day and how active you were on that day, and in the presence of an Iron Lady there, and how exciting it was on the day. I remember that, and thank you very much, sir, for that. Now, I am a great believer of talent. I've worked in the UK for about 25 years. I've worked in King's College Hospital. And I'm a great believer of talent in India, specifically talent in India. And one of the reasons I came back, I've trained many, many young doctors from all over the world. People in King's was the center for, in fact, Mecca for liver transplantation in the early days. And I've trained people from Spain, from Greece, from many Western countries, Ireland, and many people from India, Pakistan, Sri Lanka. And I have to say that Indians had a specific talent for technical abilities, which is why you see such fantastic cardiologists in this country. And when I left King's, 15 years now, I had my position as a professor for almost 10 years after returning back. I was going back every 6 weeks to work for 1 week. Many said I would fail in India. Many didn't think that you leave a position as a professor of surgery in King's College London and go to India. They thought I would fail. But I have to say to you, 15 years later, I'm so pleased that I made that decision to return back to the city where I'm graduated. And it's not just a success. They said academically also it's going to be impossible. And I have become more famous as a liver transplant surgeon after coming to Chennai than I was when I was a professor of surgery at King's College Hospital. Most of the recognitions, people wanting me to write a chapter on Gray's Anatomy or Balian Love, I became the first president of the International Liver Transplant, first Asian to become president of the International Liver Transplant Society. I'm currently the president of Living Donor Liver Transplant Society of the world. So India gives you opportunity, and I want to address the younger people here. Today is a day of opportunity. You don't need to go anywhere in the world because the talents are better here in India than any other part of the world. And there is another thing that happened about a month ago, and many people didn't take notice of it. A month ago, I did the first ever completely robotic pediatric liver transplant in the world. So AI and robotic surgery is taking off in a big way. And I do believe, I think in cardiology as well, it's going to make a huge change. I think the robotic surgery, I've heard that you don't need to actually be so skilled maybe. The robot will place the catheter, the robot will get into the artery, it will assess the size of the catheter. Is that all true? Yes? Very preliminary, but it will come, I think. When we can do, and when I was interviewed about this child's robotic operation, because in a robotic operation, you're not standing next to the patient, you're sitting in a console in the corner of the room, and I was asked whether we can do an operation from one part of the world to another part of the world. This is just a month ago where I said that would be very difficult to do a liver transplant sitting in India, and living donors are not done that many in the UK. I mean, if I have to say to you, we have the largest pediatric liver transplant program in the world currently. We do more than 100 children. Any program in the West does less than 40 liver transplant, pediatric liver transplants a year. So people said, can you do a pediatric liver transplant robotically sitting in Chennai in the US? And the answer I gave to the media was, you all know when we speak from home on a television and then you look at the screen, there is a delay of 2 seconds maybe. And that's why when the people call phone calls, they say, speak on the phone, don't listen to the screen because there is a delay. And I said, that sort of a delay it's not possible to do complex surgery because you have a big bleeder and you only know 3 seconds later you see the bleeder, you may not be able to stop the bleeding because the next time you look at it, the whole place will be full of blood. But to my surprise, one of the guys who actually interviewed me sent me a WhatsApp message, and the Reuters news yesterday said there was a robotic prostate operation done in Florida for a patient in Angola 11,000 miles away. 11,000, and that was through a fiber optic cable. So now many countries are linked with direct fiber optic cables, and when you have fiber optic cables, you will be able to one day do your cardiology procedures sitting in Chennai to any patient in any part of the world. So it is becoming really global. Now from this, I'm talking about what I news about yesterday, and I land here. This was a message news yesterday, something very positive, something that I'm interested in, and I land here. There was chaos. I came from Dubai this morning. There was a lot of chaos in the airport because the flights were being rerouted. The United States attacked Iran, and I think the British Airways flight that took off from Chennai landed back in Chennai 3 hours later. And I'm thinking, even though technology is changing, people are not changing. You might say people have changed. If people have changed, Tirukkural was written 3,000 years ago, yes? How will it be applicable today? It won't be applicable if we have all reformed ourselves, educated ourselves. And I have this theory that we always say about compassion. I think compassion is a taught attribute. I always say to doctors, in today's world where we are commercial about everything, you can't give up on self-assessment and compassion. Self-assessment is another thing that all of you have to think about. When you make a mistake, you know better than anyone else. It is you who's made the mistake, even though no one else can prove that it's you who have made the mistake. And when you go home year after year, I mean, there is a saying, a surgeon who says that all of us as surgeons one day have to think about, or not one day, periodically think about people who we have harmed. I don't think any of us here could say we have not harmed anybody. Self-assessment is something that is important for us. Compassion is important for us. I think compassion, I believe, is taught. It's education. Otherwise, edhukaga ulaga marai. I hope I can speak in Tamil as well. Or Avayar. I'll say a few things about Avayar and finish with that. There have been many, many great leaders we have had. Mahatma Gandhi was there, and Nelson Mandela was there. And when apartheid was there in South Africa, the Western world hugely supported apartheid. Without that, apartheid wouldn't have happened. Nelson Mandela was in prison for 25 years. Nobody cared about it. And when Nelson Mandela came to London many years later, he came to Brixton, which was not far from my house. I went to see him. The crowd that was there to appreciate him was unbelievable in London. There is a statue of Nelson Mandela. So I believe at the end of the day, goodness will prevail always. Goodness will always prevail. அதனால தான் இப்போ நம்ம சினிமாலெலாம் கூட ஆரம்பிக்கும் போது மங்களமாக ஆரம்பிக்கும்பான்னு சொல்லுவாங்க. முடிக்கும் போது அந்த காலத்தில் மங்களமாக முடிப்பாங்க. All the movies finish with a wedding sound. You've seen that in the olden days. I think we've lost that. இப்போ தான் பேய் படம் எடுக்க ஆரம்பிச்சிருக்காங்க. பேயை சாவடிக்கிறது மட்டும் கிடையாது. Front of us, they know they are telling lies. And they tell lies and use the lies to kill thousands and thousands of children and women and people. I think this has really affected me quite a lot in the recent past, that we have been polarized so much when we have to be one. And I want to, many of you would have heard or actually read and even memorized Rabindranath Tagore's Gitanjali poetry, where the world is, where the mind is without fear and the head is held high. He's dreaming of a world. He's not dreaming of a country. Actually, he wants his country to wake up in the world. I think people didn't see the world as fragments, where the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken up into fragments by narrow domestic walls, and where truth comes from the depth of heart. Where is the truth today? We know, people have seen people telling lies right in front of you. He knows he's telling the lie, and you know he's telling the lie. But the lies have to be told to justify action. And then, maybe for cardiology, where some of these lines I'm struggling now, where perfection really, where you're reaching your arms towards perfection. You can never achieve perfection. You can only actually try and reach your arms towards perfection. Cardiology is like that, isn't it? Or surgery is like that. Oh, I wanted to say, people think that surgery is actually perfection. Surgery, the word surgical strike, I don't know if you know the word surgical strike, was coined during Gulf War II by the Americans because it's so precise. If surgery was to be precise, cardiothoracic surgery wouldn't have died in front of cardiology. Actually, cardiology is precise, isn't it? You can go to the lesion and correct it precisely, whereas cardiothoracic surgery does so much harm. The surgery that is required to correct a small pathology is so huge that patients die of the effects of access to the area rather than to the surgery itself. That is why cardiothoracic surgery, I mean, I don't think it's died. You've almost killed it, haven't you? That nobody wants to do cardiothoracic surgery as a specialty. I think that's a specialty where most seats are available throughout the world. So it's not surgical strike which is really an accurate strike. Now, and finally he says, finally the line is that where the clear stream of reasoning loses its way, clear stream of reason loses its way in a dreary desert sand of dead habits. We all have beliefs. The reasoning is lost in this belief. I have heard people who will say, oh, I still do the surgery like my chief taught me. ரொம்ப பெருமையாக சொல்லுவாங்க, என் சீஃப் எப்படி சொல்லி கொடுத்தாரு அதே மாதிரி ஹர்னியா பண்ணுறேன்னு. நான் அவங்ககிட்ட சொல்லுவேன், you've not moved at all. I mean, he said that for habits, religious habits and things like that, where reasoning is more important than doing things for the sake of doing things. And I think in today's world, you need to keep moving on. We can't be thinking about the past and the glories of the past. And we need to work towards one world. Unity is what we need to be thinking about. And finally, I want to finish off again addressing the young people to say that this is a land of opportunity. I run a hospital. I run one of the largest liver transplant program in the world. We have 32 doctors in our liver transplant program, and everyone is different. Everyone's got a different talent. Some will be technically outstanding. They are not the best necessarily. Some would have common sense. Some would be very good with patients. It's a combination. You can't say that the best technical guy is the best guy that I have. The leader doesn't have to be the best technical guy. So I think it's the same with you guys in cardiology as well. We are all born with a talent. And I think if you have not discovered your talent, it is you who have not discovered it. You've gone into the wrong field. You're trying to do your best, learning something that you will never be able to learn. It's you who find out. So I want to leave you by saying something that Avayar says, because Avayar is somebody that I'm very fond of. Because she says, நம்ம திருக்குறள்லாம் உங்களுக்கு தெரியும், திருக்குறள் 2 லைனில் எல்லாத்தையும் சொல்லிடுவார் திருவள்ளுவர்னு. அவ்வையார் வந்து திருக்குறள் 2 லைனில் சொன்னார்னா அவ்வையார் 1 லைனில் சொல்லிடுவான். என்னென்ப என எழுத்தென்ப இவ்விரண்டும் கண்ணென்ப வாழும் உயிர்க்குன்னு திருக்குறள் சொல்லுவார். என்னும் எழுத்தும் கண்ணென தகும்னு அவ்வையார் அதே சொல்லிடுவா ஒரே லைனில். அந்த மாதிரி she says about this, about talent and you recognizing your talent, and I want you to think about it, to recognize your talent and not struggle with something that you want to be rather than what you are. வான்குருவியின் கூடு வல்லரக்கு தொல் கரையான் தேன் சிலம்பி. I'll translate that. உங்களுக்கு தூக்கணாங்குருவி கூடு தெரியும்னு நினைக்கிறேன். கீழே இருக்கும் ஹோலு, and then there is a room, and then inside will be the chicks. வான்குருவியின் கூடு வல்லரக்கு தொல் கரையான், கரையான் சிலம்பு, கரையான் புத்து, சிலம்பு எட்டுக்கால் பூச்சி சிலம்பு, தேன் கூடு. இது யாரால செய்ய முடியும்? I think even with modern printing it's impossible to do that. You can print it. They're talking about printing organs now, they're making livers now, but that will take time. But not your ability to do a procedure from here to Bombay. That will come, I think, very quickly. But to replace something that is there in nature, for us to think that we can replicate that is impossible. So she says that, Yan Periyan Vallame ena valimai solla vendangan. Don't think that you're the biggest guy on earth just because you have an ability to do something. Because all of those little creatures have an extreme ability which cannot be replicable. And she finishes by saying, Ellarkum ovvondrelidu. Everyone has a talent and everyone is able to do something which is easy for them only to do. It's recognizing what is simple for you is what will make you a big guy. And therefore the lesson to the achievers is not to be too arrogant, and the lesson to people who are trying to achieve something is not to give up on that thing. It's to struggle hard and strive hard and reach your hands towards perfection is the advice I would give to the young people here. Thank you very much.
I think he deserves a standing ovation for the excellent talk, Rila. The Cardiobase, really you have touched the heart, the base of the heart. And it's not only advice for the youngsters, even for the elders. Very, very good advice. And you quoted Avayar. We read Avayar regularly, but we didn't think a spider ஒரு செலந்தி கூடு செய்கிறது மாதிரி நம்ம இன்னைக்கும் செய்ய முடியாது. So excellent talk. Sir, நீங்கள் பேசுனது not only here, it has, please sit down. It goes to all over the country. We have got so many centers now listening. We are telecasting, and all the people who are not there also, they'll have a link, and we have recorded the talk. I think it's one of the good talk, and I request my wife, Dr. Bhanumati, and Sengotuvel's wife to honor the. Now we are honoring as a faculty, not as a lifetime achievement award. Please bring the faculty mementos. You please adorn shawl, Purnima, my wife Bhanumati. She's a gynecologist. This is ultrasonologist. Yes, adorn the shawl.
You heard me speak many times.
Pudunga. Moment, please. Give the memento. Sir, we don't normally give flower bouquet. We give fruit bouquet because we are hypertensive persons. The fruits contains fiber, fruits contains potassium. It is good for hypertension. So I always give them fruit bouquet to create the awareness.
It also contains sugar.
Not the sugar, yes. So I also now request Dr. Shanmugam, Dr. Sarat Kumar, and then Dakshin to honor our Vice Chancellor. Whenever we honor an outstanding person, we forget the person who presides over. So I think I remember, yes, please. Dr. Shanmugam and these three people are the stage managing, very well so far.
He was Vice Chancellor when the Iron Lady was in power. And that wasn't very easy, was it?
There was no interference.
No interference.
Leila, don't ask those questions in
Political
public.
questions. No, I'm telling the power of people, individuals. She had a huge presence there on that day, an enormous presence.
I think the awards function we can adjourn. One more time, Bobert Rela has completed more than 6,500 transplants. The youngest person whom we did was 5 days old, and the oldest one was 82 years old. All of them are still living. Good. Now I request Shanmugam to take over and conduct the next program. Shanmugam, over. Justin Paul, please come. Sorry, Justin Paul. Justin Paul, are you ready? Sipadacham?
Not this laptop. My laptop.
Yes, after the celebration, we are going to listen to our cardiologist, Dr. Justin Paul. He will be talking on cardio obstetrics. Why do we need a new subspecialty? Now, a lot of subspecialty is coming. I still remember Dr. Moses, our professor, he will say that, cardiodiabetology, cardiometabolic, cardioneurology, so many things he has, diabetic. Therefore, now we will listen to him. To chair this, I request Dr. Vamsi Mohan, physician, and also Dr. Namita, Professor of Medicine, MMC, to chair the session. 1 second.
Good evening, Dr. Justin. Cardio obstetrics is an emerging multidisciplinary approach
to treat cardiovascular diseases during pregnancy. And this can include hypertensive diseases, it can include aortic diseases, valvular diseases, congenital heart diseases, myocardial infarction, thromboembolic phenomena, and cerebrovascular diseases. I think with this introduction, I request Dr. Justin Paul to proceed.
Very good evening, all of you. It was such a pleasure to listen to Dr. Muhammad Rilla. Thank you for preponing his talk before my talk. And now I'm here to talk to you about the new field. How many of you heard the word cardio-obstetrics? Can I see show of hands, please? How many of you heard the word cardio-obstetrics? Maybe about 5, 6 or 10 probably. Now, let us see. If you look at the maternal mortality ratio across the world, you can see that from 1985 to 2023, it is coming down dramatically. But then if you look at what is there in China or Sri Lanka, we have a much higher MMR than rest of them. If you look at Norway, UK and US, our MMR is still very high. So if you look at the number of mothers who die during pregnancy, India contributes to the second largest number of mothers during pregnancy. Of course, our population is high, we remember that. So why are mothers dying during pregnancy? What is the importance of cardio-obstetrics here in our states? So if you look at that, most of the states in India have brought down their maternal mortality. Kerala, Tamil Nadu have brought it below 50. That is very good. But what happens when you start bringing down the maternal mortality is something that we need to recognize. If you look at UK, the single largest cause of maternal mortality is heart disease during pregnancy, cardiovascular disease. If you look at US, every third mother who died during pregnancy is because of a cardiovascular disease. Why is that? See, we call this obstetric transition. When a nation's healthcare improves, when the MMR starts coming down from more than 1,000 to say less than 100, less than 50, the contribution of the direct causes of maternal death start coming down and the indirect causes of maternal death starts increasing. So increasingly, we expect heart disease to be the major contributor of maternal deaths in the days to come in our country. Is it really true if you can look at that what is happening here in the nations with a high MMR like Pakistan, only 4.2% of mothers dying during pregnancy are because of heart disease. Whereas if you look at Sri Lanka, almost 1/4 of the mothers who die during pregnancy are due to heart disease. Now, is it true or happening in Tamil Nadu? If you look at what is happening in Tamil Nadu the last, say, 14 years, how many mothers have died? How many mothers have died of heart disease? What is our MMR? And what is the cardiac contribution of MMR? You can see that it has increased by almost 2 times as the MMR comes down. So unless we need to focus on improving the care of women with heart disease, these mothers are continuing to going to die, and cardiac diseases is going to be the largest contributor of maternal deaths in our country. The reason is we are identifying heart disease in younger age. We are treating them, complex surgeries, complex interventions, and they grow up to adolescent age group dreaming of becoming a mother. Now the existing situation is not really trained to handle these high complex heart diseases and these women coming during pregnancy. In addition, more women become pregnant much later in their life, that they have a higher cardiovascular risk. Another important point I would like to share with you is that this is in California. 68.2% of all maternal deaths due to heart disease could have been prevented by an altered care pathway. A staggering 68%. Do we have data like this in India? We don't. So the point I would like to share here is heart disease is going to be the single largest contributor of maternal deaths in our country in the years to come, and many of them are preventable. So this is some of the data that we had. So just to show one of the case, as you find that this primey, 18 years, switched over to heparin during pregnancy, she develops a valve thrombosis and dies. Her azithromycin dose is only 2 milligram. Safest would have been to continue acetrom. But unfortunately, this mother died. This is not just one. So many mothers we see like this. A complex patient like this, I do not think a single cardiologist or a single obstetrician will be able to handle the complexities to navigate this pregnancy and give them a safe delivery. So what really happens is, what happens if the baby dies? Looking at the harassing interviews and the reviews, many obstetricians would not like the patient, nobody would like to have a patient die. Cardiologists, okay, of course, hope they don't call me, because we are all very interested in structural interventions, deploying valves and deploying stents. We improve our knowledge base in that particular area. So there's hardly any coordination between these women, and this woman goes through all these complex issues, including domestic violence and harassment that she has to undergo at home because of the heart disease, complicating pregnancy. Do we have a confidential inquiry of maternal deaths in our country? Except Kerala, when it was started in 2003, we don't have like this in any other states. It is not it is more of a harassing inquiry than a confidential inquiry. So we really need to work on improving these things, like say, for example, what are the avoidable causes of death? What are the contributing factors to the avoidable cause of death? How it could have been prevented? These are some of the areas that we need to work on. Do we have guidance to manage Indian pregnant women with the heart disease? UK has, US has, Italy has, and we follow all these data and do it in India, where the Indian cardiac disease epidemiology is totally different. And none of these guidelines has a paper quoted from Indian authors. Hopefully in the coming 2025 ESC guidelines, our paper will be quoted. So this is one of our data. We found that preconception counseling, very few people have, but those people who have it have a better fetal outcome and a better maternal outcome. This is something that again we don't have it. So the summary here so far, I will say, that is paucity of Indian data. We don't really have an understanding and working together, coordination among the specialties, and not many are keen on improving this knowledge base. I'll move it forward. Yeah, these are some of the issues that we found as we started the Madras Medical College Pregnancy and Cardiac Registry, the single largest cardiac registry in the world as of now. So when we started collecting this data from 2016 to 19, we had data on 1,029 pregnancies, and majority of them were congenital heart diseases. And what we really found was those with pulmonary hypertension, those with prosthetic heart valves, those with LV dysfunction were associated with high maternal morbidity and mortality. And we find that particularly in prosthetic heart valves, there is a very high lack of coordination and non-uniform management processes and high proportion of avoidable cause of maternal deaths. And we published this, and there was a big editorial by the ROPAC registry chairperson where the three major registries of the world were compared, and we found that we have a very high maternal mortality and we also have very complex cases. So we found that 60% of the mothers had their heart disease detected for the first time during pregnancy, and we felt that a dedicated and trained coordinated cardiovascular care can improve the outcome. So we went ahead with a bigger dream. We started the Tamil Nadu Pregnancy and Heart Disease Registry, where we identified 29 sites, 6 private and 23 public hospitals, to see whether we can develop a cardio-obstetric team here and whether it can help to improve the maternal fetal outcome. And this was funded by ICMR, and NHM gave the administrative support here. And we published this methodology. And what we have is that, what we really focused on is everywhere we visited the participating site, we focused on the importance of networking them together, and we had created a cardio-obstetric social media group where they worked together, discuss every case, and we particularly focused on anticoagulant management of this pregnancy. And we had 2,995 mothers, of which we finally analyzed 2,863, and we found that maternal mortality had slightly come down, but more importantly, prosthetic heart valve related maternal deaths had significantly come down. It was no longer a predictor of maternal mortality. So we really felt that comparing our previous data, published data, and this one we presented to the European Society of Cardiology as a late-breaking science, we found that prosthetic heart valve is no longer a predictor of maternal deaths. And we also noticed that significant mitral stenosis was a predictor of maternal mortality, whereas in our Madras Medical College registry it was not so. The reason is that we have antenatal balloon mitral valvotomy, whereas 27 of the 29 centers there do not have it. So there are a lot of public health messages to the government that we need to, empower antenatal interventions in large volume cardio-obstetric centers. And this is compared to our non-cardio-obstetric care and cardio-obstetric care. It's a historical comparison. You find that maternal cardiovascular events are less, maternal deaths are less. Particularly in prosthetic heart valve, you see that there is a significant improvement in the maternal outcomes. So this was our conclusion that, the predictors of maternal death is a late pregnancy assessment was again an important predictor of maternal death. And we were adjusted to basically, this was our conclusion. And British Medical Journal adjusted us to be the best maternal and child health team of South Asia in this month, April, for our Tamil Nadu Pregnancy and Heart Disease Registry. And we didn't stop dreaming there. We thought, why can't we dream slightly bigger? So we went ahead with the National Pregnancy and Cardiovascular Registry Study of India. This is a multi-method study, a cluster randomization study, where we are developing a protocol for managing women with heart disease in India based on our own data. And the second part, we are doing a cluster randomization study, testing the usual care versus the protocolized cardio-obstetric care. And in case it works out better, we'll be recommending it to the government of India to make it its official protocol. With that big dream, we started working on this one. And these, except I think the ash-colored sites, we have a representation from all over the country. And ICMR has funded 8 crore for this study, which will go up to 2028. And as of yesterday, we have enrolled already 2,936 patients, and we are working on this particular area. So, this is our first investigators meeting. These are our prestigious investigators across the country. And we also have started something called Cardio Obstetrics Masterclass. Once in 2 months, we are conducting a masterclass on complex heart diseases complicating pregnancy, inviting experts across the country. One obstetrician, one cardiologist, one cardiac surgeon, one anesthetist will be in the panel. And we also have a knowledge sharing platform called Cardio Obstetrics India, where almost 1,000 cases, complex cases have been discussed, and experts across the country, in fact, many international experts are in the group. Many people share any complexities there, and the experts give their opinion. This has shared so many lives. So basically, my take-home thoughts are, what should we do? Now, what are we there? We already told you. The missing ingredients, so many of their good quality Indian data, Indian guidelines, risk stratification tools are all missing. So what do we do? My take-home views will be that cardio-obstetrics should develop as a well-recognized subspecialty. Though this is ideal, at least a cardiologist, obstetrician, a pediatrician, anesthetist should join together wherever high-risk mothers with heart disease are managed. We published this in Indian Heart Journal, how to develop this field in our country. These are the areas where a cardio-obstetric team can make a difference, and we showed that in the Tamil Nadu Pregnancy and Heart Disease Registry. So it is not sufficient because long-term follow-up, 15 years, 20 years, the outcome of these women are very, very bad compared to the rest of the team, so we need to work together. So wherever you are, if you are managing complex heart diseases, ensure that the physicians, please be interested in obstetric medicine. There are very good physicians in the area, say CMC Vellore, the maternal fetal medicine, obstetric medicine. The role they play is, in fact, our PI from CMC Vellore is a physician. And well, these are some of the thoughts that, we have to define what are the learning objectives in cardio-obstetrics. We should really help to define the role and responsibilities of a cardiologist and obstetricians. We should help to develop the research. These are the areas where we need to focus research on. If you're interested, please log on to the down. I'm just running fast. So that is all. These are the stepwise approach to improve cardio-obstetrics in our country. And we need to advocate for confidential inquiries into maternal deaths in all our states of our nation, except Kerala, which is doing this job. None of the other states are doing. I request you to advocate for it. Improve your knowledge base of our team. Even in API chapter, you can have a focus session on that. In cardiology chapters and obstetric chapters, nowadays we have 1 hour session, 1.5 hour session on cardio-obstetrics. We need to work on that. And wherever you are, create an executable SOP in for high-risk patients. And doctors should be empowered to do the appropriate counseling for these patients. And it's my sincere thanks to the team Cardiobase for this opportunity, and my thanks, and we dedicate this presentation to all these pregnant women who really taught us a lot in their delivery, in their distress and their death. Thank you very much for this opportunity.
Mind-blowing presentation. We know how passionate you've been over the years to bringing on this cardio obstetrics and the challenges that you have faced to bring this to the national level. And over to you, sir.
So in your practice, what is the most common CV disease you come across? Is it valvular or rheumatic or atherosclerotic heart disease?
Say I'm having a special focus on this for the last 10 years. Initially, predominantly, we used to have the valvular heart diseases, rheumatic heart diseases. Now, if you look at that, the incidence of complex congenital heart diseases are increasing. Cardiomyopathy is increasing. Coronary artery diseases are increasing. Now, we are having a garden variety of all these cases coming to us. Particularly, probably, we are in a tertiary referral center, and people do ask me across the country for their opinions. So, I come across all kinds of cases. But predominantly valvular heart disease, particularly if you look at the northern India, northeastern India, it's predominantly rheumatic heart disease. If you look at Kerala, it is predominantly congenital heart disease. The epidemiology is changing across the nations. As the healthcare improves, it's predominantly oriented to congenital heart disease than a rheumatic heart disease.
In what conditions would you completely contraindicate a pregnancy in a lady who comes for a counseling?
There are very few conditions that are completely contraindicated. Say decompensated heart failure, definitely HFrEF with the decompensated HFrEF, severe LV dysfunction, definitely the pregnancy maternal risk is very high. Or in patients with severe pulmonary hypertension or moderate to severe pulmonary hypertension, the risk is going to be high. Of course, patients have delivered with extra, but they need to be delivered in an area where heart failure management, ECMO, pulmonary arterial hypertension care and all is there. In such situations, we can save these patients. Or patients with the severely dilated aorta, coactation severely dilated aorta, or aortic stenosis and severely symptomatic aortic stenosis. These are some other conditions. Or symptomatic mitral stenosis, but then we can do a balloon mitral valvotomy and enable the patient to go for a pregnancy. Even severe AS, we can do a balloon aortic valvotomy and enable the patient to go for a pregnancy.
Yeah. Questions from the audience?
That is a good question. Role of biomarkers in early identification of. So yesterday, I think as I was walking in Apollo corridor, my friend Dr. Vijay Kumar asked me, "Sir, I have a patient, severe aortic stenosis, asymptomatic, gradient of 74, peak gradient. She is 16 weeks pregnant. What do you think about that?" So I said, in our experience, severe aortic stenosis, asymptomatic, they are very good. Please do a BNP. He said, I've just already asked for it. The BNP is normal and they are asymptomatic. By and large, they go through pregnancy without any difficulty. But early identification of decompensation, BNP, even particularly in hypertensive disorders of pregnancy, those with the high elevated BNP, the results in the risk of adverse outcomes are more. So BNP in pregnancy is definitely going to be helpful in early identification of complications. Come again? What dose of aspirin? Now, high-risk pregnancy and aspirin is predominantly in obstetrician's territory. For the cardiac diseases, we very rarely advocate aspirin, but by and large, obstetricians are advising 75 milligrams of aspirin. I'm not of course, obstetrician. Yes, sir.
Actually, prosthetic valves, metallic valves, I have never switched over from vitamin K antagonist to the heparin.
Sir, I want to clap you for this, sir. Seriously, I'm telling you.
I have not seen even one case of azithromycin embryopathy or warfarin embryopathy in my practice. Have you seen any case of warfarin embryopathy?
Sir, I think this is the message that I want everyone to have. Dr. Alagasan, after so many years of practice, professor is telling that I am continuing azithromycin and I have not seen a case of warfarin embryopathy and all the patients are doing fine. Whereas if we switch over to now the issue is, if we switch over to low molecular weight heparin, it has to be monitored by anti-10A activity. Without monitoring anti-10A activity and giving low molecular weight heparin, you may just find 1 or 2 successful pregnancies, but one swallow does not make a summer. The data is very, very clear that even the latest published data, where we published in European Heart Journal 3 months back, the ROPAC region, 444 anticoagulant prosthetic valve patients with pregnancy, the low molecular weight regimen was the worst. And if you are giving subcutaneous heparin, it should be, no role for subcutaneous heparin at all. The best thing will be, oral anticoagulants. Even if the dose of acetylene is more than 2 milligrams or warfarin is more than 5 milligram, still the chance of warfarin embryopathy is very low. I have seen one case of warfarin embryopathy that was actually in an abortus, stillborn baby. So the numbers are not very high, and you can always identify them by yearly antenatal ultrasonography, and you can do the needful appropriately. So the safest will be to continue VKAs.
Yes, sir. So wonderful presentation. Really, always enjoy your lecture. And what we observed in the hospital was the young individuals developing cardiac failure, especially after delivery or during the delivery. The cardiac failure rate is more in pregnant women. Is there anything related to the hormonal effect or to the volume by itself, or some changes in the heart occurring in heart failure patient with the pregnancy?
I think there are 2 types of diseases. There are 2 types of heart diseases during pregnancy. One is pre-existing heart diseases, and the second one is the diseases developed during pregnancy. The one that you are talking about is diseases that develop during pregnancy. During pregnancy, in the last few months or the first 5 to 6 months, that we commonly call peripartum cardiomyopathy. There is LV systolic dysfunction. Multiple etiologies are postulated. One of the common etiologies postulated is the prolactin hypothesis, where there is a mismatch between prolactin and the SFLTT1, and as a result these things develop. But the incidence as of now is not very high, particularly in India, and the recovery rate is good, particularly if you identify them early and manage them early.
Yeah, that's what is noticed in our hospital. Yes, thank you very much.
Yes.
Can you wind up? About prevention.
Yes.
Sir, you are speaking about prevention in utero prevention. Any steps you are taking now, sir?
Which one?
For preventing the cardiac.
One of the preventing steps is, what I think is I will say that organizations like API or organizations or non-governmental organizations, you will have to really join and advocate for certain things to be developed in the government. So for example, I can write a proposal, but depends on whoever is there on the chair and the tables, it may move. So one of the important things that I would like to have is that networking with the school healthcare with the taking this adolescent girls heart disease registry and taking it up all the way up to their pregnancy and childbirth. That is one way of recognizing them early and managing them early and treating them early. Of course, a detailed antenatal evaluation for heart disease is important, clinical evaluation.
The last question from Dr. Lakshmanan.
I think the cost effectiveness, at least do echo for a patient who is pregnant. I think most of the obstetricians, they don't do.
No, it is compulsory.
Sir, actually, Sir Lakshmanan sir's point is very valid. I have actually written an editorial for Jack 6 months back. Routine antenatal echocardiography is the time has come now, as was the question that I asked in the editorial. Where I have discussed is that I have discussed 2 actions, SANE versus RAIN. SANE is selective antenatal echocardiography, RAIN is routine antenatal echocardiography. I have really vouched for SANE rather than RAIN, because if you look at that, if you routinely do antenatal echocardiography for every patient, if your healthcare system is comfortable enough to organize that without increasing out-of-pocket expenditure to the patient and without compromising the quality of echocardiography for the rest of the patients, it is fine. But then instead of doing 300 patients echocardiography, start doing 400 patients echocardiography in the same time, the quality gets affected. So I'll be preferring a very selective, detailed clinical evaluation and choosing the patients for echocardiography, but nothing like that if you can do routinely antenatal echocardiography, if your system can afford that.
As per my knowledge, unless they undergo LSCS, most of them don't undergo echocardiography.
Maybe if there is some, I can share my editorials here probably.
Thank you, sir.
So one last question for you. So here, Namita. So one last question for you,
yes,
sir.
Namita.
So do we have the prenatal counseling centers where for this patients who are already...
So another important area where we need to advocate for is not only have a pre-pregnancy counseling centers, of course there are there in certain areas. We need to empower the medical fraternity or human resources to provide the right kind of counseling, because in the data we published from the impact registry, some of the counselings were not appropriate.
So maybe we need to train people.
Exactly,
for,
exactly.
Yes, sir. I think that was a wonderful discussion, and thank you, sir, for that discussion.
Thank you, chairpersons and the speaker. Now we will move on to the next lecture. I think it's again by our friend Dr. Sengotu Velu. The title itself I told no, it's very confusing for me. Clipping with confidence, redefining mitral and tricuspid valve repair with, I think, M tier and T tier. I think to chair this session, I think Dr. Vijay Kumar and Prabhakar is that? No. So in that case, I will request our close friends, Dr. Edilan and Dr. Sevakadaksham, to chair the session. Please.
Good evening. I welcome you all to the talk by Dr. Sengotu on clipping of the mitral and tricuspid valve. I mean, previously, all these patients will be at high risk, and doing a surgery for mitral valve replacement, especially in secondary MR or a tricuspid valve replacement alone, is rarely being done. But now, with the advent of this procedure, mitral clipping, you can do it easily. To talk about more on this procedure, we have Dr. Sengotu. Over to you, Dr. Sengotu.
Thank you, Edilan. So, I think it's difficult to understand this topic. I'll tell you the new therapy, what is known as TEER therapy. There is a TEER. It is called as transcatheter edge-to-edge repair. So, I'll tell you what it is. It is basically a procedure done without surgery for mitral valve and tricuspid valve. So this is again a big magnitude. Mitral regurgitation is a common problem, and it's in fact has a high incidence, particularly the secondary MR. The mitral regurgitation, let me talk about a little bit about the mitral valve. The mitral valve, it is between the left atrium and the left ventricle, and you can see the valve has got two big leaflets, the anterior mitral leaflet and the posterior mitral leaflet, two leaflets, and it's actually called a mitral valve apparatus because it has got cauda tendineae, which is attached to the papillary muscle, and the papillary muscle, as it contracts along with the muscle, it helps to open and close the mitral valve. So it's important. The mitral valve integrity is so important, so that the blood normally flows from the left atrium to left ventricle. So mitral regurgitation can occur mainly because two important etiology. One is it can be a degenerative MR. It can be any pathology like rheumatic or any pathology related to the valve, that is called primary MR, or it can be secondary MR. The primary MR of this one, what we are talking about, is a degenerative MR. We are not talking about rheumatic pathology because rheumatic pathology is generally not treatable with transcatheter. But degenerative MR, which is either a mitral valve prolapse or leaflets are altered, that is degenerative MR. Whereas functional MR is when the left ventricle is dilated, like in acute dilated cardiomyopathy or a post-ischemic cardiomyopathy. This is very common. It can be either due to atrial cause, like atrial fibrillation can cause atrial MR, or it could be due to LV dysfunction due to ventricular MR. So basically these are the two big spectrums. So the degenerative MR we commonly see in even in young patients with mitral valve prolapse with severe MR. And this is one of the causes where we need to have the early surgery. Whereas secondary MR usually happens in people who have a secondary to heart attack, an MI with papillary muscle dysfunction or a papillary muscle rupture or a caudal rupture. In elderly people can cause MR degenerative. So now, based on the etiology, whether it's degenerative, functional, we basically do a basic treatment. Generally, conventionally, surgery has been the conventional treatment for mitral regurgitation. But now about the functional MR, usually ejection fraction is low, and generally surgeons have no role because they don't operate when the risk is extremely high. So there is only option now with the new evidence coming up from many trials, transcatheter tear therapy. Transcatheter H2H repair is one of the big therapies which can be done for degenerative mitral regurgitation in young patient surgery, but elderly or young patients with extreme risk for surgery, we can still plan tear therapy. So the consensus guideline update also, the guidelines also now has updated. Transcatheter therapy is one of the important options to treat mitral regurgitation. So it all evolved from Alfieri stitch. So mitral valve like this there was a stitch made by Professor Alfieri from the anterior mitral leaflet to posterior mitral leaflet. Instead of one big orifice, the mitral valve is made to two orifices. And this was a stitch he did in 1991. And that is how this whole idea came up on this surgically this was not a very popular procedure, and in fact not many surgeons took it up. But then slowly this procedure was planned to do without open surgery as a transcatheter procedure. So what was done was you go and place a clip here so that you create a big orifice into two orifices. So that was the whole idea, and this actually Professor Alfieri, I had recently had the opportunity of meeting Professor Alfieri in his university, and we had spent time with Alfieri. Alfieri's originally the whole idea came because I believe he was operating and he saw congenital, he was operating an AST, atrial septal defect, and then he looked into the mitral valve which had a congenitally double orifice mitral valve. And when he looked at it, the patient was surviving many years with double orifice. He thought probably creating a double orifice probably does not do any harm. So he created double orifice surgically, and that is how the idea came. And he did one, and then he repeated the procedures particularly for anterior mitral leaflet prolapse. So that happened, and then now this procedure has now come to transcatheter procedure. So the concept is you put a clip between the two mitral leaflets like how, and create a double orifice. So this clip creates a tissue bridge, and as you can see down, the clip creates a tissue bridge and makes two orifices. So that is this is a bridge which forms. So this is how the concept came. So for subsequently the trials both for degenerative MR, Everest trial showed benefits, and subsequently the COP trial, which was again for functional MR, showed huge benefits. So the assessment is you do a transthoracic echo, clinically assess severe MR. Based on transthoracic esophageal echo, we decide depending on whether it is suitable for a clip. So it's a complex device. It looks like a complex device, but actually it is not. I mean, it is a bit of a learning curve, but actually we can do the success is you have to identify echo. Yearly you can identify MR, and yearly identification, particularly in dilated cardiomyopathy, if you do the MR yearly, then the prognosis is much better. And along with that, you have to always do personalized care with optimal medical management, which involves a lifetime management. So it involves this is how we clip the mitral valve. You can see two leaflets. There can be a caudal rupture, and there can be a frail mitral valve, and the mitral valve is frail. You can put in a clip through the left atrium. You come and put a clip and cast the clip and create two orifices, the mitral valve. So this is how it is done. I'll show you a small animation. You can see this is the mitral regurgitation. This is the mitral clip system, which is quite looking more complex, but it is a procedure which is quite
catheter is introduced
quite good learning curve, but it can be done. So this is how it is done. The procedure is done. Usually we take through the intravenous inferior vena cava. We go into the right atrium, and from the right atrium we want to puncture and enter into the left atrium by a septal puncture, and then we pass the clip through that catheter into the left atrium, and it is all monitored by transesophageal echo, and the clip can be easily positioned across the mitral valve, and then the clip advances just in front of mitral valve, and it should be oriented. The clip should be exactly oriented to the line of coaptation. So the clip is kept here, positioned well, open, and turned for orientation. So depending upon you can see this is a line of coaptation. You can turn the clip so that it is exactly perpendicular to the line of coaptation. So the clip should be like that. So you can see the MR, the blue color one is the MR, blood coming back to the left atrium. Instead of going one side, the blood is coming back. So to stop that, we take the clip inside, cross the mitral valve, and then we open the arms, and then we catch the leaflets, and then we close the clip and lock the clip, and the MR is completely reduced instantaneously. So we create a double orifice. So there can be increase in gradient, so we monitor for mitral stenosis. Usually the 1 or 2 clips doesn't cause significant mitral stenosis, provided the basic to start with if the area is good. So you can see now there are 2 orifices of the mitral valve, and then we can remove the catheter out. So, and this clip can be released, and the clip can be removed. So this is a very safe procedure, and it can be done in patients who can't undergo surgery, or patients who have severe MR with LV dysfunction who cannot undergo surgery. Surgeons will never do in a patient with severe LV dysfunction, post-MI, severe MR, papillary muscle dysfunction. These patients will remarkable improvement once the mitral regurgitation is completely gone, and then the clip gets endothelialized, and there was a tissue bridge formed. So the MR, which was significant before, is completely reduced with 1 or 2 clips. So results may vary depending upon the severity and the position of the MR. So we have done few cases. I can show you some cases. This is one of the cases what we did. Myself and Dr. Muthu. Can you just forward it a little fast so that we can show it to you? So we can show you quickly. So this patient was
asthmatic with atrial fibrillation, with severe mitral regurgitation.
You can see
I can see in the echo image severe flail of the P2 segment of the posterior mitral leaflet, and you can see that there's eccentric mitral regurgitation. Also, you can see a mild aortic regurgitation. You can see in the 3D view, you can see the flail P2.
This is the
this is also very clearly seen.
The mitral regurgitation. In the echo, you can see the mitral regurgitation.
We can see the posterior mitral leaflet with the prolapsed P2 segment. So the first step is to get a very good
we go from the IVC, cross from right atrium into the left atrium, using the intravascular echo, transesophageal echo. So this is you can see we're going from the right atrium into the left atrium. This is the left atrium.
The tenting of the needle.
See, we are just tenting and going through the foramen ovale. We cross into the left atrium.
You can see the SVC on the right. And this is for superior to inferior orientation. Now we have moved to short axis of the X-plane. And we can see the tenting now. It's more posterior. You can see the aorta on the right side. This is for anterior-posterior orientation. Once we are sure, then we can measure and see the height. Whether we have sufficient height is measured in the fourth sample view. The site of puncture should be at least here. We have 4.3. The site at least
so we check the measurements before we puncture,
so that we have adequate space to maneuver the valve in danger site.
So once that is done, then we take the clip inside.
And then
can you move it forward
to the dilator? And
okay, so I will move it little forward so the want of time. Can you show it please now?
the tip is
Okay, now you can see. Can you show it?
We're going to show a live twin box with one wire, and now we take the second wire.
Can you show the screen, please?
Which is placed in the.
Just be here, don't go over it.
Pulmonary vein to monitor the pulmonary venous pressure continuously.
So I'm trying to go a little forward so that I don't have to go much time and spend in the procedure.
So, patient, and before that, it's important to restore the.
What is the problem?
We're going to show a live in-box mitral clip recording. Our team includes.
I called you to make it simple, you're making it more complex. Doesn't matter, we leave it as.
positioned just above the mitral
Play
valve.
it now. What happened? Gone, huh? No. Beginning in, huh? It's coming
We're
from
going
the
to show
beginning.
a live in-box
What
mitral
did you
clip
do? I don't
recording.
understand. You made it by the beginning
Our
again.
team
Wait, yes, I don't want this. Just put only this.
So that the laptop, that screen is not coming on my laptop.
Yes, so this is a separate video. You can show it.
see a mild aortic regurgitation. You can see in the 3D is measured in the fourth chamber view. The site of puncture should be at least here. You have to align it properly into the guide.
Can I have the slides now? I'll stop the video. So the clip can be done, and we have fixed the mitral regurgitation, and I don't know why it doesn't work. Okay. 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 So several new evidence now says that patients with severe MR with LV dysfunction significantly benefit from this therapy. The Reshape 2 trial, huge evidence, and now also the tricuspid valve. It's one of the most challenging valves to treat, and it's been also called the forgotten valve. Patients with severe TR often are left with no options. Several patients with they are diagnosed very late. They develop secondary cirrhosis, and they are often very symptomatic. And the only possible therapy for these patients can be tricuspid TR, and tricuspid valve can be repaired using transcatheter H2H repair. So the message is tricuspid, transcatheter tricuspid and mitral tricuspid, transcatheter H2H repair is indicated. For MR, it is functional MR or high risk degenerative MR. And today we have Mitra clip as well as a MyClip from India, which is already a homemade solution. So TR procedure is versatile and for functional and degenerative mitral regurgitation and tricuspid valve disease, applicable to both mitral and tricuspid repair, highest safety profile in mitral valve interventions, available on the shelf and requires minimal planning. Thank you.
Thanks, Dr. Sangotavel.
I'm sorry.
Because for a very long time, whenever there is a rheumatic heart disease with pulmonary hypertension and tricuspid regurgitation, we used to be fixing a sort of circular thing into the right side, into the tricuspid valve, just below the tricuspid valve. And now this looks much, much easier than that one. And because they are degenerative valves. What is the chance of this clip getting dislodged?
See, it all depends on how significant leaflet tissue is anchored in the clip. So if you're able to have a good leaflet grasp, and if you're able to stabilize the clip, sometimes you put one clip, the clip can possibly, if you put one more clip to stabilize the first clip, then you have more stability. So what happens is, the mechanism of, for example, tricuspid regurgitation could be one due to leaflet pathology. More importantly, it is dilatation of the annulus. And that is why they put a ring, the surgeons used to put a ring to reduce the size of the annulus. So what we do is, when we put a clip, it also serves as an indirect annuloplasty effect, because by pulling the leaflets together, the annulus also is reduced, and over time the right ventricle gets remodeled and the size of the annulus comes down. And that is why even if you put a clip, it's very important to continue the diuretic therapy at least for the next 6 months to 1 year, so that the remodeling happens and the actual annular reduction takes place. So it's a combination of both correcting the leaflet as well as reducing the annulus. So normally we put only 1 or 2 clips from the septal leaflet to the anterior leaflet. So if you put posterior leaflet, even if you don't treat it, if you just put the anterior leaflet, it generally the TR reduction happens.
Do you have to give lifelong anticoagulation like we do in mechanical valves?
Sir. No need, sir.
Only antiplatelets.
Only antiplatelets. The issue is there is no need for any contrast. But you don't have to give contrast, because the patient procedure is done under general anesthesia, because they require a transesophageal echo to the entire procedure. It's completely TE guided. So imaging is critical, because we need to identify where the leaflet is, adequate tissue grasp. So imaging is the most crucial aspect for success of this procedure.
The 2 trials which came out for their initial, this co-opt and MITRA-FR, results were contradictory. And then subsequently what they found was that in addition to the TR procedure, if guideline-directed medical therapy was given, results were better. And then the reshape HF2 also confirmed that not only GDMT but also selection criteria is very important to get good outcomes from TR.
So what is important, this is about functional MR. When you have functional MR with severe MR in dilated cardiomyopathy, what they tell from the co-op trial, what they said was, you have to identify these patients very early. Once the ventricle is hugely dilated with EF less than 20%, and those patients don't do well when the mitral clip is done because it's too late. So if you identify early, when the left ventricle is not much dilated, you can still approximate the leaflets. Then the co-op trial showed a huge promising benefits for these patients. So identifying the patients at the right time and using the co-op criteria is very important for success of functional MR.
Few comments. The mitral valve tear may be a successful one, especially in the short term and maybe in the long term and all that.
Sir, it is extremely useful in elderly patients with papillary muscle rupture.
I agree. But the tear is not going to be that easy. It's not going to be that useful.
Which one, sir?
Tear. The tricuspid edge-to-edge repair is not going to be that easy, and it is not going to be that useful also.
No, sir.
Because there are two or three reasons. One is the tricuspid leaflet anatomy itself is extremely variable. There can be, instead of 3 leaflets, there can be 4 leaflets, 5 leaflets, up to 6 leaflets. The second one is the tricuspid annulus is not fibrotic. There is no fibrotic tissue around the tricuspid annulus. Even if you do a DVEGA or you do a ring annuloplasty and everything, it is going to stand for some time, but it will fail. So that is the second issue. The third one is the severity of the tricuspid regurgitation. We don't recognize or treat the moderate or severe. We allow the tricuspid regurgitation go to a very, very severe category, then think about tricuspid edge-to-edge repair and all that. At that time, nothing can be done. None of the treatment is going to be useful.
Sir,
those are the 3 points.
It is now widely recognized and it has been increasingly used everywhere, the tricuspid tear. And we have done one patient. And normally, I'll tell you why it is beneficial. As you said, tricuspid is more complex. The leaflet numbers are variable. Usually, the leaflets are 3. The anterior leaflet, posterior leaflet, the septal leaflet. There can be multiple leaflets, 4 or 5. But the most important part is the septal leaflet it's got a fibrotic, it is more tissue. Whereas, as you said, rest of the leaflets do not have much support. That is why this annulus easily dilates. So if you're able to pull the septal leaflet with any other leaflet, posterior, anterior leaflet, you're going to have a more of an anchoring effect in reducing the annulus. So that is the whole idea of tricuspid tear. So you have to do from the septal leaflet, one should be always be septal leaflet. The other part can be anterior leaflet. And second, the magnitude of TR reduction will not eliminate TR. The TR is not going to go away. It is from torrential TR to moderate TR or mild TR, and that goes a long way in reducing the symptoms of the patient. And there is also an elegant study where they have shown combining both, because these are all from surgery. When they do mitral surgery, they also do tricuspid valve repair. Similarly, patients who undergo severe MR, severe TR, patients mitral valve, when they do the mitral tear, they are also now doing tricuspid tear simultaneously, and the initial results are encouraging. So tricuspid tear is one of the areas where it is really growing, because the options for treating the tricuspid valve are very limited. Now there are certain valves which are not suitable for tear therapy for tricuspid valve. There are also valve replacement has come called evoke valve, which is not yet available in India. But today we are the only percutaneous option is tear, which is available in India. There is one more option, which is the trick valve, which has been shown to be not as effective because it's only a temporary solution, whereas the tricuspid tear appears very promising.
Thank you, Dr. Sangutuvel. For want of time, I think we'll close the session and go to the next talk.
Thank the chairpersons and the speaker. I will move on to the next one. I think the speaker is none other than our close friend, Dr. N. Sivakadaksham. He is one of the senior interventional cardiologists, well-known orator, and he is going to talk. The debate is over finally over the choice of diuretics, CTD versus hydrochlorothiazide. For this, I request Dr. Lakshmanan, his own close friend, and also Dr. Parandaman to chair the session.
I think Shiva is an excellent speaker, well-renowned cardiologist, my best friend, my classmate. I know Shiva, I remember when you are in house agency, we used to give hydrochlorothiazide, nothing less than 50 milligrams.
Yeah.
Next year the BP is not come down, they say go to 100 milligrams.
Acid drugs.
Yeah. We don't know how many people we produce diabetes, how many people we kill by adding. We never knew that the drug can cause so much hazard when you use it in a higher dose. I think they expose everything. Now the chlorothiazide is a boon to the practice. It has got a much more effectiveness, safety profile than the hydrochlorothiazide. To say everything, I think I welcome him to his talk on the topic.
Thanks. He has already given the result of the debate. See, JNC 6, if you look at the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, diuretics like thiazides, hydrochlorothiazide, were recommended as a cornerstone of initial antihypertensive therapy. This was the thing in up to 1997. As Dr. Lakshman was telling, we used to use only hydrochlorothiazide in a dose of never at 12.5, 25 or 50 milligram. Even though all of us know there is hyperuricemia, hyperglycemia and hypokalemia associated with such high doses of hydrochlorothiazide. JNC 7, if you look at it, 2003, in trials comparing diuretics with other classes of antihypertensive agents, diuretics have been virtually unsurpassed in preventing the cardiovascular complications of hypertension. In the ALHAT study, in which more than 40,000 hypertensive individuals were treated, there were no differences in the primary CHD outcome or mortality between the thiazide type diuretic chlorthalidone, the ACE inhibitors, ARBs, calcium channel blocker, amlodipine. So ALHAT study very clearly said, if you look at the total outcome morbidity and mortality, thiazides like diuretic chlorthalidone has scored equally if not better than ACE inhibitor and amlodipine. Chlorthalidone is considered as a first-line medication for treatment of high blood pressure. Some recommend chlorthalidone over hydrochlorothiazide. So we should know which is better. A meta-analysis of randomized controlled trials found that chlorthalidone is more effective than hydrochlorothiazide for lowering the blood pressure, while the two drugs have similar toxicity. Now, when you talk about reduction of LV muscle mass, whenever you treat a hypertensive, the prognostic factor is by either by ECG or by echocardiography is left ventricular hypertrophy. Any drug in the anti-hypertensive armamentarium, if it can reduce the LV muscle mass, left ventricular hypertrophy, that is a preferred drug. Normally, when you come to diuretics, it is written that diuretics cannot reduce the LV muscle mass. But among the diuretics, there is evidence that chlorthalidone is superior to hydrochlorothiazide for reducing the mass of the left ventricle of the heart in persons with enlargement or left ventricular hypertrophy. There are one more effect for chlorthalidone. Chlorthalidone reduces the amount of calcium excreted in the urine, reducing the risk of calcium oxalate kidney stones. In people who have had multiple episodes of calcium oxalate kidney stones, chlorthalidone lowers the risk of having another episode of kidney stones. So chlorthalidone is more effective than hydrochlorothiazide for lowering urine calcium levels and is therefore probably more effective. Now, what about the meta-analysis? We will go into it. Comparison of the effectiveness and safety of chlorthalidone and hydrochlorothiazide in patients with hypertension, a meta-analysis. The outcomes assessed in this meta-analysis included the changes in systolic blood pressure, diastolic blood pressure, myocardial infarction, stroke, and all-cause mortality. Our analysis showed that chlorthalidone was superior to hydrochlorothiazide in controlling both the systolic and diastolic BP with no significant heterogeneity reported. However, there was no significant difference between the two groups in terms of risk of myocardial infarction, stroke, all-cause mortality, and hospitalization due to heart failure. Hypokalemia rate was reported to be slightly higher in the chlorthalidone group. Even though chlorthalidone and hydrochlorothiazides are structurally similar compounds, they are quite different pharmacokinetically because hydrochlorothiazide is different from chlorthalidone in that the latter has a long half-life and a large distribution volume because of its extensive partitioning into red blood cells. That is, chlorthalidone has a long half-life and it is present in red blood cells for a prolonged time. The half dose of chlorthalidone is more effective in reducing systolic blood pressure compared to hydrochlorothiazide, primarily due to its BP lowering efficacy throughout the nighttime hours. So therefore, it is a drug that is preferred, especially in people who have an early morning rise in blood pressure. Differences in the persistence of BP lowering effectiveness would play an important role in differences in arterial stiffness and central BPs. 4 studies compared the changes in systolic BP from baseline. The mean reduction in systolic BP was significantly greater in patients receiving chlorthalidone compared to patients receiving hydrochlorothiazide. A pooled analysis of 4 studies assessing the change in diastolic BP also showed that the mean reduction of diastolic BP was significantly greater in patients receiving chlorthalidone compared to hydrochlorothiazide. Now, myocardial infarction and stroke, as we have told in the beginning of the lecture itself, there is hardly any difference in reduction between the two groups. All-cause mortality also showed no significant difference between the chlorthalidone and chlorothiazide. Hypokalemia. The hazard of hypoglycemia in patients receiving chlorthalidone was significantly higher compared to patients receiving hydrochlorothiazide. So it is always, whether you are treating a plain and simple hypertension or a hypertension with cardiac failure or hypertension with kidney disease, what is mandatory is after starting the patient on chlorthalidone, you should recheck their electrolytes at least once in 3 to 4 months. So summary, all over the world hydrochlorothiazide was used more often than chlorthalidone. However, in recent years it has been actively debated whether chlorthalidone and hydrochlorothiazide need to be considered as interchangeable agents, but the evidence indicates that chlorthalidone may be a more favorable option than hydrochlorothiazide. If you ask who is the best between Tyson and Ali, it is difficult to answer. Between Sachin Tendulkar and Kohli, it is very difficult to answer who is the better one. And similarly, between Messi and Ronaldo, it's very difficult to differentiate who is better unless you see each and every play that you analyze. Similarly, what was good 20 years back was chlorothiazide. Today, what is good, effective at a lower dosage is definitely chlorthalidone. So CTD is powerful in low doses than hydrochlorothiazide. Thank you.
So thank you very much, sir, for a wonderful presentation. It's a very clear message that chlorthalidone is better than hydrochlorothiazide. But my small query about this is that we are in a tropical country where the sweating is more, humidity is high in a summer time like this. If you already we have a lesser amount of water in the body because of sweating. If you give diuretic in those situations where the hyponatremia is very common. So we now come across, especially in summer, a lot of admissions with hyponatremia is there. So in those situations, what you like to do, whether to continue hydrochlorothalidone or to substitute something else?
I am yet to see a patient who is not on loop diuretics coming with dehydration or hyponatremia with these small doses of chlorthalidone and chlorothiazide. So chlorthalidone small doses, and all of you know, how many times does it increase the urination? Once? Probably only once, not even twice. So I think it is a safer drug. In such situations, what is important is, among the diuretics, indapamide is shown to cause more hyponatremia than chlorthalidone and chlorothiazide. Hypokalemia is more often reported, but day-to-day practice, there are some articles which I have read. In long-term usage for hypertension, if you use a chlorthalidone or chlorothiazide, you do not come across hypokalemia. There are also several papers stating that. So it's a very safe drug. I don't think they can cause any dehydration or electrolyte imbalance.
Yes. Elderly also safe, sir?
Elderly also same. Only thing is we have to take care in elderly, naturally, because if you are going to adhere to salt restriction and a diuretic, definitely they will have a hypokalemia. Elderly by themselves, they are prone for hyponatremia.
That's what, sir. Thank you, sir. Thank you very much.
It's a very weak diuretic. People taking SGLT inhibitors, they are also on the chlorthalidone. One should be cautious. Must take them at least to drink one more bladder full of water.
The importance of diuretic in antihypertensive treatment is not only as a separate entity, it augments the work of beta blocker, augments the work of ACE inhibitor or ARB and calcium channel blocker. That is where it scores. When you use some of the calcium channel blockers, they are not very effective individually, but when you add it with a small dose of 12.5 milligram of chlorthalidone, the effect is superior.
I don't know. I use some of the elderly people weekly twice chlorthalidone, Wednesday and Sunday, because the longest acting drug doesn't cause the dehydration and the hypokalemia.
Even SGLT2 sometimes I prescribe on alternate days. They do well when they are having severe dehydration or the muscle cramps, etc. And the recent article put that now SGLT2 also will be useful maybe in calcium related renal stones also. I don't know how it works. Yes.
I think only the nephrologist should be able to answer.
Any questions from the floor? Yeah, Aditya. Use the mic.
Sir, good afternoon, sir. Sir, chlorthalidone role in case of long-term hypertension, sir. Whether you use for long-term hypertension or whether you want to replace it when we are using for a long-term patient, sir.
All the drugs in hypertension are for long-term usage, and diuretics especially. And when it comes to treating elderly hypertensive, wherein you get a lot of isolated systolic hypertension, beta blockers are of no use because there is blunting of the autonomic nervous system. There are only two drugs that you can use in elderly isolated systolic hypertension, diuretics and or calcium channel blockers.
Thank you, sir.
I think Canadian hypertension recommends 3 drugs, ARB, CCB plus chlorthalidone. I think all the 3 will be effective in ISH. You can add all the 3 or one by one you can add. Thank you, Shiva.
Thanks, Lakshman.
Wonderful lecture.
Thank you, Dr. Sivakadaksham and the chairperson. I will request both the chairperson to stay there And also, I will request Dr. Namita to come to the stage. Therefore, they will be discussing the panel discussion on chest discomfort. I think please be brief so that we can accommodate other times improperly. You can initiate yourself. You want to have, no? Muruganathan? You want to join? Sir. Appa innoru chair podupaanga. Chair. 4 chair. Yes. Now somebody initiate.
I'll share my experience.
Yes.
I tell you, when a diabetic comes with a chest discomfort or some atypical chest discomfort, even the ECG is normal, you have to always rule out coronary artery disease. I tell you, one of the very leading gynecologists brought her husband, very leading lawyer in Chennai. When they came to me, they already had 2 ECGs. I took a third ECG or normal, and but the symptoms are very typical of angina. Because he's a very leading busy man, I said, you better go to a corporate hospital, get admitted, do an angio, and then proceed. So I gave a letter to the hospital concerned. He went to the hospital there. They kept him in the ICU for 6 hours, and the cardiologist, probably the senior, were not available. The junior said, nil cardiac, madam, you can take him to the house. She came by 11 o'clock and called me. She was kept shouting at me. For nothing, you threatened me and then you sent the patient to a corporate hospital, expenditure. Madam, they didn't do any angio or troponins. They say troponin is negative. They say the angio is not required. Exactly by 2 o'clock in the midnight, he developed a massive myocardial infarction. Went to the same hospital, early morning bypass surgery. He was in the ventilator for 2 months and died. So the message is very clear, loud and clear. Diabetic patients, when they especially come in the midnight, I always tell my staff nurses, be careful. The duty doctors may not know. They are all budding juniors. But when a patient with diabetic comes with a chest discomfort, normal ECG, normal hemodynamics, but still the patient has to be kept for a minimum 24 hours to rule out the patient is not having any coronary artery disease.
The idea of introducing this subject, chest discomfort, every day the practitioners come across some form of chest discomfort. That is why we had a panel of one pulmonologist, Dr. Tilakavadi is supposed to come. Please come. Please welcome Dr. Tilakavadi, the pulmonologist. And then Parandaman is general physician. Of course, Dr. Lakshmanan is a pseudo-cardiologist, and Sivagadacham is also there. So we can always have different people. Dr. Namita also is there. See, first of all, you must know, when you say chest discomfort, it can mean anything. It can be pulmonary, it can be bone, rib, or it can be cardiac. So the recent classification about the chest pain, the ACC says cardiac pain, possibly cardiac pain, and non-cardiac pain. Again, cardiac pain is divided into coronary pain and non-coronary pain. Again, coronary pain is divided into acute coronary, chronic coronary. So like this, the classification has come like that. So that's why every physician, every practitioner should know about the chest discomfort. The point what Lakshman made is very, very important. Many times what happens, they take a ECG from the beautiful machine, and the machine says ECG normal. And many times when the ECG is normal, the duty doctor says everything is normal. We lost 3 patients in the last 1 year by looking at the ECG by the machine. So the message is, if the symptoms are very typical, even if the ECG is normal, please observe or admit him. See, we lost 3 patients recently. For that only, the STEMI people have introduced a project called, I want to inform everyone, called Chest Pain Clinic. What they are doing now, they want at least 30 practitioners or physicians who can volunteer them. They will be giving one ECG machine, which can detect artificially intelligent way whether this ischemia or no ischemia. And they also give point of care troponin measurement. Then the three, they'll give an expert opinion on ECG over the phone and also guide you where to go. If there is any suspicion, they'll say go to the place where you can do thrombolysis or where you can do stunting. So at the end of the meeting, if somebody is interested, we are giving this offer for 30 physicians. We'll give free ECG machine, and then we give point of care for the troponin, and also we give expert opinion on everyday problems or ECG through WhatsApp. Why we have chosen like this is because we want to avoid, like what Lakshman said, unnecessary death. So this is one information. And once you are very comfortable after, say, 6 months of pilot study, they may charge 7,500 rupees per month for their service, like they're giving machine, they give troponin, etc. For you to understand where, everybody can make a mistake. The famous Paul Wood. Paul Wood is the one person who wrote a book on cardiology. He knows what is just discomfort. But when he developed problem, he didn't know it was a heart problem or ischemia. He died of heart attack. The person who has written a book on Paul Wood cardiology, but he was a smoker. So like this, anybody can miss chest discomfort. So that's why we have taken this topic. Now we'll talk from the Tilakavati is one of the leading pulmonologists. So we'll start from her. What are the common causes of chest pain or chest discomfort in pulmonology, Tilakavati?
At the outset, thank you very much, Cardiobase team, for having me here. It's a honor and pleasure to be here among this elite group of cardiologists. So I think it's a teamwork whenever there is a patient with chest pain or some breathing difficulty. It's actually a very good teamwork which comes out with the diagnosis. But from the lung side, I think the most commonest in an emergency is we should think of pulmonary embolism, pneumothorax, as far as the lung side is concerned, and acute exacerbation of COPD and things like that. I think no patient walks out of the textbook like, they have only coronary artery disease, they have only COPD, they have only pneumothorax. It doesn't happen like that. If it was that simple, then there is no need of any panel discussion. So it's actually a combination where the patient comes. So teamwork definitely helps. From the, as you all discussed, that acute coronary syndrome, you lose patients. So this is also like an emergency, like pneumothorax, acute pulmonary embolism. I think these are the common conditions from the lung side where we get. The other things are a little bit chronic. This is what is life-threatening in an emergency.
Namita, having listened to pulmonologist, as a general physician, what are the non-cardiac chest pains every day you come across?
So we do get many patients with non-cardiac chest pain, as simple as a GERD or a heartburn, they come with that, or an esophageal problems, they do come to us. And also not to forget about that the basic undergrad teaching where we tell them that if they are able to point a finger, then it is not an anginal chest pain, it could be a costochondritis, musculoskeletal pain. So all these are what we usually come across. And as going back to the basics, what we tell them is, first look at the patient, whether he is acute, is it a life-threatening episode of chest discomfort. Think of myocardial infarction, other cardiopulmonary causes is like what Madam said, and then finally think of the non-cardiopulmonary causes.
Parandaman, can you tell me what is the difference between esophageal producing dyspepsia or discomfort or cardiac discomfort? Clinically bedside.
Esophagus, yes, thank you. First of all, thank you very much, sir, for Cardiobase having given this wonderful opportunity to discuss on this. The esophageal problem, esophagitis, that typically mimic cardiac anginal pain. This also retrosternal, cardiac pain also retrosternal. But one difference is, this pain will radiate to back. The esophageal pain will be prolonged for minutes to hours. But ischemic pain lasts for 10 minutes to 20 minutes to 30 minutes. If it is infarction, more than 30 minutes. By the time you get also symptom. So whenever you say pain, there are 5 things you should look for. What is the site of the pain? retrosternal, back, or whatever side. What is the character of the pain? There are so many characters. Stress, that is squeezing pain, piercing pain, tightness, heaviness, pressure-like pain. There are so many descriptions there. So that will give the clue which origin from. So site of the pain, type of the pain, then is there any radiation? Radiation to the arm, shoulder, and radiation to the fingers, wrist. Then is there any associated factors? This all matters. With this itself, you can tell what is the pain is, what the origin is. What is the associated factor? If it's also giddiness, palpitation, sweating, more likely cardiac. If it's also pain during swallowing, pain aggravated longer duration, aching pain. It is not a squeezing pain, aching pain, esophageal pain. Pain aggravated on lying posture, aggravated, this is esophageal pain. So, and sometimes very difficult to say this is esophageal or cardiac, then you go for a marker. ECG, the sir was telling, Dr. Lakshman was telling that ECG, this is know that 65 to 70%, 65 to 70% only it is sensitive. 30% it will not pick up. Whereas specificity is 85 to 95%. So if ECG is negative, doesn't mean there is no ischemia. So that's what the learned physician and of course astute physician immediately picked up this myocardial infarction. He is sent to the center because even though 2 ECG was normal, that is what the pain, character of the pain, radiation of the pain, and then associated features, comorbids, this all decides. So this is how the esophageal pain is a prolonged pain, retrosternal pain, aggravated by lying posture, radiated to back, not to the shoulders, and it is relieved by water or antacids and worsened by supine posture. Whereas a cardiac pain is not, and duration of pain is almost all the pain of non-cardiovascular pain lasting longer duration. Whereas cardiac pain lasts only by shorter duration, except myocardial infarction, where lasting for more than 30 minutes. And of course, before that we intervene. And also, in this situation, when you are confronted with such a difficult situation where the cardiac or esophageal pain is there, immediately go for ECG. ECG is the one will pick up as early as minutes, 2 to 3 minutes to 30 minutes, which you pick up within earlier stage with tall T waves. But the sensitivity is less, 70%. Specificity is high. 2, the markers, biomarkers we do. We have every hospital, we have troponin I, troponin T, troponin I will be there, is there, we can do. And what is it? This will pick up only 2 to 3 hours later, minimum 2 hours. But literature is there is a heart specific free fatty acid binding protein that picks up as early as 30 minutes. If a facility is available, we can go for heart specific free fatty acid binding protein that you can pick up earlier than the troponin. But okay, troponin will last for longer.
Thank you, Parandaman. Yes. So another thing also, esophageal pain, when you stoop, it will get more. And when you give nitroglycerin, esophageal pain also is relieved, heart pain also is relieved. But it takes more time for esophageal pain to relieve. But chest pain, ischemic pain will be relieved immediately with the nitroglycerin. So these are another few points, in bedside we can do. Lakshman.
And how many people still believe that the Levine sign, the clenched fist? Last week a patient came, sir, I have a discomfort. This man has found out the symptom in 1813, Levine. Levine sign is still holds good. Patient comes and says, clenched fist, that has got a chest discomfort. Most likely it is a coronary artery pain. Another patient came with a very typical annual pain, diabetic patient. We admitted. Very third day he developed a herpes zoster, especially when they left a D4 dermatome. The pre-eruptive zoster pain exactly mimics like a cardiac pain.
Yes. Yeah. Now one more thing, in clinically, if you get a rub, do you know whether it is especially left side, pleural rub or pedicular rub? How do you differentiate?
So you start from the history. I know, like if you have a sharp localized pain, it is mostly pleuritic. And then you auscultate, you look for other signs of pleuritic involvement, referring to the shoulder, sometimes if the diaphragm is involved. And then pain, which stops when you stop breathing, and then it is associated with breathing, then it is clearly a pleuritic pain. Then on auscultation, you will typically have a sharp localized pain, and which disappears on breathing. When you stop breathing, it disappears, whereas a pericardial pain doesn't do that. Your pericardial pain continues and it's related to your cardiac issue. So, and then very difficult to, it is localized. Pericardial pain is localized, even pleural pain is localized, but the sites are different. That's the only thing we should remember.
Yeah, Sivagadacham, what is triphasic rub?
You tell yourself. I do not know.
Yeah, Parandama.
Excellent point. When you talk about rub, triphasic rub, pre-diastolic, systolic and diastolic. 3 phases will be there. That is present mainly in the base of the heart, not in the apex of the heart. The pain of pericardium is seen by the finger, that is noted by the finger, because the lowest part of the pericardium is pain sensitive, other part of the pericardium are not pain sensitive. That's why it's point to the apex. Whereas the rub is seen in the base, where it is close to the sternal angle, 3 phase will be the triphasic pain. That typically present in all phases. That is, it does not vary with the respiratory changes. Especially the lung cause, where deep inspiration, they will have stopping of the rub, whereas in the triphasic pain, after even keeping the respiration hold, you can continue to hear the 3 phase of the rub. That is very typical. Any patient with that will be better heard when sitting and leaning forward. Any pericardial pain will be better heard when sitting and leaning forward, because the lung is wide apart, the heart close to the chest, so you will hear all 3 phases. So
Pradhaman, I will accept this for an examination answering.
I tell you.
Do you follow all those things?
Shanmugam.
Yes.
I never seen a cardiologist carrying a stethoscope.
Yes. Now they don't want to
I
have.
think must ask Sivagadacham, how many people you auscultated? I don't know. You are a conservative cardiologist. No, I mean, youngsters, I've seen many corporate institutions. I never seen them carrying a stethoscope. I don't think it's a rub everything. Straight away with chest pain, they are pushed into the angio.
No, but still.
I think the most important thing for a cardiologist is history. History taking is the most important. Patients are very clear nowadays. He says, I am a smoker. He says, I am a diabetic. I have a varied kind of pain. The diabetic is able to say that it's not the typical chest pain. But what is most important is most of the people say it is exertional angina which is relieved by rest. That one word is sufficient. Sir, I've been walking daily, but now for the past 10 days, if I walk for 10 minutes, I have to stop for a while and then continue walking. And that is what is called second wind angina. They stop for some time and then continue walking, their angina disappears. So this is second wind angina. So most important is history. Next, as you say, is stethoscope. There is no doubt. Third, when AI came, people asked me, what is AI, sir? Artificial intelligence. I said AI has done a lot of good for cardiologists because all the ECGs are reported as abnormal. And that's how they come to a cardiologist.
The esophageal pain and cardiac pain, the pain goes to the jaw.
Yeah.
Patient classically will say, I have jaw pain, sir. That's a very classical signs of coronary artery disease.
You got 4 minutes.
Sometimes I seen one Madurai diabetologist had a severe pain. He went to a dentist. The dentist saw some infected tooth. She wanted to extract it. She gave an injection, he fainted, and then he was proved to have acute MI, he died.
The reason, Lakshman, why I have chosen this topic, when you say chest pain, people know what is chest pain, but I have given chest discomfort. Because this Harrison, 2022nd edition, they say chest discomfort. They don't say chest pain. They say chest discomfort. Though it is chest discomfort, it need not be in the chest. Again, though we say discomfort, it can be discomfort or pain. So one should not get mistaken by the history. So as Sivagadacham says, we always remember E, exertional, emotional, exciting. All these E can produces pain, and that also gives a history. So even now, in the era of artificial intelligence, clinical examination, history taking is very, very important. That's why we have taken this point, because bedside you have to decide what investigation to do. You should not waste time. So now,
Muruganathan, you got 2 minutes.
Okay, thanks.
Yes.
I'll ask Namita one message, Lakshman one message, Parandaman, and finally, Madam. You have one message on chest discomfort.
So again, as Sir said, I would reiterate on history taking again, and according to the history, go for the investigation. So that would be my message.
Lakshman.
Yeah, comorbids. Just discovered the comorbid conditions. And one more risk is now the guys who work in the IT industry, young people, they eat as many times as possible. They are the high risk group. So beware that even a youngster comes with a just discomfort. Our duty to rule out that it's not coronary.
Parandaman?
So I like to mention this particular point. Most of the patient comes in the midnight with chest discomfort. We take an ECG normal. We give as usual do pantoprazole antacid, patient become clinically all right. We send home. That is a normal thing because ECG normal, patient improved with the antacid, pantoprazole, and patient was all right. He himself went and we also send. And subsequently they come. What is the mechanism is that the reflux of acid into distal 1-2 centimeter of the esophagus cause coronary spasm. That's called afferent vagal stimulation causing coronary spasm. So this patient has to be admitted, as already SSL sir said, admitted and evaluate for this thing, so that you should not miss it, because the reflux of acid itself will cause coronary spasm in a patient already having the potential injuries to the lower esophagus. So especially in the midnight, they come with the dyspepsia, ECG is normal, respond very well with the pantoprazole with the antacid. Please admit him, evaluate, and wait for the repeat ECG and troponin I, so that we will not miss that patient because maybe a MI patient.
Thank you, Parandaman. Now,
I would say it takes less than a minute for a good clinician. Use your eyes first. So look at the breathing. If there is a paradoxical breathing, you know it's diaphragm problem. If there is a sweating, diaphoresis and a chest pain, you know it is cardiac. And put the stent next. Now you used your eyes, now use your ears. If you see diminished breath sound on one side and things like that, you know pneumothorax and things like that. If your cardiac issue, you can also pick up from the stethoscope. The third important is the POCUS, that is your ultrasound. In less than a minute, it can diagnose pneumothorax, it can diagnose pneumonia, it can diagnose pleural effusion, it can do anything. It is important that you know how to use it. And the fourth important is the saturation monitor. So with these four things, I think in less than a minute, any good physician can diagnose whether it is cardiac, pulmonary, or any other cause of chest pain. Thank you.
My message, one more message is, if you are a good clinician, mostly 90% of the ladies, when they come younger age, they will have a functional chest pain. You can easily identify functional chest pain with all the, what are the signs. They will have action like, they are breathless and things like that. So when you are very comfortable in the diagnosis, there also, if you tell the patient attenders to admit, they will admit. Because she comes for admission only. So you can take serial of ECGs also, but you are pretty well sure that it's not a cardiac pain. After 2 days, the patient will feel that you relieved the pain, you relieved everything. So that's one of the good things also a clinician can learn from the functional pain. And my final request is, if anybody is interested to start our chest clinic, please give your name. We will send you the ECG machine, the troponin point of care, and we'll give you the advice. So with this, once again, I thank the panelists, Dr. Parandaman, Dr. Lakshmanan, Dr. Namita, and Dr. Tilakavati. So give a big hand for all our specialists, and Sivadacham especially. He has answered all questions. Thank you, Sivadacham. Thank you.
Thank you all the panelists. Now we will move on to the next one. There is a slight change in the program. I think Dr. Lakshmanan wants to leave the hall early, so therefore he has requested to have his ABPM presentation within 10 minutes. That will be followed by the cardiothoracic surgeon and Dr. Muthukumaran's lecture. Over to Dr. Lakshmanan.
I think less than 10 minutes, Shanmugam. Can I have my slide, please? How many of you are doing ABPM in your practice? Aditya, okay. I started in the year 2010, my ABPM. Now almost 16 years I've been doing this. They are there.
After Dr. Muthukumaran's lecture, you will have the Dr. Muruganathan's quiz and workshop by our Sendil Kumaran from Erode.
Yeah, there's slide presentation.
There's no video.
No video.
Okay. No, it will automatically.
Thank you. Yeah, that's the BP in adults, which is the best classification, 2017. And as you could see here, the stage 1 is 130 to 139 and diastolic is 80 to 89. But ABPM, when it comes, the 24 hours ABPM is 130 by 80. In the daytime, it is 135 by 85. And in night time, it is 120 by 70. Very simple machine. I think somebody has brought the machine. You can see it outside. Somebody is wearing it as well as how to use it. If you could see the blood pressure by ABPM, it records the blood pressure minimum 14 times a day. Normally 14 times a day, but we can go up to 36 times a day. See, the daytime blood pressure by ambulatory is 135 by 85. Night, it almost, the systolic dips to 15 millimeters, 120, and the 85 diastolic becomes 70. When you get up in the morning, again goes back to 135 by 85. We call this dipping status, and almost 67% of the CKD patients are non-dippers. 40% of the diabetics have CKD at the time of onset of diabetes. This is one of the normal ABPM of my patient. If you could see here, the blood pressure in the awake period is 120 by 70, and the night time it is 105 by 60. So it dips very well. We might wonder whether this blood pressure reduction in the night is harmful. In fact, it is very much beneficial. You know why the dipping occurs in the night time? There's a decreased sympathetic outflow in the night, decreased stress and stress hormones in the night time, the endocrine circadian rhythm, relaxed muscles and decreased barrel reflex due to the posture, marked reduction in the heart rate and the peripheral resistance and cardiac output, increased natriuresis. All the end organs take a very perfect rest under low stress. This rest is important to prevent the target organ damage. This is the, I call hypertension inferno. Whenever the blood pressure is high, the machine gives it in a... You could see here the blood pressure in the daytime 160 by 108, nighttime 148 by 85, and again goes up. Though it's dipping, still the patient has got a high blood pressure. See, this is actually almost like your stage 3 hypertension in the daytime. Look at this patient. He's not only a non-dipper, he has also got elevated blood pressure in the night time. So he's got a severe hypertension. BP load is almost 100%. And you can see the morning surge of blood pressure. See, this almost 6 o'clock to 7. You can see the blood pressure almost near 190. So by the time the patient early morning surge, they come with the myocardial infarction or a stroke. So you must also see not all the 100% the BP is elevated. Sometimes the PTE, the percent of elevation or BP load more than 50% is predictive. I think all those things we can never find out by the blood pressure by single estimation in your clinic. So most of the patients, if you really put them on, here the patient was admitted with severe vertigo. He was known hypertensive on triple drugs. Look at what is happening when you see the blood pressure. He actually is in hypotension. So sometimes we have to de-escalate the therapy depending on whatever the drugs he has been taking. And variety of pictures we get. The influence from here is stage 3 hypertension, 24 hours hypertension, non-dipper, morning surge. Look at the morning surge here, and the the morning surge is one of the very bad prognostic marker. Here again is a non-dipper, but this is a case of IS surge. You can see the difference between the systolic and the diastolic. The diastolic appears normal, the green bar, and all the systolic blood pressure is very high, very high. As you could see here, the awake period, the BP is 165 by 77, and night time is a non-dipper 161 by 72. They all carry a very adverse prognosis. Sometimes the patients, we feel the home BP is normal, but when they put the patients on ABPM, we get a wonderful result. Nighttime dipping, only we can find it out by, if you could see here, there's a yellow bar here. The initial 2 readings, the machine will not take it up, because sometimes when you tie the machine, we get a weight coat effect also with the machine, weight coat hypertension. So it also rules out the patients, the cause of hypertension is not due to weight coat. So weight coat hypertension, mass hypertension, in all conditions the ABPM helps us. Some of the ABPM records. You can see here the weight coat effect even also here. When you tie the machine, the patient's BP goes up for initial 2 readings, so machine doesn't take it up. So what do you see in this one? We'll finish off with this. What do you see in this ABPM? Yeah, it's a non-dipper. And not only non-dipper, it's a riser. The nighttime blood pressure is more than the daytime blood pressure. See? The 200 is in the night time. So they have got a very bad prognosis. They are the candidates who will go for the stroke, the hemorrhagic strokes and things like that. I think for a short time we'll finish here, and then it's another very important tool in the armamentarium. All diabetics should undergo the ABPM, because most of the diabetics are non-dippers. So sometimes you have to add a drug at bedtime to bring down remember not all 24 hours the patient may be on blood pressure. This is called the percent time elevation, BP load. They have variability of the blood pressure, early morning BP surge, non-dipping status. Depending on that, we can add the drugs, the hypertensive drugs, what drugs they require and things like that. Most of the CKD patients will have a picture like this. Though you add a drug, the BP will never come down. Thank you, Shanmugam. Thank you, Muruganathan, for the opportunity given. Any questions, I'll take it up. 1 or 2 questions from the floor. Use the mic, please.
Sir, CKD patient with nocturnal hypertension, which drugs you prefer, sir?
I am now started using ARNI. I start with 100 milligrams, step it up to 200 milligrams, checking on their potassium levels. I find a very good results with the ARNI group of drugs.
Thank you.
This morning I asked the question whether you use ARNI as an antihypertensive drug. We are getting some reports from Japan also, the patients who got a CKD with a non-dipping status, the role of ARNI in the treatment of hypertension, resistant hypertension, especially when you put them on also on SGLT inhibitors, the dipping status comes down. They become dippers.
Dr. Lakshmanan, you may be familiar with the ARNI, but for the general practitioners, which drug you would like to advise?
At least give them telmisartan, the ARBS. So the potent ARBS, the one drug which can help see now most of the time when you see the non-dipping status, the patient may have obstructive sleep apnea. Rule it out first. Obese fellows, tell them how much time at least put them on the sleep studies and find out how much the hypoxic rate, number 1. Number 2, patients who take secretly NSAIDs, they'll be taking all painkillers at bedtime. They're also non-dippers. So before you dump them that it is only due to the disease, obstructive sleep apnea, obese people who take a lot of alcohol. You take 3-4 rounds of alcohol, check your pulse, the systolic BP will go up like anything. So alcoholics and people who got the shift workers, they're all non-dippers.
What about calcium channel blocker?
Yeah, calcium channel blockers also use it nowadays. The modern CCBs are very, very good. You have to give one single dose, it reduces, but nothing like because renin activity is very high at bedtime, at the night time, especially in diabetics. So give a renin blockade ahead of the CCBs.
Sir, my name is Dr. Parmeshwari Subramaniam. I have used ABPM for my patient, and based on that readings, I have started him on the tablet. But how often should I repeat it again? Maybe 4 months or 6 months, sir?
No, situations, suppose if you think the patient is on good control, this again ABPM is indicated. You give them for 6 weeks. Okay. On the 7th week, again do the ABPM, the response to the treatment.
Then after that, no need to repeat.
There's no need to repeat.
If it is well controlled. No,
yeah, it's well controlled. Once the patient, you show them this, they'll be really taking the medicines. I always take it. Next day, I show it to the patient. Look at your blood pressure. It's all in the red zone. Your BP is not on control. So you should take medication. Because once in a time, suppose they take a blood pressure this time, the BP appears normal. Even high blood pressure will be missed. Most of the time it happens in missed hypertension. When the patient comes to the hospital, they are perfectly normal. When they go to the work zone, the BP rises.
It is not only the BP, you have to monitor the target organ damage also.
Yes, sir.
That
yes,
is
sir.
important.
That we are doing. Thank you, sir.
Positivity, false negative, anything in this machine?
No, nothing. Only thing, success rate depends on the technician who does it. Normally we get about 80 to 90% success rate. 10% sometimes the patient may not appreciate. Some of the uncooperative patients will try to remove it or meddle with that or play with it. So they must tell them when they wear it, when the BP is being checked by the machine, you have to keep it still. And usually put it on the left side because that's the arm which is not functioning. We don't use it on the right hand side. Don't put the monitor on the right hand side.
How to differentiate, sir, false machine reading?
Pardon?
False machine reading, how to differentiate, sir? Due to patient's artifact or due to?
No, artifacts. You can see actually the machine gives you all the 36 times, it will give you the value. Suppose there is no value, then it becomes a blank. I think it comes about 16 papers. Each page will carrying some message.
Thank you, Dr. Lakshmanan.
Yeah.
I think there are no questions, Once again, thank you for
thank you.
View on ABPM.
Thank you, Shanmugam, for the opportunity given.
Yes. Thank you. And now we will move on to the very interesting session, transcatheter pulmonary valve replacement. I think Sengotivel was doing always, the aortic valve. Now he is going to tell us about the pulmonary valve replacement. For that, we got Dr. Muthukumaran, a pediatric cardiologist. He got a lot of credit. I think you want to introduce him? Yes. He is the pediatric cardiologist with 22 years of experience. You should know that now we got limited pediatric cardiologists in our state. Another thing, successfully executed world's first ductal stenting on the smallest baby, 1.2 gram in 2018 itself. He is the only cardiologist who has proctored all valve implantation in the heart without surgery in India. Specialized in treating with the range of pediatric cardiology conditions in the country. Now I will request Dr. Sengotivel also, because both of them are in the same field. He can tell something extra about Dr. Muthukumaran, and also he can go to the topic.
Dr.
Yes.
Muthukumaran is an adult structural interventionalist and a pediatric interventionalist. We work together. He's one of the great things about him, he's now designed his own procedure for a fontan, which is widely accepted as a transcatheter option, and he was asked to present it in the plenary session in American College of Cardiology. So great to have him here.
Thank you, Sangal sir. Thank you, sir, for calling me. And quickly going on topic. Actually, I was listening to Dr. Justin And interestingly, he said that congenital heart disease is becoming more commoner in pregnant women. And that's because, when I started in Apollo in 2008, the real pediatric cardiology surgical program had a effect in Tamil Nadu in 2000 only. So we've been having Tamil Nadu government scheme helping, and so the number of surgeries have went up. Now I would expect our adult congenital population going up. Our ladies will be coming for pregnancies, people will be coming for a follow-up. So if you look at the congenital heart disease incidence in adults, it is 1 in 150 compared to pediatrics by birth 8 per 1000, which is basically, if you look at the congenital heart disease in adults, is more prevalent than what we see in pediatrics. But in particularly in Tamil Nadu, we will be facing lot of adult congenital population walking among us, and are we geared up for that? I don't think we are geared up for that, because we don't have an awareness of adult congenital population. As Dr. Justin said, there will be a lot of things is happening, and we need to really look into those things. So my topic today is on pulmonary valve implantation. If you look at the how do you disable this? This is coming. My mouse is not functioning. Right. So if you look at the commonest heart disease being operated is tetralogy fallow and other RV anomalies. If you see, mostly surgeons, if they have a good pathway, they patch the entire RVOT and close the VST, and that's called a transannular patch. But if they don't have any communication, they put a conduit from RV to PA and you close the VST. This is the most commonest heart surgery being done, and they live into adulthood, and they range, like a lot of people range from 20 to 60 depending on the surgery they had, and they're living in a community. Surgical indications is replacement is often delayed. Most people don't refer a pulmonary valve implantation. They actually wait a longer time. RV fails more than the LV. RV becomes like a paper, and once you replace a pulmonary valve, the RV cannot recover back like a LV. So very important that we need to replace the pulmonary valve at the right time. And what we look for is, we do an annual, every 3 years we do an MRI looking for right ventricular dilatation. If right ventricular dilatation is quite high, then we go for early pulmonary implantation. If the RV dysfunction is there, we have to replace the pulmonary valve. Since they are coping well, we should not leave them longer, because once they go to a stage of RV failure, we cannot, although we replace the valve, we cannot give them a complete cure. So percutaneous pulmonary valve implantation is the first valve to be replaced in the heart in the humans in 2000. Luckily, I was with Dr. Philip Bonhoeffer when we designed this valve in Great Ormond Street, in UK, where they used bovine. You can see the jugular valve stitched onto a stent, and the whole assembly is taken across inside, and then once there's this conduit which is leaking, you can see there's blood coming back, then they put a valve there inside and there is no leak. So this is the first and triggering point for all valve implantation. Then the aortic valve started, mitral valve started, tricuspid valve started, but pulmonary has been the first one, forerunners in inventing pulmonary implantations. So if you have a patient who had a post-op surgical with pulmonary stenosis, we need to look at the echo reports, and if there's severe PS, then we need to replace the valve. We have got, and if there's moderate PS, looking for symptoms and also looking for ECG changes. If there is then we look for suitability of transcatheter pulmonary implantation. If not, then we go for surgery. So if we have most often what we see in tetralogy fallow is pulmonary regurgitation than stenosis. Here what we are monitoring is RV dilatation. If RV dilatation is more than 165 ml per meter square, then we think of replacing it. If they are symptomatic or having ECG changes, Sometimes they have frequent VT because of heart dilatation. So all these things should be taken care before we really embark on follow-ups. So we do follow up all the pulmonary valve, post-op tetralogy follow-up every year, and particularly when they go through pregnancies, they can deteriorate. So we have to make sure that they will be able to go through pregnancy well by replacing valve. How do we contraindications? Coronary compression. The pulmonary valve lies very close to your coronary. When you inflate a valve, the coronary gets compressed. So we have to test that first. If the coronary compression is not there, then we go for valve implantation, or else we favor surgery. So if you have an acute infection, if you have a heart with endocarditis, obviously they have to go for surgery. So if you look at the TPVRs, either surgeon would have done a conduit as a child, or a bioprosthetic valve be put in, or there is no valve but just a patch. So 3 types of TPVRs. So what are the valves available now in India is we have self-expandable options. Harmony valve is now newly into India. We have got approval. We got MyValve, and we have Sapien valve. If you are RVU'd less than 27, we have the Melody valve, which is a Medtronic, or we can also use some Sapiens or the MyValve. So as all everybody, we do a CT scan to look at the landing zone. Once we define the landing zone where exactly we can put the valve in, then we go for the procedure. So once the pre-op is planned, we look at different models. You can look at the different models of RVOTs. Here you can see the conduit, severely calcified conduit, and we need to make sure we put a covered stent, open it up, and put a valve inside. Here you can see unequal calcification, the pulmonary valve. There's a huge calcification is there, so we have to make sure that we don't cause paravalve leak. So looking at the anatomy, then we go for planning of the procedure. I just quickly show a couple of examples, not much. So if you look at here, this patient had severe conduit obstruction. This is your pulmonary artery. You can see here there's a severe calcification, and this patient had a surgery done when the child was around 2 years of age. And so we go through the heart. You can see that's a wire going through your pulmonary artery into your, this is your RVOT into your pulmonary artery. And we open up a balloon. Here you can see that we are checking for coronary artery. So once the coronary artery check is done, we take the stent across. You can see the covered stent is here coming across, and we open the covered stent first to open the entire narrowing. Once the narrowing is open, then we take up the valve. You can see valve coming there. Then we put the valve, open the valve there, and the valve starts to function straight. You can see there is no leak. So that's what the conduits. The bioprosthetic valves can also be, so we assess the bioprosthetic valve and see what type of bioprosthetic valves we have got. Once we know what type of bioprosthetic valves we got, whether we can expand them or we can fracture them, based on that we do implant valves. This is a 20-year-old who had a tetralogy fellow operated with the bioprosthetic valve, and you can see here the surgeons, when they did a surgery, this is a prosthesis, and you can see a huge gap between your prosthesis and your pulmonary artery. So it's got a PR with the bioprosthetic valve. You can see this is your bioprosthetic valve. There's a huge leak happening which was not filled before, and that's the bioprosthetic valve. So what we did here is we serially dilated the valve to a bigger size. You can see this valve has been fractured, and we have increased the size, valve size 24 to 29, and then we implanted a valve. Once the valve was implanted, then we also closed the paravalve leak with the device. You can see the device coming here, which is closed, and that's a final picture showing good functioning valve. There's no leak. So we need to assess it, what the bioprosthetic position, and do. But in our India, what we have is we have a huge population with native PA, which means that you have no valve inside. So what we do is for this particular thing, this is basically our situation. In about 80% of the population have got no valve, and they're living in the community. Quickly telling about history, this is an index patient, 15-year-old presented with breathlessness. She had 2 pregnancies in the past, and she did well and has been at a follow-up. And 2019, she presented with breathlessness, palpitation, and easy fatigability. And the echo, ACG, and MRI was done RV was very huge dilated, and then it wasn't pumping well. The EF is less than 20%. And the severe PR and the time of suggested pulmonary valve replacement, we were refused for surgery because they felt the surgical replacement is high risk. So we did assess her in a combined meeting, and at the time we only had a valve, balloon expanded valve, 29 mm here, and we thought of implanting a balloon self-expanded venous P, which is Chinese valve, and we had a corona outbreak at the time, and so she did the corona, so we didn't get the valve from there, and she's been deteriorating and had a couple of admissions, heart failure. So at the time my valve started with a 32 mm valve, new valve, and so we used that valve. You can see here this is your huge PA, and this is a huge RV, and you can see water blood goes coming back, and that's what he sees here. So she's quite a symptomatic lady with atrial fibrillation, and so we took a valve across, 32 valve, which is there. You can come see there, and we just implanted it across into the native RVOT without any stenting. Once it's done, and you can see there is a good functioning of the valve, and we were discharged home the next day, and AF got better within about with 3 months. She's off all medications. We have done more than 150 valves now in India with the native PA, my valve, and we have good experience. And the important thing is we need to really assess them earlier. If you see a pulmonary valve patient who had atrial fallow, do an MRI, see, look for RV dilatation, and follow them regularly. And particularly if they are going for pregnancy, you make sure they are fit to go for pregnancy, or follow them regularly. Make sure you replace the valve at the right time rather than leaving them like the last lady for last minute. And we do have a 35 mm valve now, which is from my valve, which is sort of a new addition to our system, and a new pulmo valve has come, which is custom made for pulmonary position. So in summary, the least ignored valve is the tricuspid valve. They say, I would say pulmonary valve is also in the category because they don't present symptoms the last minute. So we should not wait for symptoms to come. You need to look for RV dilatation, RV function, and ECG changes. ECG shows a wide QRS complex, and you have a RV dilatation, RV function deterioration. You should need to refer them from early valve implantation. And we can do the valve implantation without surgery, and the cost of the surgery is implantation is coming down, and we can replace up to 34 mm of RVOT without any issues. Thank you for listening. Thank you.
Thank you, Muthu, for that wonderful lecture. So my question is, you are doing the highest number of pulmonary valves in India. So how do you, first of all, aortic valve and pulmonary valve, the major difference is aortic valve has got a lot of calcium. So the valve is anchored to the calcium, whereas pulmonary valve is mostly done in the young patients, even in adult patients, congenital heart disease doesn't have calcium. So you had the concept of, earlier they used to put a stent and implant the valve. So how did you get that idea of doing it without a stent? How did you feel confident that valve will anchor without any calcium?
It's actually it's interesting because I had been working together, me and Dr. Shankar sir, for aortic valve a lot, and we had a pure aortic regurgitation case where there is no calcium, and we actually oversized by 25%, and it stood well. And it gave me an idea that we should do the same thing with PAs. So in PAs, we oversize the annulus 25% so that valve nicely anchors. If you look at a calcified aortic valve, we don't really oversize. Sometimes we undersize the valve to get a valve in position. We don't go more than 10%. But where there is no calcification involved, we do go up to 25%. So with this idea, we have done this, and we are able to achieve that. If you oversize the balloon stretch diameter, we put a balloon and stretch the diameter of PA and add a 25% to that, then the valve gets very effectively stabilized in the PA.
Any questions?
Most important is like you told, land in. How many cases you had any land in mal position? Did you had or any?
You mean embolization?
Yes, sir. Morning.
I just brushed the slides. I had about couple of embolizations, 2 embolizations so far out of my out of the entire series I have done, and that's the initial experience. So what you should need to look at is the landing zone should be far off from your bifurcation, because the proximal part of balloon will be opening inside the PA. If you are quite close to the PA, the whole assembly will come down. So then valve will embolize. So the proximal part of balloon should be able to expand just below the bifurcation. If in case that the landing zone is quite close to bifurcation, then you have to stent from LPA or RPA, form a landing zone in the MPA and do a valve.
Then stent fracture things happens.
Stent fracture we haven't seen it, no. No. Good.
Thank you, sir.
Thank you.
When to redo the valve, sir? The children are growing, no? When,
so after the surgeons, when they do the surgery, they don't replace the valve because it's a growing child. So the RV has got a capacity to, and PR is well tolerated by us initially. But as we grow along, the RV gets more dilated. And what is we seen in all literature is when the RV gets more than 165 ml per meter square, then RV gets in trouble of irreversible damage, having VTs and other issues. So what we do is we do MRI at 10 years of age, and when MRI is having good volume, we repeat the MRI 3 years later. So, and also look at the ECG tracings very frequently. ECG tracing shows a QRS duration more than 160, then we refer for valve implantation.
I think if there are no questions, I think we can conclude. Yes.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Muthukumaran and Dr. Sengotu. Hello. Now, this is an important session, especially the emergency medicine or the critical care. Now, all the big hospitals now got an ER room, emergency room. Therefore, directly whatever complaints in the day or night or whatever place, they go to the emergency room. Then in that now, what is the doctor expected to see the patient, and also what medication, whether it is a medical or a surgical. For all these things will be done properly by our emergency medicine specialist, Dr. Sendil Kumaran and team. You got Dr. Jayaraman, SIMS Hospital, Chennai, Dr. Gautam Kumar, Apollo, Tenambete. Then you got Dr. Aarti, Assistant Professor of Department of Emergency Medicine, SRM. And you got Dr. Sridevi, Professor of Emergency Medicine, SRMC. Now I hand over the mic to Dr. Sendil Kumaran so that he will take you all the specialities of critical care. They have put clinical scenario, narration, breathlessness. Then you got the clinical relevant imaging, X-ray and CT, emergency resuscitative procedure, pictile and needle thorax, ICD, pericardiocentesis, bedside ultrasound for breathlessness, ABG breathlessness. Then ambulatory we have already done. So if the time permit, they will elaborate, otherwise they may shorten that. Over to Dr. Sendil. Yes. Please.
Very good evening to one and all. After a long, exhaustive session, this is a small session and it will be more on practical tip. As the emergency physician, the patient enters into the emergency room without any diagnosis. Most of the time they will say, I am having a difficulty in breathing. So here, this year we have taken a theme that we are going to approach and handle, how we are going to handle a difficulty in breathing patient, okay? Breathlessness patient in the emergency room. It may be various causes, though it is a tip of iceberg with the limited time and the resources, we will try to show, and mostly we are concentrating on preventable deaths. Most of the time, the scenario is the patient comes with the breathlessness, they will be there for half an hour, 1 hour, we are waiting for the consultant. Meanwhile, the patient get collapsed and then patient may be declared as dead and went to a PM, and when we do an autopsy, most of the time these are preventable cases. So here we are going to focus mainly on the preventable cases. For this, I request Dr. Aarti, the Assistant Professor of Emergency Medicine from SRM, to start initiate, followed by Dr. Jairam and Gautam will handle on this hands-on train. Aarti.
So good evening. I'm thankful for this opportunity here. So I have come here. Sir has given a brief introduction of what we are going to deal now. So I am here to tell you what the basic cases what we get in our emergency department. We should save our lives. That is our main intention. So this is a classification of how things would be. A life-threatening emergency, it is only a breathing difficulty. So then how do we treat an urgent cases? What are the urgent cases and what are the non-urgent cases? So my first case.
So this is how we classify in our emergency room. So if anybody has any experience in seeing this kind of cases, a mixture, most of the time this breathlessness will not come alone. So there will be always a overlap of cases will be there. Maybe life-threatening asthma going for a metabolic acidosis or myocarditis following scorpion sting. Like that it will be, overlap will be there. So it is not that just a single clear-cut case will be there. So with this background, now we are going into a case scenarios.
Okay. So I have a 55-year-old male who is a known case of COPD on home BiPAP. So this patient presented to ER with breathlessness. So since 4 hours and it's gradually progressing. So this patient had a history of cough with expectoration for the past 2 days and no fever. So I have the patient vitals. So the heart rate is around 155, the BP is 80/50, saturation is 85% in room air, and respiratory rate is around 45 per minute. He's drowsy and alert to call. His ABG is here. So anybody wants to comment? What would be your treatment?
Respiratory?
Respiratory acidosis. So with this, how would you proceed on with the patient?
The main thing is that why he's having respiratory acidosis, I want to see. And he's having COPD and he's on a home BiPAP. So better would be in this case, I will, as he's a drowsy and alert, first I will intubate the patient and first I will stabilize the airway. After stabilizing the airway, I will connect it to the ventilator and I'll see the settings. And in this time, I will see why the patient had developed this acidosis and I'll go into the general examination and X-ray findings.
Yes, excellent. The main reason we are stopping here is, here we should not search the cause. Okay? This time, the patient is a known COPD on home BiPAP, so he is worsening. So here we should not search why the patient is worsening. Here we need to stabilize the patient, then we move on to finding the cause. Clear?
Okay. So as you said, the patient is crashing and we need to treat the patient and rather than to treat the numbers. So this would be a basic treatment management of the asthma or COPD. Then suppose we get the X-ray like this. So what do? So we did most of our management and we take an X-ray and the X-ray is this. So what do? What do? We got an X-ray.
What is this X-ray?
It is a typical pneumothorax where I will do the ICD insertion immediately and I will set it. And
how you are saying it is a pneumothorax?
Lung findings are not seen in the right side.
Huh?
Yes.
Is it a pneumothorax or a bulla?
Bulla also could be the finding, sir. But first I will do the physical examination and then see.
So now you want to put an ICD or we have to wait?
We have to wait, sir.
You have to wait. Okay.
So it is better we wait for this patient because it is looking like a large bulle. So we get misdiagnosed by looking at this kind of an X-ray in the ER. So what we tend to do, we immediately tend to do an ICD. So we rush for the ICD, so which is not there, it is a large bullae. We can wait, keep the PEEP low, try to do nebulizations and wait for the patient to improve. So we have this X-ray, so what do? If suppose the patient is having this X-ray. So this is very typically showing a very large bullae, multiple bullae are there. So this one was a very single large bullae, but this one has multiple bullae.
So this is most time we get a caveat. Okay, when a patient is known COPD, deteriorating, high PCO2, becoming drowsy, and your chest X-ray shows this, immediately our tendency to put a ICD. What is the wrong in putting an ICD here? Is it going to cause any harm? Yes? Yes. By puncturing this bulla, again, it is going to increase the pneumothorax chances. So, especially if the patient is put on a positive pressure ventilation. So, bulla we don't do a ICD, we want to do a CT and evaluate, and after the stabilization we do a CT, then we can evaluate for going for a bullectomy. Surgery can be done if mandatory. Okay? Most of the time these kind of bullas we see, multiple bullas will be there, and we come to know this is a bulla, this is not a pneumothorax. When we see a single large bulla, we should not go more anxious to put a ICD. That is a message from this. Next.
Okay, this one, if the X-ray is this. So if the patient has this X-ray, so what would be our treatment?
I think Aditya, you can continue. See, it's only for the experience of the other people. Also.
This is just an interaction.
No?
Somebody has to interact, otherwise it will be a monotonous.
Okay, so this is looking like a tension pneumothorax. So by pushing the mediastinum to the opposite side, so this for this X-ray, definitely we have to go for the ICD. So that would be the treatment.
This is the worst X-ray that physician should not see. Okay, and pneumothorax can be seen, but not tension pneumothorax. Because tension pneumothorax is a clinical diagnosis and not a radiological diagnosis. This kind of X-ray should not be taken. Okay, before that itself, we have to put an ICD. So you need to know the beauty of clinical medicine by just examining the patient, auscultating, looking for the center of the trachea. If it is shifting out, then we have to put an ICD, then we have to take a X-ray.
Our practice says taking an X-ray in a tension pneumothorax is a crime. Okay, so this CT shows multiple bullae and this shows a pneumothorax. Okay, so next. So we have already dealt with the X-rays, ABGs, and now we are going with the little bit more from auscultation to ultrasonation. So we have evolved a lot. So just by looking into we don't even need an X-ray to find out a pneumothorax. Just by the bedside ultrasound, we can find whether the patient has got a pneumothorax or not. So usually when the probe is, this is how we place a linear probe in the mid-axillary line or in the mid-clavicular line. In that we can see this is a normal sliding. So if the patient is not, the pleura moves, and if the pleura is not moving, then we call it as an absent sliding. So that indicates pneumothorax. Okay. So lung sliding has been absent. So we call, when a pneumothorax is there, we call it as a stratosphere sign or a barcode sign. And lung pulsation has also been absent, and B lines are absent, which is very characteristic of a pulmonary edema. So A lines would be present, and there would be a lung point from where pneumothorax is not there to a point where pneumothorax is there. So even if there is one B line, we exclude pneumothorax.
If you closely observe this looks like a seashore sign. Okay, it is just like a seashore. So if you see a seashore, it indicates that the patient is having a pneumothorax. Okay.
Okay, we'll go to the next case. We have a 25-year-old male with chest pain and breathing difficulty for the past 3 days. So no fever, no cough, and no trauma. Okay, so his heart rate is 108, his BP is 100/60, saturation is 96% in room air, and respiratory rate is 25. So the ABG is this. So we don't have anything much except for a type 1 respiratory failure. Okay, so this boy has been repeatedly coming to a ED multiple times with history of chest pain. So every time he comes to chest pain, he had been given pantoprazole and has been discharged. So this was his X-ray. This was a real patient. So what do we do for this? ICD? Needle thoracocentesis? So what do we do? So this is also a pneumothorax. Okay, so this is also a pneumothorax which is more than 2 centimeters, and the boy is absolutely fine. He has not got any drop in the saturation. He is neither gone into a tension pneumothorax. So what could be this? So the treatment would be placing an ICD, yes, but we need to evaluate the cause why he had developed a pneumothorax. Okay, so this boy was a recurrent cocaine abuser. So that's why he developed a pneumothorax, spontaneous pneumothorax by substance abuse.
So what is this called? Recurrent pneumothorax by cocaine abusers. Why cocaine abusers going for recurrent thing? Any idea, any clues? Most of the time, the drug abusers will use all your peripheral lines. They will get thrombosed. So they will not able to get a vein. So they will try to get a internal jugular or external jugular, they will try. So by the time they will get a iatrogenic pneumothorax. This is very, very common. One with the drug abuser. If you see multiple needle marks with the thrombus thing coming with the breathlessness, immediately you can auscultate. This gives a clue that they may have a pneumothorax. Okay. The second thing is the puffing. So they used to take a puff in a closed thing, and they will take a vigorous puff. So if they are having any bulle or any other thing, they will get for a rupture and go for a pneumothorax.
In your case, how many cases you had in cocaine and pneumothorax?
Sir, now we are seeing large, sir. Almost 15-20 patients now we are seeing.
So this would tell you a ultrasound feature, which this side shows you a normal lung where it is looking like a waves on the beach. So this would be a normal sign. In a pneumothorax, you could see a barcode sign, so which is also called as your stratosphere sign. This is how it looks in case of a pneumothorax. Okay. So even before your X-ray, the ultrasound picks up a pneumothorax. It has got almost more than 90% sensitivity. Okay, so for this gentleman who comes to the ER with breathlessness, so what do we do?
This is X-ray. Does it give any clue?
Can we discharge the patient? Is he fine?
Hemodynamically stable, saturation is maintaining. Only complaint is a little chest discomfort and breathlessness.
Though the X-ray appears to be absolutely normal, the end, if you look, which is called as a deep sulcus sign.
Deep sulcus sign. Pointer.
So this we call as a deep sulcus sign, which is an indication of pneumothorax. So even this patient needs to be admitted and observed. So these are the subtle signs of pneumothorax in the X-ray.
If you fail to recognize the deep sulcus sign, it is a negligence. So any deep sulcus sign, you have to admit the patient, and you can repeat the X-ray, or if you have a facility, we can go directly for the CT. This is an occult pneumothorax. This can be easily picked up by the deep sulcus sign. Its sensitivity is almost 95%.
So this is an algorithm telling you when to intervene for a pneumothorax. So this is a 5-year-old child who was referred to us from an outside hospital with a breathing difficulty. So what do? I put a ICD for a 5-year-old child. The mother brought the child with breathing difficulty. So we didn't do anything. We just placed a Riles tube. So this is just an eventration of the abdomen, so which is looking like a pneumothorax, but for this we need not put an ICD or do any kind of intervention. Just by placing a NG tube, this abdomen gets resolved. Okay, so these are the things which we need to look into so that we do not miss the simple diagnosis. Okay, just by putting a Ryle's tube, this can be treated.
Can you tell now what is the significant
Yes,
findings to say
yes,
that this is eventilation, not
yes,
a
sir.
pneumothorax?
So this is the lung, and this is actually the gas shadow of the stomach. Okay, so raising this, and you could hear the gurgling sound here. So clinical diagnosis, clinical examination also plays a very important role in this kind of an X-rays. So in a young child, it is very rare possibility that they get a pneumothorax. So you need to auscultate them properly, and you can use the help of your ultrasound to find out all these things. So this, just by placing a Ryle's tube, the child became normal, the child didn't have any breathing difficulty.
This is actually a case of a diaphragmatic hernia. Here the content get herniated to the thorax cavity. Actually, this is a child was playing, jumping. After that, they developed breathlessness. So others, the X-ray was taken outside. The primary pediatrician thought it is a pneumothorax and referred to us for putting an ICD. Just if you pass an Ryle's tube, the Ryle's tube you can see it in the thoracic cavity because the entire stomach content is stomach with the intestine has been pushed inside. So this is very, very common in the neonates. After delivery, they used to see this kind of patients. In the 5-year child, it is aggravated by jumping from a height. Okay, here we should not put an ICD. Most of the time, if you put an ICD, this will put a perforation, and you can even see the food particle coming through it, through the ICD tube. We have seen many times the patients, even in adult patient going for a diaphragmatic hernia, ICD was done, and all the food particles will be coming through the ICD tube. So you need to be careful. So before putting this kind of ICD, you just pass an Ryle's tube and look for it. If the Ryle's tube will be lying down in the thoracic cavity, it clearly gives a clue that the patient is having a diaphragmatic hernia. Ma'am? Ma'am, it is not a recurrent condition. It may be a congenital defect in the diaphragm, or it may be a traumatic. So it has to be repaired.
So how to, when we have a doubt, so how do we deal with it? It's a simple trans-illumination test. So we can just place the light and then see. If it is not a pneumothorax, so it will be like this. If the child is having a pneumothorax, it will be like this. Okay. So by doing this test, simple bedside test, we can rule out a pneumothorax, and then we can do a Ryle's tube placement or an ICD. Okay. So next case, I would like to hand over to Dr. Jayaraman, sir.
Thank you, madam. Yes.
Hello, good evening, Dr. Jayaraman. Thank you for the opportunity. So this is a 67-year-old male, underwent a recent PTCA to LAD, presented to ER with chest pain and breathing difficulty for past few hours, almost 8 hours. Is extremely diaphoretic, cold and clammy. So this is his vitals. His heart rate is around 170 per minute. BP is not recordable. SpO2 will not be detectable because BP is not recordable. If there is no peripheral circulation, SpO2 is not reliable, even if you see a number on the monitor. Respiratory rate is around 40 per minute, and this is his blood gas. So what are the differential diagnoses? Patient is in hypotension, severe tachycardia, and his lactate, if you see in the ABG, is 12. That denotes there is anaerobic metabolism because of his hypotension. So peripheries are not having circulation. So can it be a MI, cardiogenic shock? So what tool will help us in getting a diagnosis on the bedside? Can I see some hands going up? I'll say 1 or 2 bedside tools. Blood investigations, how many hands going up? X-ray chest. So nobody will ask for a blood or X-ray in the first end. So you have an ultrasound machine or an echo machine. You just put the probe on this patient. And this is the finding. So what is your diagnosis now?
Pericardial efficiency.
Yes. So this is acute because this patient has recently started on having symptoms and you see effusion. So what is this patient's condition called? Pericardial effusion with patient in hypotension. So cardiac tamponade. So next step will be pericardiocentesis for this patient. This is a life-saving procedure. Just a simple ultrasound on this patient's chest will get you the diagnosis in this patient. So that's why we stress on POCUS, bedside ultrasound for all our sick patients, either to diagnose a pneumothorax or to diagnose a cardiac tamponade or any other diagnosis. So bedside echo or ultrasound is very useful in these patients. So 77-year-old male coming with breathing difficulty since early morning. He is not able to sleep, and he has a lot of comorbids like diabetic, hypertensive and coronary artery disease, and he is on regularly taking all medications for these diseases. So just to make the diagnosis easy, he has fever and cough.
Is pre-treatment and post-treatment are different?
Yes. So this one is pre-treatment, this is post-treatment. So if you could see, can we diagnose him as pulmonary edema? Pulmonary edema is usually bilaterally, you will have the shadows. Here more on the right side than in the left side. So if the patient has some fever, cough, so it goes in favor of pneumonia. So you treat for pneumonia, like basic ABCs. If the patient is maintaining saturation, just support him with nasal prongs or low flow oxygens. If he's quite dyspneic or his PCO2 is building up, put him on NIV. What are the indications in this patient for intubation? It would be if this patient is very drowsy, his GCS comes below 8, or he is not able to maintain his saturation in spite of NIV, or his PCO2 keeps building up in spite of NIV, then this patient is indicated to be intubated and put on ventilation. So after you treat this patient with oxygen, antibiotics, now a lot of viral infection is there. So it is not only bacterial, it is also viral. Keep in mind for all the viral infections also. So advise all the young people and elderly people for early flu vaccines. Early flu vaccine with quadrivalent flu vaccines.
This is, you told pneumonia, but can we tell no this is ARDS or you have to differentiate some special?
So ARDS, usually it is bilaterally, infiltrates are bilateral, and ARDS is not diagnosed only with X-ray. We have other criteria, Berlin criteria, which includes PaO2 by FiO2 ratios, X-rays, and other parameters to diagnose for ARDS. The first case, we'll go to the first case. First case. So again, go to first case. Just we'll just go up. Just keep moving. Somebody is okay. So again, this patient, this is a 50-year-old COPD on home BiPAP presented to ER. This is already discussed, but a few points in this also. So he is breathless for past 4 hours, gradually progressing. He has cough with expectoration for past 2 days and no fever. This is vital signs. So you have seen the, Dr. Aarti has shown the echo, imagining you have seen the echo and the lung findings in this patient. You diagnose this patient as pneumothorax. So what would be a treatment approach? Just you continue on NIV or you put this patient on ventilation after intubation. So I heard one doctor saying intubation for this patient. So this patient, if there is X-ray is normal, I would not intubate this patient, because if you would see here, this patient was drowsy, but he is alert to call. His GCS, if it is more than 12 or 15, so we can try with NIV with increased pressure support or something before going ahead and putting these patients on intubation. Because COPD patients, if you see the ABG here, so you will know with this ABG bicarb of 40 is a chronic patient. This is chronic compensation. So once you intubate these kind of patients, it's very difficult to extubate these patients. So always have a lower threshold in these kinds of patients. Always in doubt, go for intubation, but keep your threshold a little bit low for intubations in these patients. Try to manage with other NIVs and other medications, and if they are not improving, then you can go ahead with intubation. But if the same patient has a pneumothorax, NIV, then definitely this patient needs to be intubated. Just I wanted to add this point in this patient. So Aarti will continue that.
So this one with the both the chest X-rays. One, as sir has asked, could either be a pneumonia overlap with a pulmonary edema, both. So if required, we can ventilate the patient and then start on NTG, Lasix, so your regular usual management. So the features which suggest a pulmonary edema could be bilateral pleural effusion, fluid in the fissure, and your cephalization, all your upper lobe diversions. So these all can indicate a bat wing sign, which is very commonly seen in a pulmonary edema. So these are the findings in a chest X-ray which can denote a pulmonary edema. So you can have a pulmonary vascular congestion with cephalization, which is upper lobe diversion of the vessels, and then peribronchial cuffings, and increased interstitial markings and curly B lines. So this can also be picked up by your ultrasound machine. So even before taking an X-ray, so even your ultrasound machine can pick up your B lines, which can clearly indicate us whether we are dealing with a pneumonia or a pulmonary edema. So this line, which I already showed you for pneumothorax, this would be shimmering and it would be moving. The number of wetness, can you see the longitudinal lines which are here? So this indicates the wetness in the lungs, and as it is increasing, the pulmonary edema is worst. So there is no breach in this line. So if there is a breach in the line and the horizontal lines are running down, then it could indicate as a consolidation. Okay, so those are your Z lines and these are your B lines. So starting from the starting of this slide, from here till the end it is going. So this is fully there. So which is a overt pulmonary edema. So these only 2 lines are there, which is fine. More than 3 lines indicates a pulmonary edema. As the more wetness is there, the more the thing is. Before doing an X-ray, before doing an NT-probe BNP, before doing an ultrasound, before doing an echo, you can just, by putting your probe, you can find the pulmonary edema.
So this is called as acoustic shadows. So if you see the acoustic shadows, it indicates that there is a wet lung. Okay. So you can, the patient with how to differentiate in a pneumonia, we will not see these kind of B lines. Even if the pneumonia with overlapping cardiac failure can be there, the patient would be having a borderline cardiac function. Because of this pneumonia or sepsis, patient can be decompensated and deteriorating. So at the time the patient can get accumulation of this fluid. So how to differentiate? We can use a pro-BNP. So pro-BNP in patient with pneumonia or sepsis, it will not be increasing, whereas in a cardiac failure, it will be increasing. Moreover, the patients, we can just by doing an echo, we can able to tell. But there is certain caveats is there. The important thing is, even the sepsis can cause a myocardial depression, mimics like a acute cardiac failure. So you should be careful in that. And sometime the patient can have a normal EF, but the patient would have been having a cardiac failure. So pro-BNP is the biomarker here, will help you to save this patient. Okay.
So next case, we have a 50-year-old female with fever for 5 days, cough with expectoration for 3 days, and breathing difficulty since morning, presented to ER. So she's a known diabetic on regular medications. Her vitals, BP is 90/50, saturation is 85% in room air, and respiratory rate is 35 per minute. So this is her X-ray. So clearly we can look into a patch. Okay. Okay.
So what is that X-ray? Can you tell that? Sir? Illa sir, this X-ray, sir. Just give some wild guess. I'll just give a clue. The patient's total count is normal.
So we have this.
Most of the time when we see this kind of picture, we immediately come to a conclusion that this is a lower lobe pneumonia. Okay. Next.
So we do have also a pulmonary embolism presenting to us with an infarcted lung. Okay, so even that can be there. So your differentials will never end just by looking at your X-rays. You need still more investigations in the bedside to prove that it is not an consolidation, it is not an embolism.
It looks like a wedge infarct, Western mark sign that's commonly seen in the X-ray. Very common in pulmonary embolism.
So other features which can clearly indicate a pneumonia could be a unilateral haziness, so which can blur your heart border, and some, in case of an atypical pneumonia also, bilateral hilar adenopathy will be enlarged. So a pleural effusion masking with a meniscus sign can also indicate a consolidation here, and a very clear cavity here can indicate a bacterial pneumonia or a tuberculosis. So a fluid-filled lung abscess and a mass in case of a Q fever or tularemia, which is very less common here. Would see a pneumococcal mass. So staphylococcus can cause a round shape. You can see it mimics a bullae, but it's a staphylococcal infection. So in the ultrasound, so how do we differentiate between the consolidation and your pulmonary embolism? So if you put the probe, as before I said, we are using a linear probe for a pneumothorax, but for a consolidation, we would be using a curvilinear probe at the right costophrenic region to look at this is your lung base and your liver. So here you could see the consolidated lung with air bronchogram. This is your air bronchogram, which can clearly tell you it is a consolidated lung. So we call this as a shred sign. Okay, so this indicates your air bronchogram. So this would have if it is a normal lung, it would have an equal echo texture as your liver. But in case of a consolidation, it is hyperechoic along with a air bronchogram.
Moreover, you will have a sympneumonia effusion will be there.
So the effusion is the black one.
Pardon? Fever. Fever was 100 degree.
Okay. So this we call as a shred sign. So we know the curve 65 score.
Sir, only one doubt, sir.
Yeah.
Here, sir. Regarding that case, sir, this case had consolidation. So when it presents, can we institute that 1 hour bundle, because the patient is having fever and patient is a 50-year-old female. Cough with expectoration is there. So when we diagnose it as sepsis, do we, before initiating the biotics, can we send from ER itself the blood culture, all that 1 hour bundle?
Yes, 1 hour protocol.
Bundle.
It's called as early goal directed therapy, EGDT. Okay. For EGDT, if you want to start EGDT, it has to be done in the emergency room, but you should not delay in giving a antibiotic. So immediately you take a blood sample in a 2 different thing. First you resuscitate. Meanwhile, it should be hands in hand.
Team.
Culture has to be taken, and a broad spectrum antibiotic based on your hospital antibiogram. You have to start the antibiotic. Okay. And before that, we want to know whether it is on the
Cardiobase
65. So this will tell you to categorize the patient, whether the patient is really sick, need an ICU admission, or can be manageable in the room side. So with this scoring system, this will definitely help you out, whether definitely the patient needs an ICU or can be shifted to a ward and we can treat the patient. So without assessing this, directly if you admit the patient in a ward side, if the CRUB 65 score is very high, then you may get a code blue in your hospital, so that you have to rush and resuscitate, and their mortality is very, very high. So to prevent that, we can assess this in the emergency room. This should be like a collaborative thing, not just seeing an X-ray, not seeing a blood pressure, just with the history. It should be collaborated with all, then we can come to a definite diagnosis.
So this is a 40-year-old male presented to ER with syncopal attacks and breathing difficulty since morning for the past 4 hours. He had a recent history of trauma with femur fracture, for which he had a recent admission. So this itself will put to you a diagnosis. So the heart rate is 145, BP is 80/50, and saturation is 90%, and respiratory rate is 38 per minute. So the ABG is showing.
So does this ABG gives any clue? Does this gives any clue? So important thing when the patient is sick coming to the emergency room, apart from seeing your pH, PCO2, PaO2, look for the lactate. If lactate is more than 2, it indicates that the patient is really in a problem, either with the hypoxia or hypoperfusion. Okay, so we have to intervene this patient and try to settle it as early as possible. Otherwise, increasing in the lactate itself will be telling you that the patient is deteriorating, and most of the time the battle will be lost. Okay.
Yeah. Good evening, one and all. I am Dr. Gautam from Apollo Tenampet Intensivist. Just from the history, what will be the first investigation you will be asking for the patient? Sorry, sir? Yeah, patient is hemodynamically unstable.
Patient is
in spite of triple
hemodynamically
inotropes, still he is hemodynamically unstable. You couldn't shift him. Yeah, okay. Echo will be the first one. Yeah. In spite of the completion sake, I'll just put up ECG. Yeah. Okay. This is ABG. Patient has shock. Definitely his lactate will be elevated. Not surprised about it. This is ECG. Is anything convincing to it?
S3, Q3, T3.
What will be the first or like predominant sign in pulmonary embolism?
S3,
ECG.
Q3.
Yeah, exactly. There is definitely not S1, Q3, T3. Okay?
S1, Q3, T3, if you analyze, in our hospital almost 150 cases we analyzed, and only 10 cases satisfies this criteria. Other remaining 100 cases had a sinus tachycardia irresponsible to the other vital parameters.
Other than that, right bundle branch block, that is also an indicator that RV overload, probably something is happening there.
So we did a X-ray as atelectasis, pleural effusion, Western mark signs, Apton signs are the signs in the X-ray. Patient hemodynamically stable, we shift the patient to CTPE to roll out PE. If he is hemodynamically unstable, do echo, then you decide whether to thrombolize the patient or not.
So this is a cut-off sign. So the major vessels have been cut off, occluding the thrombus. So here the emboli is been cutting off the major vascular flow. So the patient's repeated complaint may be syncope. Just syncope will tell you that the patient is with syncope with tachycardia. The first diagnosis in emergency room, we should think of pulmonary embolism.
Appreciate PE. There is a filling defect in the left thing. Yeah. So echo will have RARV dilatation. Patient will definitely will end up you in shock. Patient will have the features of RV strain. Wells criteria whether to rule in or rule out, you can assess Wells criteria along with D-dimer. If Wells score is less than 4 and patient has negative D-dimer, we can rule out PE. Definitely there is no PE, it has more than 90% sensitivity. And there is also other score called Perk's rule. If everything is patient is checking into it, then you can rule out PE. This is not to rule in. The only investigation to diagnosis is CT pulmonary angiogram. All others for the only the ruling out thing. Okay. This patient had a cardiac arrest, suspicion of PE, you have to thrombolize the patient. If patient is having massive PE with hemodynamic instability, you can thrombolize the patient. If patient is having symptomatic bradycardia secondary to PE, you can thrombolize the patient. There comes the big debate. What can be done for the submassive PE? How many people will thrombolize for submassive PE? X-ray done, there is a massive effusion.
So what is this? What is this X-ray? We have a patient with the history, and this is the X-ray. So what do we tend to do? The saturation is low, the heart rate is high. We tend to immediately take the ICD, place the ICD immediately, and collapse the patient. But no.
Why we should not put ICD? Massive pleural effusion. No? It's one of the indication. Out of 6 indications, massive pleural effusion is an indication where we need to go for a decompressed thoracic cavity.
Yes, exactly. There is no tracheal pull to the opposite side. It's pushed to the same side, which means the patient has got some endobronchial mass. It is a collapse of the lung, pleural effusion. So even your X-ray can misdiagnose you. For that only we are insisting upon usage of ultrasound in the ER to rule out the major diagnosis and to find the clinching diagnosis and treat the patient effectively. So we are...
What we used to do in our GH time is we used to do the pleural tap under the thing, and then we used to percuss and we used to see if any underlying mass is there. Like you told, never we go for ICD in this case.
So we have received the patient from hospital, where for this they would have put an ICD, nothing has come but the patient collapsed and came in a very sick condition.
It's very difficult to find out the mass from this X-ray. You may need a CT also, then you'll be able to appreciate it.
So if there is a massive pleural effusion, can we aspirate the entire lot? I had a better experience once. He had a huge, he was dyspneic and he was really sick. And I aspirated 2 liters of fluid. That night he collapsed. What could have been the reason, sir? I thought I had given him a good relief, but midnight I had a call that he had an arrest.
Sir, 2 things would have happened, sir. One, by doing a massive tapping, we would have injured and the patient would have developed pneumothorax. We are commonly seeing that, one. If not that, when we are doing a massive aspiration, the fluid shift will be there. So sudden collapse in the intravascular volume will cause the patient for a cardiac arrest.
So always when you aspirate... So is there any guideline how much to aspirate, not beyond a particular level?
Not more than 500 at a time, sir. You clamp it, then release another 300 or 500 ml. Because this phenomenon is called as re-expansion pulmonary edema. These patients go in for frank pulmonary edema because of the pressure changes in the vasculature. So it is very difficult to, you have to immediately intubate these kind of patients.
How many hours you will clamp and release?
No, it is just 10 or 15 minutes. Just clamp and release, just 250 to 500 ml. Not.
No, I didn't put an ICD at all. I just aspirated mechanically.
Sir, whatever it is, just if you have put a IV tube, just close it, and after some time you can release it.
And so moreover, any one time I should not aspirate more than 500 ml. That's the point.
Yes,
okay.
Sir.
Thank you, sir.
And moreover, it should be done under the cover of albumin infusions because of oncotic pressure variation. So that will be prevented by putting a patient on albumin infusion.
One point which in GH my sir used to say is, whenever we are doing this pleural tap or anything, if the patient coughs, means that will be the first sign that the patient is going for this re-expansion.
To stop it immediately.
Better to stop.
Yes.
Actually, that indicates 2 things. One, we are touching the pleura, so that there is a chance of injuring going for pneumothorax. That is one.
Yes.
Second thing is, if the patient coughs in spite of that, the patient is going for re-expansion pulmonary edema. So that should be can be prevented by either your diuretics or with albumin infusion.
Yes, sir.
Now, how many times you have used albumin infusion in your clinical practice?
Sir, routinely we use, sir. When we are doing a massive tap, more than 1000 ml, we put them on albumin cover.
How many ml?
500 ml we'll wait and put the patient on infusion of 50 to 100 ml of albumin. Then we'll go with this. 20% human albumin. Sir.
This is the same patient's ultrasound, which shows there is a pleural effusion with floating lung. This called, it's an M mode. you can appreciate a sinusoid sign. The black color thing, it's effusion. Okay, so you can tap, you can do the diagnostic tap, you can evaluate it, then you can decide whether to put a ICD or not.
Thank you.
I think all of you give a big clap. You know, I have learned many things. I think you should have also learned many things. Every year they will come and definitely will improve our knowledge. Thank you, Dr. Sendil and your team.